morning, everyone. Relax, because we're just going to start in at 1:15 because some of the buses were running late with the luggage today. So it's lovely to see everybody, but just chat and relax for a couple of minutes and we'll start at 1:15. But we're going to start the main session on time because we'll just shorten. It's just a short session on the WHO announcement. But we'll start at 1:15, so relax and enjoy, but don't run away. So we'll see you in a minute. Right. Good morning, everyone. If everybody could have a seat, we're going to get started with this special session before the main session this morning. So come and get a seat, and lovely to see everybody here. Good morning, everyone. Well, thanks for those who've come in extra early. I hope you still got your cup of coffee and a pastry. We were up all night icing those donuts this morning, so I hope you still got to have those. We just wanted to have a few minutes before the main session today, because we've got some really exciting news that we have talked about already at this conference, but we just wanted to take a moment to formally announce the transition that the Global Health Network has had to become a WHO collaborating centre. And so we wanted to explain that to the Global Health Network community, that everybody is, and also that we've got one very particular project within that we wanted to explain and invite you all to get involved with. And so I'm going to hand over to John Reeder to explain the WHO's decision on making us a collaborating centre, and then Sam and I will take you through the plans we have for the research framework. So thank you very much.
Thanks, Trudy, and good morning, everybody. And first, congratulations to the network on being made a WHO collaborating centre. It's not an easy process. There's an awful lot of paperwork as you might expect from a bureaucracy like this. And in fact, now WHO is trying to really hone down on just the centres that it collaborates with in a really substantive fashion. So it's becoming harder and harder to become a collaborating centre. But the background of this is I think many of you would have been here yesterday and realized that one of my jobs is director of TDR. And we've been working with the Global Health Network for quite some time, particularly around creating a community of practice for our clinical research and development fellows. And I suspect there are a couple of those fellows actually in the audience. I bumped into a few of them around. So we have quite a long history from the start of keeping an eye on this. But then there was quite a change. About 3 years ago, the Director General decided to establish a science division for the first time at WHO. And the idea here, of course, always science and evidence has backed up WHO decisions, but was to really bring it front and center and trying to make it a coordinated attack across the organization. And as part of that division, they decided to set up a Department of Research for Health to try and coordinate and harmonize the WHO research approach. And the DG asked me to take that on as a second job and kind of set up this center. And as I was thinking about how we did this, obviously on one level, we're looking across the research spectrum within the organization, but coming from a background of being a researcher and working, I was director of the Papua New Guinea Institute of Medical Research for many years. Working on the other side of this, I was very keen that we started to involve the wider scientific community. And so WHO didn't sit on this hill of science kind of looking down, telling people what to do, but actually got down and became part of the community. So it was a great opportunity to engage a little further. And we did this with two things. The first was one of my responsibilities is looking after health ethics for WHO. And we have many brilliant collaborating centers and centers that collaborate with us. And we really wanted to support knowledge exchange between them. And this is already something we engage with. But then really the exciting concept that you're going to hear about today was really trying to, as the title of the conference says, to make research possible in every healthcare setting. And one of the obstacles to this is that investigators are trying to set up studies and they look up the ICH GCP kind of regulations, which are made for big scale pharma randomly controlled trials. And they just think, this is too much. How can I ever cope with all of the bits and pieces around this to make a protocol? But the truth is, you don't need to be. What you need to do is look at your context and get the appropriate guidance to get a protocol that's safe, it's effective, it's ethical, and works for the investigators. So we wanted to help researchers navigate all these many pieces of guidance and to be able to put together protocols that really serve their own needs, but are still excellent science and to excellent standards of doing this. And this is where we started to really engage in this tool. An analogy that I had early on is, at the moment, it's like you go into a library and you say, I'd like a book on clinical trials. And the librarian just says, it's a library, we have plenty of books. If you look up and down every row, eventually you'll find it. And what we want to do is for that librarian to take the person by the hand and say, what you need is in this section, look here and you'll find everything you need. And I think you'll hear that we've made considerable progress to that. So I'll hand over to Trudy and Sam, but again, my congratulations, and we really look forward to working with the Global Health Network in this more formal capacity with WHO. Thanks, Trudy.
Thanks, John. So it's official now. The Global Health Network, all of us as the Global Health Network community are a WHO collaborating centre. So that's really exciting. So I'm delighted we've had the opportunity to mark it. So the most important thing is to really get down to business and what that means. And what I'm really excited about is, if we think back to the talks we heard yesterday, and you're going to hear again today, lots of different groups are setting out to do research. And a lot of this meeting is about how people find particular areas of conducting research difficult and they don't know where to get help. And we'll talk about this more later this morning. So what we've been trying to do with the science division, as you heard, is to try and find a solution to that. And so what we want to do is to, as John so eloquently put, to help search through the library. So if you're a researcher working without a big program around you and you want to set up a high quality study, how do you do that in a way where you can navigate all of the myriad of information that's out there and cut down to what you need for your study to make it safe, ethical and accurate? And ICH GCP is completely valid for a randomized controlled trial for a regulatory product. And it's all based on the Declaration of Helsinki, which says you need a good study, it needs to be safe, accurate and ethical. But it's just almost impossible, unless you're vastly experienced, to work through the whole of these guidelines to say, what do I need to do for my study in this setting, in this context, to ask the right question and make sure it's accurate, safe and ethical. And so we've come up with this plan that we've been working on for a while. And all we want to do this morning is invite any of you, all of you, to help us refine this. The expertise in this conference is vast, and also the range of experience and the range of studies you work on is an amazing opportunity. And so we're trying to build a framework which will work as an online app, which Sam's going to explain in a moment. And it will simply be like having an expert standing at your shoulder to say, okay, are you doing research? It's not an audit, you're doing research. You're going to either be taking a sample, giving an intervention, doing maybe a questionnaire or an interview, or you might be using identifiable data. And the really exciting thing is that research is moving really fast. It's evolving very quickly. I've talked to lots of people about this week, and we've heard from presentations, and we'll hear later today. And we're moving away from having sort of phase 1, 2, 3 and 4 and the old norms of clinical trials. And there's so much opportunity, even with looking at real world data or taking data from observational studies and looking at it in a different way. So we also need agile frameworks to help still make sure that any type of health research is safe, ethical and accurate. So this framework we want to develop should work for any type of study. And so that could be an observational study, it could be a clinical trial, it could be a social science study. You know, we heard so much about community engagement yesterday. It's so vital to do those perception and human behavior studies too. And so this piece of resource that is going to be developed as an app will ask this series of questions and it will at the end come out with a solution for your own study that says, to make sure it's safe, accurate and ethical, these are the things and steps that you need to do. And so I'm going to pass to Sam, who's going to just take you through very briefly how we'll do this. And then he's going to challenge all of you to see if you want to get involved. So thank you very much. And over to you, Sam.
Hi, everybody. So yes, as Trudy's been saying, we've been working on this framework, and our first challenge was trying to work out how exactly to embark on this undertaking. So what we've done, obviously being part of the Global Health Network, is we've gathered together some of our community to create a core team who is helping of experts of different research studies to help us build the core content of the app. And this core team is then creating some content that was then reviewed by a wider working group that is also from the Global Health Network community, and they review what we've done. So we've created, the core team creates questions and answers based on a particular case study, of all different types of studies. And the review team reviews that, sends us back the feedback, and contextualizes it for us, so we can start creating the right questions, the answers that they would expect people to choose, which then take them through a pathway, and this gradually builds up a picture of the study that they want to do and the guidance that is relevant to their study. So there's the core team and the review team, and as after the review team, what we do is build it into this app, and then we're asking going wider again, the wider community to have a look at the app, play with the app, and to give us more feedback. Are we asking the right questions? Do we need, have we got the right answers for how you work in the field? So this is a bit of a busy slide, but this is just, but it is actually simplified. But this is just an indication of how we've been working to build the questions, to start building the route through to try and capture what you want to do in your study, and to point you to relevant guidance that's relevant to the study that you want to do. So the pathway will take you through various questions, and then it will take you to dead ends, but then we'll output the right summary, an overview of what you want to do, and point you to the guidelines, and it will keep going, taking you through. And the app itself is a very simple app. It's all online in a browser setting, and the app is question by question. So each screen is a question. So what we see here on the slide before is what's behind the app. So you don't see every route that's available to you in the app itself, but this is just a way for us to review what we're doing, make sure we've captured everything. But the app itself will be very simple. You're faced with the questions, you go through, and behind it is taking you through all these different pathways. And at the end, if you can see here at the bottom right screenshot, it will output the overview of what you've selected in your route through the app, and produce signposts to the guidelines that are relevant to the answers you've given. So we've made good progress, but there's still lots to do. So this is where we come to everybody. We need you to help us shape this tool, to keep giving us feedback, make sure we're capturing everything, we're not missing anything, and to make this as user accessible as possible. So if you're interested in helping, please find me or any of us today, or email me, and we'd be very glad for your help. Thank you.
Thanks very much, Sam. Right, we're going to transition into the first session this morning. The main thing we need with this is to test it with studies. And so that the help we need is for people to come forward. So if you're a social scientist, if you're doing observational studies, we had from surveillance people yesterday, come forward and get involved. And also everybody who's involved in this will be fully recognised and part of the whole process. And it's going to be a huge team effort. And we're going to, as Sam said, open it up wider and wider and wider. So thank you very much. I hope that was a quick introduction. And there's lots of people around who can answer questions. So thanks very much for just taking us through it this morning. And we are officially a WHO collaborating centre. So now over to session one. So that's great. So can I ask the speakers for session one and our chair to come up and we'll swap over. Thank you very much.
It is on. Good morning, everybody. It's a pleasure to be here. Thanks, Trudy and the Global Health Network for the invitation and the associated partners. Now we're going to begin session 5, improving health research methods and processes. And I have given the task of introducing the speakers, which we can do. But also, the reason I'm here is because we have in Peru an extended research network that began as a monothematic but multidisciplinary research enterprise focused on a single disease. And along the time, it expanded to be including different aspects of research in this disease. And eventually, as the critical mass of researchers was expanding, we went to host collaborating groups of different expertises and different focuses, and became a Center for Global Health in a university in Peru, in Lima. And there are some aspects of that that are probably worth of conveying you this morning. And I will say probably the most important thing was capacity building. So we began as a very focused research enterprise, and our researchers were incorporating into master's programs and PhD programs overseas, and then they returned to Peru. So to date, we have approximately 30 PhDs in our group that have been trained overseas, have returned to Peru, and each of them, in most of the cases, has built their own research group, which expands and expands and expands the research network and opens it to different subjects, different focuses, different aspects and different diseases. And this has resulted in a series of large studies. And probably the only one I want to mention is a large study that we did with funding from the Gates Foundation, which was not focused on diagnostics or therapeutics or clinical evolution of the disease, was focused on attempting to eliminate transmission of the disease we work with in a large area of the north of Peru. And in order to do that, we had a 7 years project that included work in different aspects, including epidemiology, education, community approaches, biological interventions in the human and the animal population. And during these 7 years, and with a total funding of approximately $20 million, we were able to interrupt the transmission of this disease in a large rural area of approximately 100,000 people. So the reason I'm bringing this up is because this was a multidisciplinary, locally driven effort to driven by researchers from Peru that put a landmark piece to demonstrate that this disease could eventually be eradicated. And so that's the kind of products we will really like to see in translation, and from each of all of your groups eventually, and that's what the Global Health Network is for. Having said so, I think we can go straight forward to the first speaker, and let me introduce Jill Black. I have to put the plenary. I have only one task. I did it wrong. Okay, so it's a pleasure, personal and academic, to introduce you. I know I don't need to introduce Trudy Lang, the goddess of Global Health Network. Thank you, Trudy.
I didn't mean to start this morning by everybody who's on the dance floor last night. Could they put their hands up, please? I was tempted to get you to stand up. Now, I learned something last night. We weren't dancing. What were we doing? My Nepali colleagues, we were actively meditating last night, apparently. So that's, that's a good thing. So yeah, it was well done, everybody who was on the dance floor last night. That was a lot of fun. Okay, back to the science. I was encouraged to make sure we had a session around how the Global Health Network came about and what it's all trying to do over this conference. It seemed a bit odd, I suppose, not to really talk about the sort of detail of what this is about, because this is everybody's story, and it's all around how it's going to be taken forward. So I'm very grateful for the opportunity to explain what we're really trying to do in a little bit more detail, having just referred to it all yesterday and today. So we all know that we're here because there's just not nearly enough focus on capacity building. It's been the theme of every talk, and obviously the whole push of the conference is to try and work out how we can enable more research in every healthcare setting. I think the other point is, apart from the fact that there's just remains this, everybody used to talk about the 90-10 gap and the 9-10 publications, which were around 90% of the world's research benefiting 10% of the population, and where all the funding goes. And you saw some nice slides yesterday that Vasi showed us around where the funding is driven. It's also around shifting how research capacity development happens, and the old norms of teaching a group to collect data for a product development trial, and the data was going off elsewhere, is history, I hope. And what this is all around is creating lasting, capable, critical mass of not just research capacity, but research systems and management processes and everything you need to deliver good studies. But a really important point I want to make is that there's a huge evolution going on in health research, and it's happening really quickly, and it's really exciting. And my absolute conviction is that research in the most challenging places in the world should be driving that methodology. There are huge opportunities to do really clever things, like it's called synthetic data analysis, where you're randomizing within a database rather than at a patient level, or looking at real world data. Somebody asked us in one of the meetings yesterday, can I use real world data to answer our questions? Yes. And it should be the nurses doing that, community health workers, everybody who's involved. So research is changing really fast, but don't let that be, the really, very sort of niche research in really expensive areas of the globe that have taken this forward. We've seen in history how some of the best research has happened in the most remarkable settings where evidence is needed. And so we need to make sure that how we build teams and train people to do research keeps up, and actually, I think, leads the charge on how research happens, and makes sure that nobody's left behind, and there's equity in access to doing the best cutting edge science and using the most cutting edge methodology. We use this slide in lots of the talks the teams give around and we've heard the phrase used a lot the last day or so about the research ecosystem and how we need to not just focus on clinical trials. And we saw that in COVID, of course, and the diagram here is from the COVID community of practice on the Global Health Network. But actually, I think Zika is a really good example of why we need to think about not just clinical trials when we're thinking about capacity building. In the Zika outbreak, which many of us here were involved with, and we had a beautiful presentation from Gustavo yesterday, there were not any clinical trials. You know, most of the disease was asymptomatic. There was no way of where would you put a treatment. There was some thinking about vaccines, and then that shifted from who would you vaccinate, because it was the beginning evidence we had, it was completely vector-borne, and then that shifted later because there was some sexual transmission, and all the evidence was coming through from vector biology, a huge amount of social science, as we heard yesterday, observational studies to understand what was happening with transmission and what was going on, and then working with the mums and the babies as they were born. And it was all of those pieces of research that were needed. And the amount of evidence that came together over Zika was remarkable. And a lot of that happened in places where there was no previous experience. And Ebola was also true, but then we had to galvanize research capabilities in places where evidence was really lacking. And so for any disease, we need that whole ecosystem of research. And it needs to happen in the diseases that have been with us forever, and obviously emerging threats and outbreaks. But the really exciting piece that makes this work in terms of capacity building is whatever study you're doing, and this is what I was talking about earlier with this research framework, the components are the same. You need to set a good question. That question needs to measure the right outcome in the right place and the right community. It needs to be happening in the right setting, and you've talked to the community about, is that setting appropriate to answer that question, and are you going to be able to measure the outcome that you need to measure, or are you going to have to find a different one? How are you going to operate that? How are you going to train the staff? How are you going to work with the community? How are you going to collect your data accurately and well? And then how are you going to take those findings back into evidence and practice? And so those pieces can be taught and can be supported, and they can be switched to any one of those component areas. And so what the Global Health Network is all around is about teaching those skills. And this conference is deliberately disease agnostic and deliberately study type agnostic, because we're trying to work across that whole ecosystem and deliver all of those skills through these whole different mechanisms that the whole program has been developing over the last decade, to make sure that everybody in the team is able to understand each component step of doing a good quality health research study. So what does the Global Health Network actually do? You've heard, you know, many of you go online and access the courses. Many people are really involved in some of the regional programs. But what actually does the Global Health Network do to transfer that knowledge and bring equity to access to those skills and resources? Well, it works online and it works in the regions, but it's all about taking it's like osmosis, I hope, that you've got teams with incredible experience and skills, and they could be working in the very same hospital as a group that has never done research before, or in the same country or the same region. Or you could have a group working in Brazil, perhaps on dengue, and then there's another team in a different part of the country who've want to do research on dengue and they have no experience. So how do we transfer those skills across diseases, across geographies and between groups? And how do we do that at scale? And it's by looking at all those component areas and working out where there is expertise and how do we transfer that? How do we connect that excellence? And another area I want to call out is research management. I always say, if you can't win and then manage a $2 million grant, you're not going to be able to go to the funders and ask for that money, let alone deliver the research. We have to think of research management as part of the science. If we're going to build lasting, capable, independent teams, they need to be able to win grants, manage them, hire the team, do the project management. And so all of those pieces need to be part of this too. And so I'm sure you've all seen the online platform, and it's this vast vehicle for all of this that we've built over the last 10 or 12 years. And it's become, a remarkable digital tool for making sure this knowledge can move. But it is just a vehicle. What it really is the groups that have a hub in their own area within this community of practice. And so we have over 60 separate groups, each working on their own. Perhaps it's a research network working on something like brain infections, or it's a group who's got a shared interest in, say, community engagement or social science or health economics. And we've had some great ideas even come forward today. I might shout out Victoria and make her stand up. Victoria came along yesterday and said, can we have an area for early career researchers? And you certainly can. This is the Global Health Network is everybody's, and we will happily make sure there's an area for early career researchers that goes up as the next new community of practice. So you have these component topics and themes as all operating as a community of practice and all under this overarching community of practice for health research. And so this enables research groups and organizations and practice networks or project teams, each to work and use that technology that's on there. And then the whole platform can be accessed by team members, each other, but also the frontline research teams, lab staff, health workers, clinicians. This is the people that come to the Global Health Network every day to access a training course or to find an SOP. And that's how they end up in these communities of practice. And the dream scenario there is this access to information and resources and knowledge. So, you know, my ideal situation would be, say, a researcher in Nepal wanting to work on leishmaniasis, and she's not got you know, she's not really sure where to start, and she begins to look, and suddenly she's pointed information that she didn't even know existed. And so maybe she finds a video on how somebody did community engagement on visceral leishmaniasis somewhere else. Perhaps there's some data standards that she didn't know was there, and so she can work to the same standards as everybody else, so the data she collects can be shared. And then she does a course on research ethics and finds a template protocol. Now, all of a sudden, she can do the exactly same standard research as somebody in Harvard, Nairobi, anywhere. And that's the point, that we want to really develop this digital technology so it makes recommendations. And so people can find information they didn't even know existed, and that wherever you are in the world, you can collect and gather exactly the same quality data and design your study as well as anybody else in the world. And that's what our goal is to try and all work together by putting that information in and then creating these digital systems for translating it. But it doesn't just happen online. And the really exciting thing we're talking about today with these banners either side of the hall is this transition to the global south. And this is what we've been talking about today and yesterday, of course. And it's really exciting to be at this point, and you're going to hear much more about this later on. But I just wanted to show this deliberately overpopulated slide. Thanks to our funding from the Bill and Melinda Gates Foundation, Wellcome, and many others. There are now this vast army of Global Health Network coordinators working through all the coordinating hubs and centres you can see. And they're actively working to set up things like research clubs in hospitals, data science clinics, mentoring systems. And they can work as well if people are working on, say, looking at a new process for delivering community engagement, or a new process in health economics, or maybe we're all beginning to talk about some ways to design studies in a different way. Those coordinators can go out to the regions and run a session on that. They can do a supported session. So for anybody trying to disseminate some of your work or some new processes, these people can work and help you to get that out and really escalate your findings, and also get these new methods out into the regions. And so some of the achievements we've made on this is over 2.7 million online training courses have taken. We've had thousands of people attend workshops, and we've done those in the region and in person. And it's really making a massive difference to just mobilizing all this information, as I say, like osmosis, from these centres of excellence to the centres of less experience. So we talked about this quite a lot over the last few days. This is a really important element to this, that we're setting this up as a structure that there's no one leader. It's a coordinated, decentralized system of any number of hubs across the globe, and they can each run their own program and be the Global Health Network, Ghana or Nepal or any number of countries. and win funding to take these work forward and have their own coordinators, but everybody works together through these shared standards and this shared ethos of translating this knowledge and information. Just a quick shout out for an opportunity. I've talked about these new methods, and I've talked about teams learning how to do research. We've had this concept called a Pathfinder project, and this is where if a group are trying to say get a new question from an existing data set and they're not really sure how to do it, then the Global Health Network facility and probably the local coordinators can help work with them and take them through that process. But also in doing so, track that and work out where the pinch points are, where the areas of difficulty arise, and document it, and then map that as a process. And where the solutions were found, it might have been a data management system or working out how to get permission for using the data, whatever it might have been, or it might be in setting up a social science study, or pretty much any of these questions. And those can be tracked and managed, and then we can gather data on this evidence of the methods that were used, and then others can share and use them. And we would really like to hear from anybody who wants to help work on a Pathfinder project with us. So my last slide is an invitation to all of us, and we've talked about this so much. You know, get involved. The Global Health Network is everybody's facility. It's this open franchise platform and system, and there's any number of ways that you can get involved, either hosting a global health hub in your country, running some of these regional activities, contributing your resources online, or taking part in these Pathfinder projects. So it's been great to take you through that today, and really, you know, chat to any of us, and just if you're not involved already, then very welcome to do so now. So thank you very much. I think we'll take questions at the end.
Thank you, Trudy. I'm sure many of you will have comments or questions, but we will take all the questions at the end of the session to minimize our timing stress. We have 6 talks and methods and processes coming from different parts of the globe and approaching different subjects, including community participation, clinical trials, national systems, etc. So the first one is Jill Black, the Director of Sustainable Livelihoods Foundation in South Africa, and she will present participatory visual methods and the mobilization of community knowledge, working towards a more equitable research process. Please.
Thank you and good morning. Thanks for organizing such a brilliant conference, Global Health Network, and also for the opportunity to speak this morning. I'm Jill Black. I'm from the Sustainable Livelihoods Foundation. We're an independent research and engagement organization based here in Cape Town. And it's amazing to know that we are now part of a collaborating center with the World Health Organization. Fantastic. So my contribution to this session this morning is going to be based largely on an engaged research project called Enhancing Capacity and Reducing Risk Through 15 Best Bets for Transformative Adaptation with Vulnerable Residents on the Cape Flats. And the purpose of this project was to work with community members from 3 highly marginalized areas in Cape Town to identify potential interventions to counteract 3 environmental hazards, those being fire, flooding, and water shortage. So my talk is not on a health issue, it's not on a disease or an illness, but it's about a situation which has massive ramifications for health. So we worked in 3 communities. We worked in an informal settlement called Overcome Heights, where we were looking in the context of fire, an informal settlement called Sweet Home Farm. We were looking in the context of flooding, and a large township in the northern suburbs of the city of Cape Town called Delft to look at water shortage. It was a 3-year project. It just finished in October this year. And within the context of those 3 years, we worked with 48 community members. We followed a participatory visual methods approach, and this involved digital storytelling, where the co-researchers who were working in focus groups per community setting, shared lived experiences of fire, flooding, or water shortage, depending on which setting they were living in. And these stories were illustrated and described through narratives and stitched into short films of 3 to 4 minutes in length. So these are very individual, very personal stories. Building on that, we went into community mapping and then photo voice. And we went through this layered methods approach, this superimposing methods to build a very rich picture of community experience, community knowledge, and community ideas. And going through this progressive research inquiry enabled a very rich understanding of what could be done before, during, and after these climate-related events to mitigate their impact. What can community residents do for themselves, and what are they unable to do? What kind of assistance is available, and where are the gaps in responsiveness and support? Once all the visual materials had been generated, all the stories, all the photographs, and all the maps, our team facilitated a participatory analysis process with the community members, whereby they reviewed all of their stories, maps, and photographs, democratically decided together on which visual materials illustrated the most significant problems and solutions. They then worked to triangulate the data within these visual materials and then formulated these best bets to counteract flooding, fire, or water shortage in their communities and similar communities, and worked to take from these overarching best bets to draw out potential interventions in more detail. And to give you an example of the best bets to counteract water shortage, so these best bets were formulated by our co-research partners in Delft: improved infrastructure, upgrade, fix, and install more, especially around water meters, making JoJo tanks available. So JoJo tanks is a word that's used for water tanks. It's just a brand. Better communication from the municipality about water cutoffs. Improved engagement by the municipality, come into the township, meet the people, talk to the people, and better understand their water challenges. Household innovations within households, within community to save water, and using public places and spaces to promote knowledge and awareness about water challenges. And these were further unpacked, asking, well, in order to use public places for awareness raising, for example, what is actually needed to make that happen? Why is that needed? What's the driving need behind that best bet? Who is responsible, and how can it actually happen? So really drawing out the potential interventions in more detail. Once the best bets had been formulated and the potential interventions had been drawn out, we entered into a phase of engagement. There were 3 community engagement events, one held in each of the participating communities in Overcome Heights, Sweet Home Farm, and Delft, where the co-research focus groups presented their own stories, their photographs, and their maps to wider audiences within their own communities, other NGOs that were living and working in the area, and some members of local government who also attended these events. And then the final activity in this project was to bring all of the co-research groups together from these 3 research settings and to engage with policymakers. It's an indaba, it's a word for bringing together of many different stakeholders in the South African context. And the idea was that the community co-researchers presented their best bets in this large forum, and then went into breakaway groups per environmental hazard with government representatives who were relevant to the environmental hazard that they were concerned with. The best bets were literally put on a table, and they were discussed and debated, and a lot of knowledge exchange and co-production of knowledge happened at that event. So the challenges with this kind of work is continuity, both in terms of when you're working, doing very in-depth engagement processes with people from different communities on different topics, different environmental hazards, essentially, that continuity of keeping in touch can be quite challenging. Offering meaningful benefits and outcomes to participants, to co-researchers. The element of distress is always present when you are engaging on extremely difficult living conditions that people have to endure every day, and the disconnect between marginalized citizens and the state. In terms of recommendations, build lasting relationships with communities, be present, stay in touch, and follow through. And this is absolutely essential for building trust and building respect, and for being able to do this kind of work, really getting to know people. Foster participation and ownership through visual methods, navigate expectations, allocate sufficient time and resources, and be real about what the benefits actually are. In research dissemination, it needs to be community-led. That's by far the most powerful way of making engagement happen. Real time and resources have to be invested in preparation. People living in extremely marginalized places are not accustomed to facing representatives from government. That takes time. I can't emphasize enough how important that is to make sure that people feel ready to take on that challenge. Work to have the right people in the room together. We have a website which is specifically dedicated to this project, www.waterandfire.info, and we have created a short mini documentary of the project. It's available on YouTube. You type in the Water and Fire Project. Here are my acknowledgements. This was done, it was funded by the GCRF and done in collaboration with the University of Stirling. Thank you.
Okay, thank you, Jill. We are going to move now from the community to clinical settings. And the next talk is Clean Ops, Clinical Research Operation Training Programs in Low Middle Income Countries by Iyasu Mekonnen-Eshetu. Please.
Okay, good morning, everybody. Hope you had a very nice time yesterday. So my presentation will be on Clean Ops, Clinical Research Operation Training Program in low to middle income countries. Sorry. Addis Ababa University is the biggest as well as the oldest university in Ethiopia. And it is one of the top universities in Africa. It has 14 colleges, and one of the college, which is the biggest one, is College of Health Sciences. It's in this college where Center for Innovative Drug Development and Therapeutic Trials for Africa, CDT Africa, has been hosted. This center is a World Bank supported center, Center of Excellence for Africa, and it has got a number of training programs, short courses, PhDs, MScs, postdocs. Also, it focuses mainly on medical discovery, as well as development on drugs, vaccines, and diagnostics. As you all know, ensuring the two common goods, participant safety and data credibility of the GCP requires well-trained clinical trial staff. Competency-based training in clinical trials should be given due attention to prepare site staff for effective clinical trial conduct. So the aim of this presentation is to focus on what Clean Ops program has done so far. Clean Ops program has got its own unique features. It is participatory in its nature, that when right from the outset on developing the curriculum, though the curriculum was first developed by the core team, but it was further developed by the PDPs, and the developing competency framework was set jointly by TDR and the Global Health Network. Another unique feature of this program is it's allied to local priorities, focusing on practical problems in African trial sites. And those involved in the training were all having clinical trial site experience. It also addressed all relevant domains for effective trial conduct in this training. And it made an intensive on-job training over 10 weeks period. And monitoring and evaluation effort has been made to meet the course objectives. It also followed innovative training approaches. Just to mention some of the innovative training approaches, it employed model learning management system, which used online tool for uploading the PowerPoints. And it also gave trainees opportunities to get PowerPoint online, even if they miss classes. And it also enabled the teachers to record their inputs on slides, allowed trainees to put questions, comments, and others on slides, either as a text as well as voice record. It also followed voice rate recording, which is an interactive platform. It created discussion forum among trainees and teachers to share opinions, give comments, feedbacks, and ask questions and get responses. It also conducted live tutorial with Zoom every week for 1 hour every Thursday, where summary presentation on each lesson were presented, followed with question and answer session. It provided reading materials online, classified as mandatory, recommended, and in-depth. Designed strategy to motivate trainees by providing scholarships for top trainees to be enrolled in an MSc program hosted by Facility Africa in Addis Ababa University. It also prepared risk management plan. So the students were grouped in group and they identified, analyzed risk and came up with risk management plan in order to mitigate the problems which they might have faced. The contents of CleanOps course have got 10 lessons. Introduction to clinical research operation was first, followed with data management and biostatistics, study design and development, project and financial management, conducting a trial, parts 1 and 2, closing out and reporting a trial, working with external partners, quality systems, audits and inspections, as well as pharmacovigilance. These were the CleanOps tutors having rich experience in clinical trials. The major achievements which we claim to have in this training program was it has created strong collaboration with faculty capacity development college in Ireland, as well as innovation. It also helped us network with trial coordinators in Africa and even the trainees among themselves too. It created opportunity for sharing experience among trainees, and it built capacity of over 80 trainees in one go, established virtual platform system that might be applicable for our future training programs. However, there were some challenges which we faced. Just to mention a few among the many, there was a problem of falling behind the course for some trainees and high dropout rates as well. There was low participation as well as technology challenges, which were mitigated by following them up and encouraging trainees to participate by sending several emails, as well as seeking IT support from Addis Ababa University Innovation. This is a free access course. If you are interested, you can access it using the link shown on slide. In conclusion, CleanOps training program help trainees acquire relevant knowledge in coordinating, conducting trials in LMICs. We therefore recommend the training to continue to develop critical mass of trained trial staff in Africa, and the training could also be given in other languages like French. I would like to acknowledge the Bill and Melinda Gates Foundation for its financial support, and FCD for training our teachers as well as course admins, innovation for supporting the IT, and at Sawa University for facilitating the bureaucracy, as well as City Africa for unreserved support from the inception up to successful completion of the program. I'd like to thank you all.
Thank you. So far we are keeping Clockman happy, so let's try to keep doing that way. Next speaker is Dr. Daniela Morelli, researcher from the Instituto of Efectividad Clínica y Sanitaria in Buenos Aires, Argentina. And she will speak about the effectiveness of a diabetes program based on e-health, on capacity building and quality of care in type 2 diabetes, a pragmatic quasi-experimental study. Daniela, please.
Good morning. I'm glad to share with you this project from EX Argentina in the implementation of a program to care for people with type 2 diabetes in the province of Corrientes. As we know, it places a heavy burden on people and health systems. In Argentina, we have a high prevalence above the regional and world average. From EX, we are working to improve the control of chronic disease through studies like this program financed by the World Diabetes Foundation. The purpose of the program was to improve the quality of care to people with diabetes through a complex intervention of 4 components, as you can see: research, training, e-health, and audit. The implementation was evaluated using a mixed method study. 19 primary care centers from the public health system enrolled patients with a confirmed diagnosis and access to mobile phones. An important pillar in the program was the education component. We training professionals and community health workers, educators, and peers face-to-face before the pandemic in the clinical management and in self-care based on in the Argentinian diabetes guideline. These professionals in turn replicate educational activities at their centers through workshops and counseling. For us, their engagement and motivation was inspiring. In total, we equipped 20 centers. We provide resources like education material, equipment, and the health system. The health system was developed at EX and included the app for recording data through mobile devices, a web platform, a SMS validate system to deliver bespoke messages based on the risk factors of each patient. In addition, at least once a year, we visit the sites to understand the local context, to check the healthcare process, and to retrain the healthcare teams. In total, we enroll 1,000 patients, around 50 patients per site, of which 40% were new diagnoses. Most of them came to the center brought by other patients who had participated in the workshops or counseling. After 20 months, almost 600 patients complied with all the visits recommended in the hour guideline. Some process indicators were improved, such as glycosylated hemoglobin, food test, and eye exam. However, we couldn't see significant difference in the metabolic control. From the qualitative approach, we found good acceptability by the professionals, although they highlight the increase in the consultation time. The patients expressed support through the SMS messages. During the study, we found some difficulties, like a lack of medication for diabetes in public system, difficult to access of ophthalmologists and diabetes specialists, and flooding that caused devastation in Corrientes in those years. However, we could leave some things behind. Motivate teams and resources, support to the Ministry of Health Corrientes to expand the program to another 50 centers, scale up the project to other 3 provinces in Argentina, and almost important, we create a great bond with the funding agency, the research team, the primary care centers, and the policymakers. Join forces day by day to support research and diabetes public health. For us, this project was a good example to show how implementation study improved the process of care and influence policy. Because despite all numbers, always about the people. 2 things very important for us. In the research group, we were all women from the different disciplines. And we have supported to the institution, the EX, because it's very important to understand that research begins long before the project funding. And to have an institution that supports the researchers during preparation of the proposal is essential for us. Thank you.
Thank you, Daniela. Our next speaker comes from Pakistan, and Fatima Khurshid will speak about promoting responsible research processes using digital technology and its impact on research conduct and experience from Pakistan. Please.
Hello, everyone. First of all, I would like to thank Global Health Network for this opportunity. So, brief introduction of Pakistan. Pakistan is the 5th most populous country of the world with a low health status. So it is a developing country with a double burden of infectious diseases as well as the non-communicable diseases. The health expenditure is also below the set target of the WHO. So, tiered healthcare system with a patchy access to the research. So, though the research output has increased over the last few years, but there are limited capacities for the healthcare research with a patchy governance and oversight system. So, research regulations in Pakistan. So there is a drug regulatory authority for the approval of the drugs, or there is a ethics regulatory committee for the clinical trial approvals, and for medical regulations we have independent IRBs or like ERCs, independent review committees. So there is no proper mechanism in place for the post-approval oversight of the research project in Pakistan. This is organizational profile of Shaukat Khanam. Shaukat Khanam is a non-profit cancer hospital dedicated to perform high quality research. Though it is a cancer hospital, but it has the capacity for all other type of researches. research organization at Shaukat Khanam. Shaukat Khanam is committed to perform high quality research as referred in its mission statement. So we have our research wing based on the three sections: clinical research office, cancer registry, and the basic science lab. Clinical research is mainly responsible for the oversight of the research and review and approval processes. So the review and approval are done by the SRC and IRB, and then there is a post approval oversight of the research project. The cancer registry is like involved in maintaining the registry of hospital cancers, as well as the Punjab Cancer Registry, and basic science research lab doing research on the cancer genetics, immunology, and it has its own biobank. So research review and oversight at Shaukat Khanam. So review and approval at Shaukat Khanam will be done, conducted in two phases. First is the scientific review committee, which review and approve the scientific content, and then it goes to the institutional review board, and then we can have the continuing review reports. So research compliance and oversight system. Before 2018, there is no oversight system at hospital. So in 2018, we have introduced, started a clinical research oversight and archival system to promote compliance to the ethics review standards and the responsible conduct of the research. The main core aim of this training program is to train the investigators, especially those without prior experience, and the research on the responsible conduct of research. Prior to 2018, post-approval oversight is mainly done by the investigators, and this is the oversight process. So we have investigators training, GCP trainings for the response and responsible conduct of the training. Investigators are provided with the training of the responsible conduct of a research with the provision of a structured template before COVID, and a regular review of these documents were done by the study follow-ups and at the time of study closeout reports. So when during COVID, we have shifted to the online session. Initially, it was done by the face-to-face session. Then we have shifted to virtual meetings. Initial informal discussion with the investigators supplemented with the video trainings and the post-training assessment. Additional open access online training resources were also adopted. So use of structured templates, regular review of the research record leading to the timely identification of the issues, root cause analysis, as well as the corrective and preventive actions. So there is a periodic review that identifies issue in a timely manner systematically through the changes in organizational policy and culture. So this is the demographic of the training program, which we have started in 2018. A total of 141 studies were assisted through this system from April 2018 to November 2022. So the most of our investigators, so this demographic is mainly based on the principal investigators, and most of our principal investigators are the residents. As you can see, it's the 58% are the residents, and only 16% of overall population had the previous experience in research conduct. So program evaluation. So evaluation of any training program is like mandatory to timely identify the issues and mitigation of the identified issues. So there are various methods that are used for the evaluation of the training programs. So we have used here Kirkpatrick model for the training evaluation. So it has 4 levels. First level is the reaction level. So how does the participant feel about the training? And second level is to what extent participants improve their knowledge, skills, and behavior. And third is the impact of the behavior. And fourth is the results. So for the reaction level, we have used a 5-point Likert scale and an open-ended question. So 2/3 of the population two-thirds of the population agrees with the quality of training and investigators' effectiveness. Only 1% population did not find instructor effectiveness. So there is a need for the improvement in training. So learning evaluation was done by a pre and post test. By the time of investigator performing their pre-test, they have already completed the GCP training, so they have an idea on responsible conduct of research. So the results of pre-trainings were 72% and the post-training were 84%. So behavior, for the behavior evaluation, we uh, sorry, for behavior evaluation, we conducted the record review, and all the studies that are involved in this training program, their records are reviewed. And we have also made this a part of our key performance indicator. So you can see the result percentage differences for the last 2 years, as well as the key performance indicator for this year. So we have some challenges. So shifting the training program for informal to formal training, balancing and advisory role, open communication while ensuring compliance, and a human resource managing program. So we have some future plans. We further aim to enhance our video educational series to include training on the data sharing, ownership, good publication practices, and research misconduct. So thank you.
Thank you. Our next speaker comes from Dubai and Canada at the same time. Mohamed Akali will speak about national health research systems from system analysis, understanding, and towards strengthening the case of Palestine. Please.
Yeah, good morning, everyone. My name is Mohammed Al Khaldi. I'm working as a postdoc researcher at McGill University, scientific collaborator at Swiss TBH, and recently I joined Canadian University in Dubai. So today I'm gonna talk about the health research system analysis, where we conducted that system analysis in Palestine as a first national study, and we are now working in Iran to analyze the national health research system as well. So globally, related to the national health research, so we have seen kind of major gap in low middle income countries and high middle income countries in terms of research productivity, as well as the building of health research system in each country at the national and local level. We have seen something about the SDGs and linking the research with the attainment of the SDGs, and how we invest in research and innovation to amplify the public health interventions based on evidence and knowledge. And we started to see something like major attention and interest in research, and in terms or in light of the WHO strategy that actually focuses on the capacity, standards translation, as well as prioritization of the research topic. So universal health coverage is really bringing the research topic as an important and central issue that the national and member states should focus on. And COVID-19 has shown an important need for evidence and integrating the evidence into the policy making level, as well as building strategies based on updated knowledge and evidence. So regionally, we have really limited national health research systems built in the Middle East regions, as well as the limited number of productivity in the Middle East, especially in the low middle income countries. So some studies actually have been done by WHO EMERO office, and they found that there is a major gap in the national health research systems, and building or rebuilding the national health research systems pillars in the country. So at the local level, we have seen Palestine producing a good number of research, but this research is fragmented, unstructured, and there are a lot of things that need to be done at the structural level: resources, capacities, and the stakeholders' involvement. So just giving an overview about the context of Palestine, where we have their like political instability, as well as kind of military interventions, occupation, and in two different parts of Palestine. And this is really a unique situation that can be actually studied in terms of health policy and system research context. So there are many challenges that Palestinian health research system and health system as well experiencing: governance, resources, lack of sustainability in the capacity and resources, as well as demographical and epidemiological changes, and an issue of the data and information quality and availability. So theoretically, the health research system definition, it's kind of a set of people, institutions, and actions that comes together in order to found or to establish health research system to generate high level of evidence or knowledge, and also how we regulate this knowledge within a context or a structure. So the structure of this system that should be ideally in each country exist should be actually foundation elements or components, values, principles, and cultures, as well as the key pillars, which is stewardship, financing, resources, capacities, and the production and using of health research into practices. And we call this operational or technical functions or elements. So at the end, we will have the whole building, which is the National Health Research System that actually seeks to advance the knowledge, as well as using this knowledge properly in the healthcare system. So the health or National Health Research System should be linked, or it's ideally linked with the health system and the overall scientific system in the country. And the study, the significance of this study that actually aiming to understand and analyze the health research system in order to strengthen it. So these are the objectives of the system that actually searching and investigating each part or each element of the health research system. We use a qualitative research methods, 6 focus group discussion, as well as 25 in-depth interviews with the key persons in the 3 sectors: academia, government, NGO, and private sectors. So this is actually the first findings. We found a limited understanding and conceptualization about the health research system, concepts, frameworks, as well as terms. The second part, we found the health research system performance is underperforming, and we found actually gap in prioritization of health research system topics at the national level, as well as many major structural things in the governance system, as well as the policy were actually lacking. So this is the map of the health research system in Palestine, overlapping, unstructured, and unclear in terms of responsibilities, functions, tasks. And the prioritization of health research topic is really an issue in Palestine, and we found some discrepancies and changes in the priorities. So these are the level of engagement of the health research system stakeholders in the country, and we have to work on pushing all of the stakeholders to have high level of engagement. And here it's like a map where each stakeholder are actually positioned in terms of health research system. So also we have a major gap in the resources, and we don't see any kind of central item in the government budget allocated for health research and investment. And here something about what is the status of knowledge transfer and translation in the country. And here is the major or the main conclusion from the whole national health system analysis. And we have to work on 2 levels, national level and system levels. And we have to start kind of strategic dialogue among the stakeholders, as well as having political support, collective involvement, as well as working on improving the culture and conceptualization of the health research system in each country. So this is a map of how we can build and rebuild any national health research system. We have to start from the global, regional, and national in order to build the foundational, operational, and also the final ultimate goals of the national health research system, connecting that system with the global framework of the WHO. Thank you so much.
Well, thank you, Mohammed. We have had a wonderful tour into community studies, clinical research, national research systems. And we are having to finalize this tour, we are going to close with data management. And so we have National Gao from the Cambridge Wellcome Trust Research Program. And we'll speak about innovative open source approaches in automatic clinical data management for a large multi-center trial. Thank you.
Thank you. My talk is about automating the clinical data management in a large multi-center study. I would like to begin with a thought-provoking quote. And I saw this online: better data is better than better models. What do you think? Okay, data management is the process of generating accurate, reliable, and statistically sound data for analysis and decision making. In the chain network, we had a network of 9 sites that was doing a cohort which was multi-event, longitudinal, and a multi-center, total of 9 sites from Africa and Southeast and South Asia. So we had a total like a representation of the various regions that we wanted to collect the data from. It was a study on malnourished children who are acutely sick. And so before we began, we thought about the data issues that would emanate from such a setup. And we in terms of the design issues that you need to come up with when designing a proper database for a multi-center study. And these are some of the issues that we identified. CRF issues, inconsistencies, and things like missing data, programming errors if you are going to have all the data distributed teams of data managers here and there, and also the time to chase for all these things. The unique challenges of a multi-center study include the complexity of the setup, infrastructure requirements from the various places and from the various sites, data cleaning turnaround, how quickly do you want to get back your feedback, and how quickly do you want to push back your issues in terms of queries and all that, and your standardization efforts. So what we need to see happen in such a system is we need to monitor data in real time, or if that can be possible. We also need to run cleaning queries, look at how we standardize the reports so that we don't get different reports in different sites in different formats, and also improving the productivity of the data team and not turn them into task generating people. So the solution that we came up with was an embedded service, right from design of the study to the data collection and analysis, and we embedded critical steps in the process. So it was majorly a three cause process: detection, diagnosis, and editing. So this is the methodology that we adapted. So we enforced a peer review at the we had a paper CRF that to cater for the technological differences between the sites. So we asked the clinicians to enter data into a paper CRF, and then we had a peer review to review that paper CRF. Then data will be entered onto a database that was online, and then we had more checks at the database level. And then behind the system, we had automated scripts that were able to pull this data and generate reports that we published them through a Shiny platform on the web. And these reports were readily available on time. The refreshing rate was about 10-20 minutes, so that if there are any issues with the queries and all that, that will be handled in a semi-automated way. So these are the tools that we used. We used REDCap for the primary data collection on the clinical system. And we looked around to get a lab management information system for collecting of samples, but we could not find one that would cater the needs of the site. So we came up with one that we use within the Cambridge Wellcome Trust. It's called KLIF integrated database management system, which is customized for the kind of work that we do. And then we use the open source tools, which is RStudio and RShiny, to be able to develop the web application for the queries. So the benefits of this system that we saw was that we were able to profile all the CRFs and identify the risk areas and put queries and checks on the automated platform, so that beforehand, as data was entered, we could be able to see the kind of issues that we were not supposed to see or we didn't want to see, and it was easy to communicate feedback back to the sites. Actually, they had the access to the database themselves and to the dashboard, so they were able to see all these things. Real-time checking, as I've mentioned, we managed to standardize the reports. So we had a reporting module that had all the reports well written and standardized that for the needs of the sites, both at the local meetings level, local monitoring, as well as at the coordination level, where we were able to coordinate this. And also we even came up with other clinical utilities like projecting the enrollment curves and things like that. So in terms of what are the key takeaways from this system, we managed to have a seamless data extraction process that was easy and with no or limited human intervention. We used a cron service within the computer to be able to schedule the tasks for the extraction and the generation of the queries. And this allowed us to have automated cleaning scripts that was able to look at this data and send those queries over to the sites through the dashboard. And for human interaction, we implemented task management solution, which was a sort of like a ticketing system that you're able to, you get a ticket, you look at it, and the ticket comes from the system. So you go to your database, look at the issue, go to your paper CRF, see what is the problem and fix. We managed to roll out our own LIMS solution. But of course, if you want to implement this, you can as well look at what is the solution that is out there, and you could do this. The other also takeaway is that we managed to do a clinical monitoring. We looked at the critical clinical features in terms of the quality of the data, and we asked clinicians on the ground for in case there are any queries around there, and we had an improved productivity of the team. So key recommendations for implementing a multi-center study, and you want to centralize the database, make sure that you have a standardized practice across the data management teams for all your sites. If you're able to host the database online, that is good. But if you can't, make sure you have an offline server that is able to synchronize with an online one very quickly. We have things like RedCap Mobile that is able to work offline, and you synchronize when you get an internet connection and things like that. We also you need to make sure that you're able to monitor the data as soon as possible for any problems. So what you'll need probably, if you want to implement this, you need a server computer, preferably on the cloud, to avoid the IT overheads. Also, you need, of course, the RedCap is open source. You just need to write the consortium. The RStudio, RShiny, all these things are open source tools. You need skilled human. You need a data manager that is able to do this. Most of them are trained on R nowadays. And you need a program champion that is able to really push this and drive so that everybody can adapt and the implementation can be successful. Thank you very much.
Thank you. As I was mentioning, we have had a spectacular morning, and we have seen different scenarios and different applications of global health, beginning by community studies, clinical systems in hospitals, and now data management. And I'm sure we all have taken a series of elements that we will eventually apply in our own realities. We have plenty of time for questions, so all the questions to the plenary speaker or for the talk speakers are more than welcome. No question for the chair, please.
If you can bring the mics down to the front, then come forward with your questions if you can. I think we might get better audio, but we can try. Thank you.
Hello. Interesting talk from all the speakers. I wanted to start with the chair, but now I cannot. My name is Palma Netongo, and I'm from the University of Yaoundé, one in Cameroon. And I think then I'll ask my questions to the last two speakers. You mentioned data and crosstalk between platforms. My question to you is very simple. Does RedCap not work on a mobile device? And to you, how unique were the problems that you saw in Palestine? The Pakistan is very close to you, in Palestine, and how that was, I want to put it that, how was that very unique in the way you would compare that system with the successes in Canada, and maybe put that as, with the failures that you've experienced in Palestine? Was there anything that you think you could take from Canada and be able to implement in Palestine for success? Thanks.
Yeah, so let me go first. Does RedCap work on mobile devices? Yes, there's a module for RedCap called RedCap Mobile that you can implement, but you need to do design considerations on your layout of the CRF so that it can fit on the device. It has an offline capability feature that is able to synchronize through the server whenever you come back to the office, or whenever your internet connection is stable enough to synchronize. And we recommend this. Thank you.
Yeah, thank you. It's really a very important question. So the uniqueness of Palestine case actually that has contextual differences from the other countries, as well as, for example, we have really qualified researchers, scientists, as well as health workers, but there is no well-structured and organized system or framework, as well as the political situation is heavily impacting the whole social system in Palestine, including the health system, as well as any developmental efforts that can be implemented at the national level in terms of fragmentation in the governance, resource limitation, as well as the sovereignty and resources control. It's completely out of the Palestinian or the governmental institution in Palestine. So you are trying as a Palestinian institution to build with the current resources and the space that you are given by the occupying powers. So that's why the context is unique in Palestine, but any success that can be achieved there, it's something really important, and this should be accumulated over the time in order to have final well-functioning systems, especially in the healthcare system. So it's accumulated efforts that finally or eventually you will have a well-built systems, whether evidence system or scientific systems or healthcare systems. So working under this pressing situation, it's also something unique, and it's really successful learning experience that we can apply it in different contexts that have the same situation.
Any other questions? Yes, can we have the microphone here, please?
Okay, thank you. My question is for the last presenter. My name is Oyewole Idili from Nigeria. So regarding the open data source clinical data management for automated process, we're actually conducting something similar where we are trying to see consistency between paper CIF as reported on multiple sources. So in bringing this together, I think there are indicators you look out for. As a matter of fact, I just want to know what are those indicators, and at the same time, what's the threshold for assessing or to ensure that you actually, match these different sources together. Thank you.
Okay. Should I go? Okay, thank you. So to just paraphrase your question, you are asking for indicators to look for when you are implementing such a solution. So the indicators would be one, how heterogeneity or homogeneity is your data set? Are you collecting different data in different sites, or is it a cross-sectional study? So if it is the same across, then you need to have a uniform database, and for that database, we recommend having it online, or it should be somehow the same. You can have a decentralized data set, but the issue will be things like variable names. How do you want to come and do your curation later on? How do you match these things? We have seen challenges in terms of the way people are coding the data sets. If you have a totally distributed database, and this brings problems during analysis later on in the stage. The other observation is, of course, the capabilities of the teams on the ground. How capable are they to implement a data management function and to monitor the data? So if you are the coordinating center, then you'll be worried in terms of how soon will I want to see the queries and the issues with this data. And so that's why you need to be able to consider for all these things as you make your choice. Thank you.
Excuse me, sir. Please feel free to reach the speaker after the session. We have time for 2 more questions. Our colleague up front and somebody in the back, please.
I have a question from Daniela. Daniela, first, I congratulate you that being a woman and being a woman group, you executed such a large research in your country. My question is that since diabetes is a chronic disease, and going through the abstract and the research finding you just presented, that there was no significant change in that HbA1c, but there was uptake of the health services and as well as the control of diabetes. In the chronic diseases, women or patients suffered from psychological problem, like they are having low self-management, self-efficacy, and they are mostly suffer with diabetes distress. Were you able to shed or assess that psychological parameters other than there was no HbA1c significance reduction? So the psychological parameter, did you assess that? Did you get a chance?
Help me. I speak in Spanish and we'll go translate. I try. This study, nosotros no evaluamos el impacto psicológico, pero entendemos el contexto del paciente, conocer el contexto local y el contacto y el entrenamiento con los pacientes permitió tener en cuenta esa dimensión. El escalonamiento llevó en consideración otras perspectivas.
We didn't directly evaluate the psychological aspects in the patient, but knowing the patient and knowing the environment allowed the team to have this consideration in the context of the whole program. A final question at the end, please.
Thank you. My name is Businkosi from the Africa Health Research Institute. Thank you for all the presentations. And my question is directed to Dr. Jill Black. As you know, in the settings where we conduct research, issues of access to basic services kind of dominate. And so my question is, do you have insights, or can you share how we address this impasse where communities at one level will express issues around access to water, housing, which are beyond the research remit, and we have the government, or as in your case, the city of Cape Town, being unable to meet the participants' needs? Thank you.
Thanks, Lucy. Well, I think you've raised a very important point about that disconnect between the very marginalized communities and the state. And what we found was that the value of doing these kind of interventions where we brought the community members together with government around a table and really gave them an opportunity to engage and talk and understand each other, was that there was an opportunity to discuss what the real challenges are and what government is trying to do, and why it's not the faces that the challenges that are actually faced by government in terms of them trying to implement. The city of Cape Town, with all due respect to the very well-meaning people that sit in our local government, it's very siloed, and it's very difficult for people within the government structure to move outside of their own kind of boundaries, their own kind of departments, their own units, and work together to try and bring more kind of holistic needed change. So I think what this project really shone a light on, kind of like the inadequacies of government structures and being able to respond to some of these bigger needs. But I think the importance of bringing community members and government together is that it's a continual prodding, it's a continual poking. It's like continually reminding people that work in government that they are actually accountable, that they do need to be, these are the issues, these are the challenges, these are the priorities, this is the ways in which people are struggling, and these are the priorities that need to be addressed. So it's just about continuingly kind of creating these spaces so that the government can be continually reminded of what its job is and what the priorities for the people are, and how communities themselves actually want to be involved in making change happen, but they can't do everything by themselves. They need to work in partnership.
Thank you, everybody. This has been a wonderful sharing of an array of diverse experiences. We have enjoyed it a lot. And again, please feel free to reach the speakers during the break. Rudy.
Thank you, Chair. Thank you, all the panelists. That was absolutely fantastic. We're going to do as good a job as we did yesterday, I hope, at keeping to time. So the morning exercise routine starts with the jog to coffee. Please, can you come back really promptly? We've got a really excellent session after coffee. So be back seated, ready to start at past. Thanks again, everybody. Thank you.
Good morning, everyone, and welcome to session 6 entitled Preventing Pandemics with Responsive Health Systems. My name is Cristiane Vera Machado. I'm from the Oswaldo Cruz Foundation in Brazil. I'm honored to be the chair of such an interesting session, and I would like to thank Trudy Lang for the invitation and all the Global Health Network team and the University Cape Town teams for organizing such an exciting conference. I'd like also to welcome our panelists. Thank you very much for accepting the invitation to share your work with us. So let's get started. In the last 2 years and 10 months, health systems all over the world have been deeply affected by the impact of one of the most severe health crises of all times. The COVID-19 pandemic has caused health systems disruptions or even collapse, and has shown limits in what regards their preparedness to face complex healthcare emergencies. The pandemic has also challenged health researchers. We had to learn and to act very quickly to try to understand a new disease and its consequences. Moreover, we had to change our ways of developing and communicating research. We had to learn to do more collaborative work, to enhance our efforts to influence policy decision-making by bringing scientific evidence to policy decision-making, to develop new technologies in a short time, to conduct complex research to test those technologies like clinical trials regarding vaccines and new drugs, and yet managing to comply with ethical principles. And we had to promote public engagement and to work closely with communities. Some of these challenges will be addressed in this panel. Our speakers come from different regions in the world, have different backgrounds, but all of them have been engaged in innovative research during the pandemic. Thank you very much for sharing your experiences with us. Our plenary speaker is Dr. John Amosi, who is a senior lecturer at the Nkrumah University of Science and Technology in Ghana, where he is the head of the Global Health Department of the School of Public Health. He will speak about why we need research capabilities in place in every healthcare setting if we are to prevent the next pandemic. Dr. John, please. Thank you.
Good morning, everyone. There's no response. Let's try again. Good morning. Yeah, so we've all been coffeeed up, definitely expecting a robust response. Well, I'll just go straight to the point. Thank you very much for having me here. I could spend the 15 minutes I have just acknowledging people, so I'll be wiser than that. I'll just go straight to my slides. And I'm speaking on why we need research capabilities in place in every healthcare setting if we want to prevent the next pandemic. So this presupposes that we believe there'll be a next pandemic. I think it goes without saying, all of us in the room are scientists in one way or the other, and we have come to a firm conclusion that there will be another pandemic. What, when, where, we do not know, but there will be. And it's good that we have this firmly printed on our minds. And of course, the question is, what will be the outcome of that pandemic? So we all know from history, from the Spanish flu, which was the worst ever, 50 million plus deaths, essentially more than 1/3 of the world getting infected with that disease. We like to think COVID has been terrible. Well, it's been terrible in its own right because of the overall impact, but if you look at it in terms of number of spread of infections and mortality, then it would essentially pale in comparison. So there's every indication that something worse could happen. And again, I re-reference COVID. It's so proximal to us. We're still living it in one way, shape or form. I had an interesting conversation with the very nice lady who picked me up from the airport last night, and she was telling me of her personal COVID experience, a really harrowing experience. But the truth is, pandemics aside, non-communicable diseases also are increasing our need for healthcare. And of course, us public health people, global health research people, we don't like speaking much about, hospital care and that kind of stuff. And I really want to make the point that it's really a false dichotomy between medicine and public health or population level care. Of course, we teach this just so we can appreciate the different way of thinking at the individual level and then at the community or population level. But in reality, even at the hospital level, there is population level thinking, and it's very important for us to appreciate this. So we also are facing all kinds of challenges globally, which are causes us to interface more with healthcare. I mean, think about AMR, especially antimicrobial resistance, and think about the issues around rising food insecurity in relation to climate change. And now we're trying to bring a One Health lens to climate change because of its implications. So all these are pointing to the fact that building a culture of research is important. And I want to focus especially on the need for research in healthcare settings and what this means, especially for our chances of surviving the next pandemic. There is no guarantee that we would actually survive. So far, we survived. The impact has been stark, but there's every evidence that there could be something that could literally wipe out at least us human beings. We like to think life on the planet is just us human beings, but it's a lot more than that. But there is every chance that there could be something that could do this. At a point, some of us thought that COVID was it. And I keep saying, I used to wake up at night, sometimes just sit on my bed and think, oh, this is it. The next couple of months, there'll be nobody on the planet, maybe, but it didn't happen. So we've got a couple of lessons that we can learn from the West African Ebola outbreak, which I'll invoke a few of those. COVID, we all know this. And then more recently in Ghana, we had the Marburg outbreak. It was a scare because it could have turned into something else. But thankfully, there were 3 deaths and no other infections. This is what we know, but together as my team, we're going to be investigating that via a seroprevalence study and a bunch of other studies. So we'll see what we come out of that. But it just tells you that these things can be very costly. And one thing that we were very concerned about in Ghana was the possibility of the country being shut down because of Marburg. And I know the authorities were so concerned about this. And when some of us researchers got into the fray, they were afraid that us researchers were going to find something and then mess up everything, and then the international community would say Ghana is closed down for travel, no more travel to Ghana, and so on. So they were quite apprehensive of some of us researchers. But we cannot do without research because it really is our key to collective survival. The way we live today, especially how communal we are, communal in the global sense. I mean, I arrived in Cape Town last night, coming all the way from Alberta, Canada, where I was doing something else. And it's a long distance away, but I'm here in just a few hours, carrying everything with me, whatever everything could mean, and being with all of you. And this previously wasn't so. So just our ability to move around, and that's not going to change. I was going to say, modifying the speed with which we move across the world may not be an option on the table, but it perhaps would be one of the greatest measures to reduce our collective risk of any pandemic. But it's not an option on the table, so it means we really need research to find better ways of doing this. But what does it mean to enable research capacity? There's this definition that we could try to develop sustainable infrastructure, know-how, and skills to enable individuals and organizations perform high quality research. And let's get into it a bit. There's this statement, we see only what we know. What this means is if you don't go looking, you will not find anything. And if you go looking, you'll find something. Of course, we can't go looking all the time, but we have to have an eye so that when something pops up, we can see it. There's a saying in my local language, which translates into English, that if you go looking under the eye of a corpse, you will find a ghost. So if you go looking for stuff, you will find. And taking a small digression, this is one of the reasons why talk about multiplex diagnostics in peripheral health facilities is a bit tricky, because if you go looking for things, you'll find all kinds of things. And then what do you do if you can't treat? That's a different subject. But the key here is being able to do proper case identification and really increasing the sense of alertness of healthcare workers so that they can have a high sense of acuity and believe that there must be something, there's more to this, let me look into it. And this is what happened with the Marburg outbreak in Ghana. I was fortunate to investigate that together with my colleagues, Tony, Joe, Melvin. I think Melvin and Tony are in the room. We went down to where that outbreak happened. We had a chat with the district health management team, had a chat with the doctor who took care of the case, and looked through the folder. And it was that doctor's sense of, high sense of suspicion that, well, this could be a hemorrhagic fever. We need to look into this, but it could have been missed very, very easily. But there's another twist to that, and I'll come to that very shortly. So the key was this early clinician identification. If he had not been, so sharp to think there was more to this and activate that system of sample taking and investigation, it would have been missed entirely. There were some misses though, because this fellow, after he died, his body was taken all the way to the northern part of Ghana before the results came in. It was after the results came in that we realized that, oopsie, not very good. And of course, there was another case that broke out in the north, but thankfully it didn't go further than that because they managed to contain it there. Quite the opposite of Ebola in West Africa, where it took a long time before anyone thought there must be something wrong here. So that calls into question the training that we have and that ability to think far and to understand what might be going on. And just realizing that these diseases can pop up anywhere. They can pop up in an urban area, they can pop up in a rural area. So the ability to embed research in healthcare settings really must be at all levels. And this is why we have this topic. It's not just about having it in the tertiary facilities where you have, all the doctors and the nurses and everyone and, doing their thing, the pharmacists, but it must really be something that is inculcated into the training and also practiced even at the lowest levels. And this is why my friend, Joe Bonney, coined this term, the golden space. And this golden space is essentially that space, that interface between research and healthcare, or research and clinical care, to be more precise. There's always this separation between this is healthcare and this is research. And especially in LMICs, we have a lot of this where there's a lot of pushback when trying to research within the space of routine healthcare delivery, saying research is a distraction. We need to focus on the health of the patients. We must not distract them with research or put strain or stress on them because it's research. Even in outbreak situations, we have this kind of talk that, oh, no, you researchers, please step aside. We're trying to contain an outbreak of what you may not even know. So we really need to facilitate this golden space where this false dichotomy between this is the research, this is the healthcare is taken care of. And this is, again, different levels of healthcare facilities. And this is the example of Ghana. You have these tertiary level, but majority of the facilities are at the level 1 and level 2. So if you focus your efforts only at the top there, you will really be missing most of what you could otherwise catch early. Then this culture of research needs to go beyond that. These are a couple of slides from Sir Peter Horby, who most of you know well. And this just shows the 2009 influenza epidemic, where we had anticipated a number of cases. And then the actual research that was conducted was very little. And this is really what you want. And this is more or less what happened with COVID in the UK, where a lot more research was conducted very early. And of course, we saw what this meant for the results that came out of a trial like Recovery, and the impact it has had all over the world. The findings from that study just tells you that if you have a system where the research is embedded in the healthcare, it brings results, and results that go beyond the benefit to a single country and can really be extended all over the world. I like to say that I'm longing for a day when in our wards in LMICs, or shall I say in Ghana, we will have people being randomized to different kinds of studies as a part of just routine healthcare. So when you enter the ward, you see on the board, oh, this person is in that trial, there's in that trial, but it will take some time, but we really want to get there. So the capabilities must focus on the case definition, being able to see something, suspect that it could be A, B, C, or D, and activate the necessary processes, being able to take the right samples and handle them right. Now, this is very important because we had a problem with the Marburg outbreak in Ghana, where initially it was thought that there were 2 cases emerging at the same facility. The history didn't quite make sense. We had a high suspicion it could be a contamination. Indeed, it turned out that it was a sample contamination. But that really was a bit of a problem, and so it was never really announced openly. But the truth is that it was a sample contamination. So it just tells you that being able to handle the sample, take the samples right, handle them right is so important. Otherwise, you can end up with a scare which could blow things out of proportion. And it turns out that the origin of the Marburg was not even the region where the person fell ill. And there was a delay in finding this out, all because of the sample contamination, because of 2 cases that we thought had emerged in the same place. But I can tell that story a bit later. Some of the research capacities that are relatively easy to hand down or to process through the system are online courses. Now, with internet largely available even in remote parts of LMICs, we can do this. Pre-course reading materials, engaging in in-person courses, work groups, and presentations. These are easy research capacity building skills which we can have across LMICs as part of routine training. And the examples of the TGHN and ALERT are very clear. The sheer numbers of people who have been trained and the impact this has made in being able to conduct research during epidemics or pandemics is so clear. So it really does work. But it goes beyond that. We need to bring the governments closer. There needs to be that engagement so that they recognize that research has a strong role to play. And I was very pleased. I managed to sit with the one in charge of pandemics at the Ghana Health Service, sat with him at the ASTMH in Seattle a couple of weeks ago, and convinced him that we need to look into this Marburg thing. We need to do more. And I was pleased that at the end of the day, when I went back to my room, he sent me a message, said, I think we must do more work together. I said, yeah, that's it. He's getting it. But it takes engagement for the government people to realize that research needs to be embedded. But there's a caveat there. The independence of research is so critical. I am so wary of governments controlling research or shall I say, determining what research is conducted and what is not. And this happens in some LMICs. I know some countries in sub-Saharan Africa where researchers cannot apply for a grant unless they have clearance from the ministry. This is wrong. And we need to address these kinds of things. Independence is necessary. And then ultimately, you want that research to be moved into policy. And there's a whole science around a translation to policy. I see my time is up and I have just 2 more slides. Okay. So these are some of the challenges. Some of you may have seen this slide. I've shown it before. Just the ethical clearance delays. When there is an outbreak, the focus is not on research, but we need to find a way of getting the ethics done. The implementation and the training. How do you implement research during a pandemic? There are a lot of material on this now. We know how to do this, but it's not that easy because it's the same people who are taking care of patients who are also doing the research. The politics, we can't do anything about it. We've just got to play the politics and not be naive and think that, oh, I'm not into politics. Well, once you are doing the research, especially during pandemics, then you are into politics one way or the other. And then there's the monitoring aspect of things, just keeping tabs on things. And I saw the nice presentation showing this real-time dashboards, that kind of stuff, really great. And the rest you can read for yourself. So what you want is really to move away from this, where there's a global health emergency, then you do the research and hopefully improve healthcare, to this, where you're already having your eye on the ball. And if for some reason it moves to global health emergency, then the research is already in there, and then it improves the healthcare, and then it also delivers products like drugs, vaccines, and diagnostics. And with that, I want to say thank you, especially to my team, the group Global Health and Infectious Diseases is just a representation of a few, and I could not do this without such a wonderful team. So thank you very much.
Thank you, John, for such a wonderful talk. And I will ask you for keep your questions to the end because we are a little bit late. And so we'll do the debate at the end, okay? So our next speaker is Dr. Julio Canario, who is the Director of Ethics from the Dominican Republic. And he will speak about strengthening research ethics, governance, and regulatory oversight in Central America and the Dominican Republic in response to the COVID-19 pandemic, a qualitative study. Please, Julio.
Hi to you all. Cristiani, you know how amazing this conference is. Actually, I forgot to review the soccer, the World Cup games, last night. I don't know what happened. Yeah, I mean, I believe that we had a lot of fun last night. Thank you to the organizers. It was a very beautiful surprise. I always have this dilemma between Argentina and Brazil. So, Fernando. We shouldn't forget about COVID-19. I mean, COVID-19 unlocked Pandora's box with uncovered social inequalities, uncovered economical and issues, and it affects the life of all of us. COVID-19 is a humanitarian crisis that we should never forget. We should learn from previous experiences. Also, I remember that WHO launched this document with asking for a coordinated global agenda. And after a few months, they launched a call for proposals to address the ethics of preparedness response in research public health emergencies in general, and specifically in response to the COVID-19 pandemic. I'm going to talk about how we address this question and how we do it in a collaborative manner. A group of people got together and we discussed about how we can approach this question to describe the current state of the research ethics governance and the regulation in the Central America and the Caribbean. In the Caribbean, we focus on the Dominican Republic, and to develop at the end a policy brief. The background. Several years after this, we were writing about cholera disease in Haiti, in the Hispaniola island. We applied to be present at the Global Forum in Bioethics in Research. That's how we got to know people from Peru. Rosana Lescano, she's not here, but Hugo, are you here? Hugo from Peru can tell us, you can ask about Rosana Lescano, which is well-renowned bioethicist in our region. And we have been funded by Wellcome Trust also to develop some of the research that we have been doing in these countries. We got to know the network of research ethics community in Peru. Roxana connected us with Jacqueline Arger, myself, and Roxana and myself. We have this idea to found like a network in Central America, only including those at the government institutions with research ethics committee. And we formed that network. And then Jacqueline told me about Trudy. And we began working with them, with Reddy, with Bonnie, with Helen. And now we were able to publish many papers together. And that's how we were able to have this great team and to respond in a timely manner to this call for proposals. So we have these researchers. They were not only researchers, they were specialists in ethics. They were part of their governments in each country. Some of them were not. We have also people based more in communities, community-based organizations. And we have also outward advisors. It is important to find them, to find your giants, okay? So I mean, this is for the youngest people in this scenario. So we really were able to play with research methods. We were not thinking just on science, on design behind this. We were trying to make an action-based research. We were not worried about the science. It is important, it's the basis of it. But we need to get good science, we need good ethics, we need governance. And that's how we identify our partners. We map all the stakeholders in the region. I would say we need to talk about how we overcome the challenges. We have only 4 months to deliver results, but ethics review for this project lasts almost 4 months. So you might think why this is possible. We are not talking about a clinical trial, but somehow in our ethics committee, when they see that they are the subjects, something changes. We did a regional webinar. We have some participative events, workshops, and then we could deliver a draft of the policy brief. A roundtable to discuss with the stakeholders the results of the policy brief, and then we have all the dissemination activities. Today we have a publication that's being approved. Those are the kind of topics that we cover during this work, just for you to see how was the representation of the countries and the participants, the result that we have, and some of the findings. We found that the countries are at different stages in their development of a governance structure. You have countries with no policy at all, no law, and have others with very strict laws, regulations. Some of them have a more established health system and governance for research. And before COVID, and they were very able to reorganize and prepare for the pandemic. We identify many issues that we don't have the time to talk about all of them. This is just a snapshot of the research we had, and we want you to have access to our publication because we identify issues such as not having any ethics review. And the collaborative process and practices for research and ethics review are almost non-existent. We have issues about collaboration within our own institutions and between countries in our region. And public and community engagement plans and activities linked to health research policy making are missing. So basically, we are now asking our citizens to discuss about ethics, research ethics. So just to show you some of the topics that we mentioned in our policy brief. To promote the importance of health research. This is so important in our countries, as our previous speaker mentioned. To implement ethical research principles as a key element to safeguard human dignity and the right of participants. To adequate operational procedures for ethics review in response to emergencies and disease outbreaks. To strengthen mechanism for citizen participation And finally, to increase the level of scientific collaboration within these countries. So thank you for all of you, and I'm looking forward to discuss and have any question. Thank you.
Thank you, Julio, for sharing your experience and bringing such relevant questions. And our next speaker will be Dr. Sylvie Kwedi Nona from the University of Yaoundé, Cameroon. She will present the work Research Training Needs in Sub-Saharan Africa to help ensure adequate preparation for response to disease outbreaks. Sylvie.
Thank you very much. So I will be talking about the needs. What is it that we actually need to do research so that we can be prepared for disease outbreaks, just like the one we just went through with the COVID-19 pandemic. This study was conducted as part of the work that is done by the ALERT Consortium. ALERT is the African Coalition for Epidemic Research, Response and Training. This consortium brings together a number of countries in order to identify capacity needs to conduct high quality research waiting for epidemics. And it just happened that in the middle of this project, COVID-19 happened. So we ended up having hands-on experience in terms of what we had proposed and what we got funding for. The analysis had several objectives. One of them was to identify the attributes and competencies that are necessary to conduct this high quality research that we talked about in terms of conceiving it, engaging the community, actually conducting it, analyzing, and publishing the work. Another objective was to identify the research capacity, development opportunities in alert countries, also to determine the key knowledge and skill gaps that are present to undertake this research. The data was collected through online and paper questionnaire. The link or the paper questionnaire were distributed in English and French to participants of in alert countries. That are about 21 institutions altogether that received the questionnaire. The analysis itself was based on the TDR Global Competency Framework for Clinical Research. That was the framework, and the questions were based on 4 different themes: scientific thinking, ethics, quality and risk management, study and site management, and research operations. Okay. In terms of the distribution of respondents, the majority of respondents were from Cameroon, 36%, followed by Senegal, Uganda, and some other African countries such as Ivory Coast, Ghana, Kenya, and the Central African Republic and Tanzania. It's probably not a surprise that most of the respondents were clinicians. There was students. I was actually also happy to see that the operation size of research was represented, because we had project managers, we had the laboratory staff, we had quality assurance and data managers that responded to the survey. I'm not sure how clear this is. Basically, the idea was to ask the amount of experience that our respondents had in terms of scientific, the first one was in terms of scientific conceptualization, who actually comes up with the idea of research and puts it together. What we want to see in this heat map is green. We don't really want to see red. We want to see green. So the redder the cell, the worse it is in terms of experience. So you can see here that in terms of experience in scientific conceptualization, most of the respondents said that they had minimal or they were just capable of doing the tasks. The ones that are experienced or highly experienced were limited, with few in our respondent pool. In terms of experience with general operations and management, again, you find those that have minimal experience and are just capable. The highly experienced or experienced were not as many. Oh goodness. It's quite small. In terms of community and public engagement, it's the same trend here. Minimal experience and just capable. The highly experienced or even experience less. In terms of data collection and data management, same thing. In terms of dissemination of research results, but for those particular tasks, you do have more of the capable and experienced, but again, the highly experienced were limited. We also asked about the challenges, their perception in terms of challenges, and many of the challenges that were identified had to do with administrative work. And I think that this theme has actually been recurrent since yesterday. There has been quite a bit of discussion in terms of research management. I'm from the University of Yaoundé 1, and which is the largest, oldest university in Cameroon, and if I'm not mistaken, in Central Africa, please correct me if I'm wrong. And at the University of Yaoundé 1, we don't have a dedicated research management office, which is an issue because we do quite a bit of research work. So that's definitely a challenge that was perceived. International relations, international collaborations were also identified as challenges. Funding, international funding, or even local funding is a challenge. So what can we conclude? We saw from the data that we collected that the participants were quite young in terms of their age, in terms of the years of experience they had in the field of research was less than 5 years in general, which kind of makes a lot of sense because I would say that it's probably in the past couple of decades that the research has really been booming in the countries where these data was collected. We also found that many of our respondents worked in public institutions, which is not very surprising given the landscape of how research is conducted in sub-Saharan Africa. Most of the respondents really had the task experience in the implementation tasks, just basically collecting the data, but not in conceiving and not really in analyzing and a little bit in disseminating, which is the problem. We've all heard about this phenomenon of helicopter science. This data is actually a real example of what it is, where the science kind of swoops in, collects the data, and then swoops out with the result, which is not what we want. So we really need to do better so that in the next pandemic, we can be prepared. Thank you very much.
Thank you very much, Sylvie. That was great. You brought many challenges that we shall discuss. And our next speaker will be Fernando Boza, who is a senior researcher at the National Institute of Infectious Disease of the Oswaldo Cruz Foundation, my colleague and friend. So, Fernando, go ahead.
Good morning. It's a great pleasure to be here, especially it's a great pleasure to be part of this incredible community. And in this next 8 minutes, I will try to show you a different way to do research, to measure impact, to engage community around the response of a pandemic, but also how to do research in this context. Very few examples of successful interventions to mitigate the impact of pandemic in poor communities were demonstrated during these last 2 years. What I will try to show you is how to integrate social support, surveillance, healthcare, and communication in response to the pandemic, and especially in these neglected regions. How to incorporate rapidly new technologies in this response. How to promote adhesion to vaccination, and how to generate knowledge that has impact for the community during the course of a crisis. This is a combination of actions, interventions, research that we start work in June of 2020 with actions of response to epidemic, in August, massive vaccination, and during all this process, doing clinical research. This intervention occurred in this largest complex of favelas in Rio de Janeiro, probably the largest complex of favelas from the South America. 16 favelas with 140,000 people living in this poor community, but especially divided by 3 gangs in a violent environment. But the first point about innovation is innovation in organization. What is new? The new is how to work academia, how to work with NGOs, with the public sector, and supported by private funders with the central view of the community, and especially how to work these people together in a more horizontal way. The intervention involved surveillance. We created a testing center inside the favelas. We developed mobile technology using AI to case detection and contact detection. We consolidate epidemiological information. We implement telehealth and social support. We create a home isolation program for people positive in this poor community, giving social support, food, house cleaning, and a strong access of communication engagement, but especially in this adverse scenario that was Brazil at the beginning of the pandemic, with the government producing fake news that was communicated with good data, good information to generate trust, and especially working together with the priorities of the community. We did more than 45,000 tests inside this community. We did more than 15,000 telehealth consultations, and especially 1/3 was psychology, mental health consultation. We developed the safe home isolation that impact 1,200 families. And especially the communication side was a new strategy, at least for us as health workers and researchers. We developed this character, Dr. Anna, to answer the questions that we listen from the community. Also, we produce 45 newsletters with epidemiological data, interviews related to these actions. And we had a huge impact in the general media with more than 500 actions in general media, international and national. And especially we work with the local influencers, young people. This guy, Rafael, produced a video for the vaccination program with more than 2 million views in the state of São Paulo after asked to use this piece. And we measure impact. We did difference in difference analysis where we can demonstrate that the intervention were able to reduce the rates of death per week in 48%. Then we vaccinated. We vaccinated. We mobilized the community, and we did a strong campaign to engage the community around the vaccination, including different strategies. But this was coordinated with the community and with a strong preparation, and together we developed a research program. We vaccinated 36,000 people in 4 days. We vaccinated with the first dose all the adults of the community. Together, we developed a negative test design for vaccine effectiveness, and we include people in a cohort. The test negative design was published 3 months after, and we include almost 6,000 people in the cohort. Now we are following the cohort. We are in the 3rd wave of the cohort, and we have these studies of vaccine effectiveness, all the sample from the community we genotype. We are working in programs of mental health to evaluate how telehealth can be really a strategy for telehealth, for mental health in these communities. We developed also a long COVID cohort, and now we are looking for other infections. Then, in conclusion, it's possible to do effective interventions can be done in the community. We can, the population accepted very well these new technologies, especially mobile technologies, and especially the innovation at point of view of organization is critical for mobilize the society and to have effective communication and engagement strategies are critical also to have impact in this kind of intervention. Thank you very much.
Thank you very much, Fernando, for sharing this comprehensive experience. It's more than one researchers, a bunch of different studies and multi-component intervention. That's very interesting indeed. Our next speaker will be Dr. Marvinson Farrado, Research Project Manager in the Social Innovation in Health Initiative from the Philippines Hub. He will present the work using human-centered design approaches to develop innovative models for delivery of essential health services in 3 Philippine rural communities during the COVID-19 pandemic. Please, Dr. Matos. Thank you.
Hi, I would like to take this opportunity to thank the Global Network and thank you for the introduction. So mainly, this project was started because of the reductions in outpatient care attendance owing to lower demand. Because of COVID-19, not only direct effects of COVID-19 were felt, but also indirect effects on other neglected essential health services. So this was caused by both supply side and demand side problems. On the demand side, people cannot travel to the doctor, they don't have finances to support their medication. On the demand side, the human resources were actually shifted away from essential health services and going to responding to COVID-19. So these two sides have affected essential health services. And so in our project, we had two main phases. In our first phase, we tried to figure out what were the preferences, what were the values and the behaviors of people consuming and delivering essential health services during the COVID-19 pandemic. This was done using key informant interviews, FGDs, and document reviews. Meanwhile, on the phase 2 of the program, using all the insights and ideas gathered from the phase 1, we tried to brainstorm and co-create with the community to find effective solutions or even document solutions that are already in the ground to be incorporated to the local health system. So as a brief background of what human-centered design is, human-centered design is an intersection between these three adjectives. Desirability, so what do the people or the end user desire from a given service, from a given product? Feasibility is how willing or how capable are the people implementing it? Does it have a policy framework or a legal framework? And viability, how sure are we to get funding when the intervention or innovation has been started? So these three mechanisms will help create a better human-centered design approach. So in our methods for phase 2, we have three main activities. The first is journey mapping. The next is World Cafe. And lastly, prioritization grid. So for journey mapping, we try to map starting from when the patient wants a service up to the time the patient has been satisfied with the service. So we map all the critical steps. We map all the touch points, meaning who are they interacting with, at what step, at how long do they interact, and the emotional state during those interactions. So what we get from those data is critical areas for improvement and avoiding silo mentality that, oh, they're just here for the consultation. What about the follow-up? So the main, followed by a World Cafe. World Cafe is generally, because of the identified pain points, we will now generate solutions or ideas to address those pain points. Finally, because we already have a list of interventions, we will now have a prioritization grid where the intersection of high value and high impact and high feasibility will be ranked for those interventions. So this is a sample table or form where the users answered for the journey mapping. And to give you a brief overview of what the cells in the table were. So for the rows, we have people involved, the duration, emotional state, negative 10 to positive 10, meaning high, very low satisfaction to a high satisfaction score, positive experiences on each phase of the activity, and pain points, meaning pain points, the dissatisfaction or the frustrations of the end users on a specific activity. It could be because of the process, because of the finances involved, or because of the lack of support on that specific process. And insights would be the overall learning from what you've mapped. Meanwhile, on the column part, we have three main parts: the before consultation, during consultation, and after consultation. So we are trying to map the whole experience of the patient to identify gaps and to identify key areas for improvement. So this is again another example of a patient journey map from they try to map the experience of a patient ongoing surgery. And as you can see, you can visually see at the emotional states where support or improvements are most needed. So at a glance, you know what to prioritize at this journey. After that, after all those information and pain points were identified, we then went to a World Cafe. So a World Cafe tries to simulate a coffee shop and a small group. And for each table, there's a specific pain point or discussion. So there will be around, the small groups will go around the tables and discuss pain points and add to the discussion. So because of the mixing of groups and pain points, they will now have the opportunity to improve or add upon the previous ideas. Because of those ideas, we will then prioritize them according to value to user and feasibility for the team. Because of how we set up our interaction, we actually invited patients, policymakers, and providers in a single session. So the patient has a voice and the provider has a voice, because through this patient-provider interaction, we will see how things will work in the real setting. So if you can see the upper rightmost corner would be the high value and the high feasible interventions, which are generally called no-brainers in this exercise. So because of this interaction, we managed to make a telemedicine primary health services referral pathway, which also contextualizes the needs of the patient in the interaction. Because what we found out is the patients are generally shy in using telemedicine and talking to the telehealth doctor on the other side. Meanwhile, on the provider side, the community health workers are shy in relaying or not confident in relaying their findings and their possible diagnosis to the doctor. So what we do is use the community health workers as telehealth referral or telefacilitators to facilitate the discussion. And because of this, we also made a format to help telepresenters on referring the doctors. So for the results and conclusion, most of the adaptations that we observed, even before the study started, was the community-led consolidated drug purchasing, informal teleconsultations using Facebook, WhatsApp, Viber, which are actually in need of more standardized approach, and expanded roles of BHWs and nurses, because most of the nurses were diverted to COVID-19 response. There were expansion of roles of our community health workers. So for challenges and recommendations, there's a restricted mobility to conduct on-site research. There's also premature engagement of stakeholders because they also got diverted to COVID-19 response, and scope creep. So scope creep is mainly based from the discussion of our funders that they want to add things to our study. So for closing, people naturally know how to improvise in trying to attain their needs and desires. It is up to the researcher to recognize these innovations and facilitate their integration into local health systems. Thank you very much.
Thank you very much, Dr. Fajardo. Our next speaker will be Dr. Farah Asif from the Scout Khanum Memorial Cancer Hospital and Research Center from Lahore, Pakistan. And she will talk about developing a policy statement and recommendations for Pakistan's ethics review framework in IRBs in support of public health and emergency preparedness and response.
Hoya Mora, and a good morning. I learned this greeting from a new friend in Cape Town. So I would like to thank everyone for having me here, and a special thanks to the Global Health Network. So as you know, I'm Farah Asif from Shaukat Khana Memorial Cancer Hospital and Research Center. And there I serve as Clinical Research Administrator, Head of Clinical Research Office, and Secretary to Institutional Review Board. And that reflects my interest in ethics review committees and ethics review framework in Pakistan. So I'll take you through the fast facts related to Pakistan, just to give you context of what we are talking about in the next few minutes. So Pakistan is a lower middle income country where 56 million people, they live below the line of poverty line. And the population is growing fast. That's another challenge. Pakistan faces a chronic state of underinvestment in health. And then we face many economic, geopolitical challenges. And Pakistan has been, unfortunately, home to natural disasters as well. And this year we have witnessed like the worst floods in the history of Pakistan, and 1/3 of the Pakistan was underwater. And we still wait for climate justice. So as I said, Pakistan is suffering from underinvestment in health. So as a result, we have a healthcare system which is mixed, complex, as well as fragmented. So our public healthcare system cannot meet the demand and the quality. And the private healthcare sector is providing 2/3 of the healthcare services. However, it is weakly regulated. So that's a challenge. But the good news is that over past 25 years, Pakistan has improved in key health indicators. However, we are still lagging behind our peer countries, peer LMICs. So it is heartening to see that the health research output is consistently increasing in Pakistan. In fact, in 2018, we witnessed a 21% rise in clinical research output in Pakistan. That was highest in the world. However, the quality and impact of this research is at times variable. And same goes for the research ethics review framework of Pakistan. So I'll take a few minutes to explain to you how research ethics review is organized in Pakistan. So in Pakistan, we have National Bioethics Committee, which is responsible, which is an official body to uphold ethical principles in all sectors of healthcare delivery, as well as in research. Research Ethics Committee of National Bioethics Committee is directly overseeing research ethics review in Pakistan. And then we have institutional review boards, which are situated within the institutes. So all the research studies, they need approval from the IRBs within their institutes. The research which involves international collaborations, or the research which is like national level projects, only those projects need review and approval by the national level research ethics committees. And clinical trials, they also need an additional approval, of course, from the regulatory body. So this is how we are organized like during non-public health emergencies time. And there are some some fundamental challenges when I talk about this research ethics review framework. So one challenge is that the research guidelines and regulations are lacking in some key aspects related to research. Secondly, the research ethics committees are not registered or not accredited by national level competent authority. That means that they continue to work according to their own structures and their own procedures. And lastly, there is no formal mechanism for IRBs to interact with each other, as well as to interact with the National Bioethics Committee. So they continue to work in silos. So during COVID-19 public health emergency, the National Bioethics Committee, they have established this very well needed ethics review framework. It primarily describes how COVID research would be reviewed in an expedited manner. However, as you can see from this, local IRBs are not part of this response. So that remains a challenge. So in the start of 2020, a group of multiple stakeholders from within Pakistan, they came together to systematically review the research ethics review system in Pakistan. And the objective was, so what we did was like an in-depth inquiry of local context and current structures and practices, and the way the NBC, REC, and local IRBs responded to the pressures of COVID-19. We were joined by our international community in the form of International Advisory Board, and we had the support from the Global Health Network, as well as GCP Alliance Europe, and Strategic Initiative of Developing Research Ethics Capacity, SITSA. So what we did was, we did a series of evidence gathering exercises. And first of all, we had a look how research ethics review framework has evolved during the COVID-19. And in this, we were supported by Dr. Jacqueline, Roxana, and Julio. So that's a player. We did a national level ethics workshop. And in this, we invited key stakeholders from within Pakistan to present situational summaries. And we gave a chance to IRBs, local IRBs, to share their experiences and the challenges. Then we did a scoping review of literature. The review examined the existing national literature in order to gain insight into the development of ethics review in Pakistan. We did a survey of IRBs, that was like capacity mapping of IRBs. So let's not focus on this busy slide. I'll make it easy for you. The problem statement is Pakistan nascent national ethics review system is barely 2 decades old, and while functional at national level, does not as yet have provincial counterparts as well as local research ethics committee or IRBs. The knowledge gaps that we have, there is dearth of published literature focused on research ethics. List of all IRBs in Pakistan is not publicly available, or it is not easy to find this information. There is no comprehensive empirical data to enable us to comment on the competencies of IRBs in Pakistan. And during PHEs, there is no formal mechanism of coordinated ethics review among diverse bodies which are involved in ethics review in Pakistan. So the challenges are NBC, REC lacks patronage, resources, and funding. So there is no mechanism to assess, survey, audit, register, or inspect IRBs at the national level. Most members of IRB lack formal training to implement their mandate. So IRBs do have variable and at times questionable practices. But these findings are not novel. We knew this already. Many studies have already reported this, but these studies have also called for an urgent action. However, there is no action so far that reveals that this area remains like a long-standing neglect. So with this, we propose some recommendations to develop harmonized ethics review system and strengthen governance structure, as well as develop synergies between IRBs. We need to have optimal training as per the needs of Pakistan, and we need to have proper mechanisms of having a coordinated ethics review during public health emergencies. So these are my contributors. I have been signaled that I need to stop here. So I'll just take 1 minute just to tell you that these recommendations are just recommendations. We can end here with only a paper that would lie on the cloud, or we can actually build on these recommendations and make the change happen. And we understand that we have a local responsibility to identify these challenges and address this, and we seek international support in that. And with that, I would end here. Thank you. Thank you so much.
Thank you very much, Dr. Farhat. And our last speaker will be Melody Sakala from Malawi, from the Malawi Liverpool Wellcome Clinical Research Program. And she will present the SCORE project, a COVID-19 remote triage, surveillance, and community engagement project in Malawi.
I'm short. I'm just trying to make sure I'm able to see. Thank you. Good morning, everyone. It's such an honor to present some of the initiatives that we did in Malawi to support the Ministry of Health in fighting COVID-19 pandemic. So my name is Melody, and I'm with Malawi Liverpool Wellcome in Blantyre, Malawi. We are all aware how COVID-19 exposed the weak health systems as well as the capacity for most of our ministries to be able not only to respond, but also to prevent pandemics such as COVID-19. So that was particularly in low and middle income countries. So to be specific, in Malawi, there was a lot of disruption in accessing essential health services, and there were also high demand for clinical services, but also we saw a lot of challenges in terms of medical suppliers, as well as shortages of essential health workforce. So what we did was to come up, sorry. Okay, sorry. So what we did to support the Ministry of Health was to come up with a few concepts. So we drew a lot of lessons as well as ideas from previous countries that have gone through outbreaks. For example, in Africa, we had the Ebola pandemic, as well as beyond Africa, where we had the Zika situation. So it was quite a really very, I would say, a very long and lengthy consultation process. So we tried to come up with different partners to think around how best do we support communities who were struggling at that time to be able to respond. And also just looking at how a lot of rumors were also coming in to, sort of disrupt a lot of initiatives that the government has put in place. So what we saw was that we had to actually come up with a model that was very engaging. So what we did was to work with the communities. So we came up with 3 components. So the first one was working with communities to sort of support village-led strategies. For example, we targeted the most influential leaders in the community, for example, the chiefs and also the religious leaders. And then we also tried to decentralize the triage system that was particularly managed at national level. And also we came up with an idea to engage the communities themselves to be able to document some of the data that would be used at district level within their communities. So for the community engagement setup, what we did was to engage communities in Blantyre. So we had 4 communities working with health workers and also youth volunteers. So we trained local leaders to come up with their own COVID-19 containment packages. And we also identified together with them youth volunteers who were able to support and also implement those packages. And then we went ahead to facilitate the process of making sure these youth volunteers that we identified were able to support the initiatives that were coming up. So this was very engaging. So this slide basically shows some of the community leaders during trainings, and also some of the community youth volunteers in communities trying to engage with different individuals within their communities. So for the remote triage, what we tried to do was to decentralize the national call toll-free for COVID-19. So what we did was to come up with a one-stop shop where we made sure we had credible information for everybody to access, and also ensure that we had evidence-based, as well as providing the required documented guidelines for containing COVID-19. So what did we learn from this pilot? So we conducted a cross-sectional study, mostly using both quantitative as well as qualitative indicators, just trying to see how the initiatives has been received in the community, where were the gaps, and also what were the lessons. So we came up with a survey. We talked with all different stakeholders involved. We also did a focus group discussion, as well as interviews in different parts of the communities. So this is just to show some of the outcomes from the study. So as you can see from the graph to your left, we had a median of about 77 calls from within some parts of the community. So just to say, this is a bit an outdated data. So I think it was from the first few months of our initiative. And then most of the calls were really cross-cutting. So we'd have calls in regards to preventive measures, and also people calling just to get information about the signs and symptoms, and also vaccination. So we quite reached about a quite huge number of households, and also we documented also linkages within the communities, from the community volunteers to the health surveillance assistance within the communities, and also documented the number of people who were vaccinated. So this is just to show also some of the perceived challenges. So, some of the perceived benefits. So what we can see here was the trust that was built coming from the approach that we had used, and also the partnership that we were able to involve them to be part and parcel of the discussions. And also people were able to access reliable data to be able to respond to health services and health needs within. So some of the challenges with this initiative really was, there was a large geographical areas that we were supposed to cover, and also a lack of enough resources, for example, supplies for the healthcare workers, and also difficulties, in terms of some of the beliefs that were there in related to COVID-19 vaccines, and also the healthcare workers were unavailable because most of them were overwhelmed with the workload that they had at that particular time. So we tried to really have, to engage a lot of partners, for example, Red Cross, which came in to also support the initiatives. So some of the lessons we drew from this, I think communities really do have vast knowledge. They know what works, and they know what wouldn't work in their defined geographical communities. They also know the social dynamics within their geographies. So for us, it was also a learning process. Just also to say that engagement really is about balancing the power, between researchers and also the communities. So there's really need to, have a two-way dialogue to be able also to listen to the ideas and concepts So lastly, I would really recommend if we not only capacitate, but also incentivize communities to be able to be part and parcel of their own decision making when it comes to their own health, and also to be able to own their initiatives. So the next step, so currently we are just doing a deep dive analysis of the intervention, and also having ongoing conversation with the Minister of Health for the next step. Thank you. I would just like to thank all our partners. Thank you.
Well, thank you very much, Melody. This panel was wonderful, and I will refrain from doing specific comments, of course, because the talks were very rich. I will just make two brief comments, and we can go to some questions. Dr. John Amwazi said in his speech that we shall build research capacity and embrace the culture of research, because research is key to our survival. And he used a very interesting soccer metaphor, that is, we have to keep the eye already in the ball. And our speakers have given many interesting examples of why we should do that and how we could do that. Some of them spoke about ethical regulation systems, how they should be strong and put in place continuously, so that in time of crisis they should respond, but they have to respond in a permanent way, also in peace times, as one of them have said. Others have brought examples of community engagement, very innovative experiences that were really relevant to give appropriate response to the pandemic. And others approached, I think most of them, the importance of research training in all capacities in every healthcare setting. So we are happy to get some questions to our panelists. So we have many people here, please. And if you can come to the front to speak. Yeah.
Thank you. My name is Eric Okek from Uganda. My question goes to Dr. John. You raise an issue which, in my opinion, is very contentious. Having health workers get involved in research. From experience, if health workers test their apple of research, they never want to go back to that operating theater. They never want to go back to that ward round, because seems the bread is better buttered on the side of research. My question is, how do we strike a balance between research and offering quality clinical service in an epidemic? My last question goes to Dr. Jihanum from Pakistan. In Africa, institutional review boards and ethics committee are among the most bureaucratic, most annoying committees that I've known. Either the quorum will not be met on the meeting day, or in event that the meeting happens, they will have a long list of requirements that you can only fulfill in the next generation. My question is, what is the turnaround time in Pakistan for a study to be approved by the ethics committee? Can we learn and benchmark from what is happening in Pakistan for our African colleagues who belong to the different ethics and research committees? Thank you.
Thank you for that question, Eric. I like your expression that the bread is better buttered on the side of the research. Well, it's a valid question, not only because of the remuneration issue, but the impact. There has been evidence that when research is sometimes integrated into routine clinical care, it does impact on care negatively, because the clinical staff or the care staff are more interested in meeting the milestones for the research and getting they are due than they may be on the rest of the patients who may not be involved in research. And this poses a problem. What this means is that rather than just inserting the research into routine clinical care, it must be embedded into the system. So a systems-wide approach is what is needed. And the incentive must be an incentive which is spread across the entire facility. So what that happens is that facilities should have some incentive for engaging in research, say X number of persons recruited in the facility, then the facility gets some kind of either discount or some kind of motivation from a more central source. There are different approaches to doing this. But ultimately, what you want is for the system to be friendly towards research. You don't need to have a separate system of data collection for the research and then a separate system for the routine clinical care. But if you're able to piggyback the collection of both the bio data as well as the clinical data, the physiological indices, the biochemical indices, all within that EMS system, then it's a lot easier. And also, if you're able to link this directly to improvements in quality of the care, then it's useful. We have such an experience with our ICU registry in Ghana, which we're doing together with the Moru Group and the Critical Care, Africa Critical Care Asia, where now this is feeding back and improving healthcare in the ER and in the ICU. And now this dashboard, which is our research dashboard, is a dashboard that's being used directly to improve clinical care. So it must be done with a systems-wide approach with the ultimate objective of improving healthcare and incentives going to the wider hospital than to single individuals in the facilities.
I think there's a question to Dr. Farah. Okay, am I audible? So thank you for the question. So you've rightly said that at times, and there is literature where IRBs are considered difficult, annoying, and overstepping their boundaries, and it happens. I hope that I'm not that annoying, but there are times when I end up having my coffee alone in the cafeteria, being a person sitting on the IRB. So, so you asked about the turnaround time. So I'm talking about my institution. So we do have a two-step review system. And the first step is scientific review, and we meet every month. And once the study has secured their scientific approval, it can go to the IRB, and we also meet every month. So if you secured your first approval in one go, you have a brighter chance that you will secure your second approval or ethics approval in the second month. But I would like to reiterate here that at times the time is needed. Even the investigators need some time. And we have like very interesting observations while we are trying, and all the burden is on IRBs to expedite the review process, and they are being criticized for that. But believe me, investigators do take longer times in responding to IRBs. And during our COVID experience, it was a lot of pressure on us to have like the review within first 72 hours of receiving our research study. But believe me, investigators took much longer to respond back to them, to the IRB. So that's like another thing. So, and you have asked about the benchmarking. So that's a very important area. And that's something I'm myself is looking an answer to this, how to benchmark the IRBs, because, and I believe the ability is limited because we do not have like authentic benchmarks or agreed upon benchmarks yet. So, and I've been searching the answer for this, because if we benchmark the IRBs, I believe that we will have more trust from our researcher community. So I'm a researcher as well as I'm part of the IRB, custodian of the IRB in my institution. So it's what we believe is like a more collaborative approach in like setting up IRB and running it. So what we do in our institution, we do help investigators and we give them some very good tips how to prepare for IRB and how to respond to the critiques of IRB. So this is like a friendly environment, and what we encourage the researchers as well, we encourage them to serve on the IRBs so they can have this perspective from other side of the table. So I hope that answer your question. Thank you.
Thank you. We can have only one more question. I'm sorry about that because we run out of time. So one more question. You over there? Yes, you can. Like here. And we can keep talking with the panelists during lunch. I'm sorry.
Hello, I'm Farah Nabil from the University of Zaragoza. I have a couple of questions for Fernando. First of all, congratulations on the excellent and impactful work. So I was wondering, in the pre-research phase, did you encounter any difficulties encountering epidemiological and socio-demographic data that was up to date about the favelas population? And if yes, did you have to do any pre-research field work such as socio-demographic population characterization in order to be able to design the research in a context-specific way? And my second question is, how did you ensure that the study population as a relatively vulnerable population was not exploited in the context of the study? Thank you.
Thank you for the question. The key aspect of this intervention, at my point of view, is really to work with the local NGOs that work in the favela for several years. This is a very important point in Brazil, that especially these communities has a lot of knowledge and power that frequently we not assess. Then, for example, this big NGO that works in Favela da Maré, that is originally an NGO for education, they for this last at least 10 years, they are working, collecting data, demography, collecting data, social aspects, economic aspects of the community. And in 2013, they did a census of the community, including several information related to demography, to relate to social aspects and economic aspects. Then at the end, this knowledge is there. The point is how to engage also the NGOs in research and in the response during the crisis. I think that this is a very important aspect to consider. Even in high-income countries where we have powerful NGOs, especially, for example, I were discussing with the people from France. For example, the French government not use for example, HIV NGOs that were so important during the HIV epidemic to engage people in vaccination, to engage people also in other aspects. Then I think that we need to work in a different way, but also to work in a more horizontal way to that NGOs, the community, governments, and researchers be together.
Thank you very much. I'm sorry we can get more questions, but because we are having some side meetings during lunch, but we can come and talk to the panelists. They will surely be available to exchange ideas and to talk to you. Thank you very much. This was a wonderful session.
Thank you. Thank you very much. That was just such a fantastic chairmanship and panel. That was incredible. We didn't want to limit the time. So we got a little bit into lunch, but I'm sure that's fine. Just everybody's really practiced now. Can we be ready to start dead on the half an hour after lunch, so 1:30. We've got a really strong data science section. There were so many questions on data over the last day and a half. So come back for the data science question. And then we've got the grand finale of the final session around women in health research. So please be seated at 1:30. And for those coming to the ecosystem meeting with the Bill and Melinda Gates Foundation team, everybody knows who they are. It's in room 4C. So and lunch is served in there. So see you all there now. Thank you everybody for a really brilliant morning. Well done.
Good afternoon. Okay. Good afternoon, everyone, and welcome to this first afternoon session. My name is Amel Guila. I'm a Senior Program Officer, Data Science Ecosystem at the Bill and Melinda Gates Foundation. And it's my pleasure to be chairing this first session for this afternoon. So we heard a lot, data, data, data. Here we are. This is the data science session. And we're going to be following on the theme of this conference about sharing approaches and methods to better support health research in every healthcare setting, with a focus on data and how data could contribute to these objectives. And we will be covering during these sessions data from different perspectives and how using data could inform and guide evidence and policy on the ground. I'm pretty excited about this session, bringing different perspectives, different skill set, and people working at different angles of the research and health delivery ecosystem. So to kick us off, I'm going to invite my colleague Bilal Mateen, who is the Clinical Technology Lead, Data for Science and Health at the Wellcome Trust, to give some opening remarks. Bilal?
Afternoon all. Thank you, Amel. So what I want to do in the next few minutes is two things. First, reflect on what inequity in data science-related research means to me. And the second is share with you a little bit about why we're so excited about this recent grant that we've made to the Global Health Network, Latin America and the Caribbean. Glad I've got Trudy in my eye line. I'll be back for you, Trudy. Starting with that first one. What does inequity in data science related research mean to me? So those of you that have heard us, or myself, my colleagues from the Wellcome Trust, talk about our work, you'll have heard this line that we like to use. The nature of science is changing. It's becoming increasingly more computational. The opportunities afforded by using larger, more complicated data sets that require specialist software, hardware, analytical skills are becoming more evident day by day. And the trend that we've seen over the last decade is that these opportunities are becoming consolidated in a small number of institutions, often in high-income countries, which I'm sure you can all agree is profoundly problematic. And the example I like to use, it's a crude one, that demonstrates why I think it's so problematic, starts with a really simple question. How do you end up with a racist computer vision algorithm? Anyone in this room that has ever been part of a software development project will know that the first group that you test your alpha product on is yourself and your team. If you get to beta testing, it's your friends and your family. So how do you end up with a racist computer vision algorithm like Google did, like Twitter did, like so many research groups have? You have a team that's not representative of the community at large. It's not profound. We spend a lot of time thinking about and talking about how we need more representative data sets to address inequity in health research. I think that's necessary, but it's not sufficient because we have a more foundational problem. It's the fact that those opportunities aren't available to everyone to have a seat at the table where the research is being done. And that's how we end up with inequitable research. We need more people from more diverse backgrounds in the room where the research is happening and being a part of it. And that's what makes me so excited about the grant that we've made to the Global Health Network, Latin America and the Caribbean, because it's a very intentional commitment to the tune of about £8 million from the Wellcome Trust to try and make sure that Latin American voices are heard and have a seat at the table. And a large part of that award is going to be around data science related capacity building and capability strengthening. And I could wax lyrical about all the small things that we've done along the way that change how we made that grant. So the money isn't going via a single host organization, it's going directly to our LAC partners. But instead, what I want to do in the last 58 seconds that I have is say thank you to someone. And that one individual is Trudy Lang, because over the last year, she demonstrated what I can only describe as an almost pathological level of perseverance in, I want to say, a number of conversations I lost count of, telling us not only how we can do better as a funder, making sure that we understood what good looked like, but also helping us get to a place where we could make this grant by making a whole series of sacrifices herself. And we're here, the grant is made. And that's what I want you to take away, right? From that sort of reflections and from that little anecdote about Trudy, that the solutions to inequitable research, whether they are data-driven or not, is about individual actions. It's about people like Trudy, it's about people like all of you in this room going the extra mile to make sure you're using the right data set that is representative, that you are inviting in colleagues and local partners so that we can make sure their voices are heard, and taking that extra, let's say, year of your life to tell a funder how to do their job, right? Because we're willing to listen. I'm not going to take up any more of your time. We've got 6 incredible people on stage who I want to hand over to. So Amal, I'm going to give the microphone back to you. Thank you very much.
Thanks, Bilal. Bilal, you talked about equity and equitable use of data sets and how the skills needed evolve and how data evolve. Our plenary talk speaker is Professor Nikki Mulder, who is the head of computational biology division here at the University of Cape Town. She's the PI of the H3A BioNet and Pan-African Bioinformatics Network, and she's also the head of the Open Data Science platform. Nikki is going to talk about capacity building and building data science expertise and engagement in Africa to build local capacity skills. Nikki?
Okay, so thank you very much to the organizers for the invitation to speak here today. I've been really interested in hearing data come up so many times because that's what I do. So I'm going to talk about a number of things. I don't think it's probably not important to go back to the data needs and challenges, but I'll just highlight a few. And then I'm going to talk about 3 ways that we've been trying to address the capacity development in terms of data. And I'll talk firstly about H3A BioNet because that was really the pillar for how everything else kind of came about. And then the data science, a new consortium we have, and then how we've been working in the public health space. So if you think about the different data types for health, so you have the research space where you have the clinical data, you have demographic data, and then you generate some observations or some experiments, omics data, for example. Perhaps you bring in climate data, environmental data, and then in the health space, you also have routine data that's being collected all the time. And between these two, there's often a big disconnect between these two because access requirements for the different data sets are different. How they've been curated, how the data has been collected is often very different. And when you want to do data science and make novel discoveries, you have to do a lot of data linkages, you have to do a lot of data integration, and this is really, really tortuous. But that is absolutely required in order to actually to apply data science techniques and then make novel discoveries. So there are challenges in every single piece of these whatever I've got on the slide. So every piece of the data, the metadata, curation of metadata, bringing the data together. In Africa, it's even about moving the data, storing the data. So you have to think, obviously, the other components of this, the study design, consents, the management analysis, and then the training, obviously, and the capacity development for every one of these pieces is where we've been focusing. So the first project is the Human Hereditary and Health in Africa. So H3 Africa is a consortium, it's an initiative that was funded by the NIH and the Wellcome Trust, then via AISA and now via the Science for Africa Foundation. And the aim was to facilitate modern contemporary research that looks at the genetic and environmental basis for diseases on the continent. So it's a number of cohorts that are collecting data for studying very different diseases. But underlying the research and the science is a very strong capacity development and network development goal or role of this. So H3 Africa generated a lot of data. So we're in like 10 years into H3 Africa. We've got phenotype data, we've got genomics data, we've got other kinds of omics data, we've got process data, GWAS analyses, etc. And we have this now, if you look across the different the projects, we've got data for more than 100,000 participants. This is probably the biggest collection of data on the African continent, given the previous scarcity of African data. So this came up with, brought along a lot of data-related needs. So bioinformatics requirements for computing and network infrastructure, data management support, analysis support, etc. And then underpinning all of this, of course, is training. So H3A BioNet is the bioinformatics network that was set up to deal with all of these bioinformatics needs of the consortium. So our network has been running, it started up with 32 partners. In the second round, we dropped down to 28 partners, but we spanned 17 different countries and we have more than 200 members. And the aim has been to build data-related skills to empower African scientists to take ownership of their own data, their own publications. So we've had to play a role in all aspects of the genomics. I mean, our focus here has been particularly genomics, but it's really applicable to multiple omics or other areas. So in the whole workflow of a genomics experiment, we've had to build things like the data infrastructure. So the data transfer protocols, we've had, we took 3 months to move a data set from the US to Cape Town. Now that sets you back 3 months before anybody else, if anybody else has access to that data, you're already 3 months behind them. So we had to set up good data transfer protocols, security, obviously, because it's human data, build data standards, and all the other infrastructure. And then, of course, the data-related skills. So I'll just talk a little bit about some of those that we've tackled in H3 Bionet. So data transfer protocols, we've evaluated a number of different mechanisms, and we've gone with Globus Online, and we now facilitate transfer all across the continent in the, being cognizant of the electricity cuts and the poor internet. And then we've also put in a compute infrastructure for storage and analysis across multiple centers in Africa. So when we started 10 years ago, there were just a few small pockets of institutions that could actually do even small-scale genomics research. They couldn't even get to medium or large-scale genomics research. Now we have a number of centers that really can tackle, a few hundred genomes, maybe even 1,000 genomes, whole genome sequencing, and big, 10, 20,000 genotyping array GWAS. We built an archive for genomics data, so we are the data submission system for submission to public repositories. So we always make sure that the data are shared responsibly, and they have to be shared globally, but with the African researchers getting that extra time to analyze and exploit the data, so that there's, and also when you share the data, to try to encourage benefit sharing and collaboration with the original data owners. We've developed a whole lot of containerized workflows that are feasible in the African continent. Not everybody, in fact, very few people in Africa use the cloud. So we've developed containerized workflows that can be deployed on systems that are relevant to African settings. And in all of those, we've developed training. So we run hackathons for the developing of workflows, and we train sysadmins to actually manage this compute infrastructure, because your normal university IT infrastructure, they don't necessarily work with, like buggy bioinformatics software. We built a lot of data standards as well, because it's really important in data science to make sure that the data are collected in a standardized way. So we've built standard case report forms for many different diseases, and we've done a lot of training in REDCap and data harmonization. But a very big component, as I've mentioned previously, is our human capacity development. And in H3 Bionet, we've had to tackle that in using very different approaches. So we run hackathons for really goal-driven outcomes, whether it's an analysis of a big data set, or it's developing workflows, or it's developing a new tool or a platform. We've had to deal with the demand, not only for training our own bioinformaticians and the clinicians and scientists within H3 Africa to use their own data, but also to address the enormous demand for bioinformatics and data science skills on the continent. So we run these big online courses, of a flagship introduction to bioinformatics course, and now more intermediate courses. And in order to make sure there's long-term sustainability for this, we've built a train the trainer program as well. So we try to focus on developing foundational data-related skills and then applied skills. So the foundational skills being programming, statistics, GitHub, HPC, and then the applied skills will be in 16S microanalysis or GWAS or NGS analysis. And in order to reach a much wider group, we've introduced this remote classroom model, and it's been so popular that we've taught the Wellcome Connecting Science how to do it, and many people around the world are trying to adopt this model. So basically, we have local classrooms across the continent. Before COVID, they were face-to-face, and during COVID, they just went online. We're going back to face-to-face again, and they were all connected two times a week for 3 months on a particular course. All the training, coordination, the lectures, and everything is managed centrally, and these classrooms, sometimes up to 50 classrooms, connect twice a week to the lecturer and to each other. And through this, we've managed to train in our IBT, our Introduction to Bioinformatics course, we train up to 1,000 people at a time, 50 classrooms across the continent. We've been running this for 6 years, and literally we finish one course and we get the requests for the next course to run. And now we've gone to the more advanced training where you can actually run major workflows on HPCs or on the cloud. And those are sort of about 20 classrooms and about 400 people. But this has really enabled us to increase our impact. So we've managed to train a number of different trainers. We teamed up with the carpentries to do some training, the bioinformatics, the clinician and scientist users, bioinformatics scientists, bioinformatics engineers who are going to be developing, the next generation of tools, and then sysadmins to make sure all the underlying infrastructure is in place. Because remember, when you're sitting in the global north, all that is in place already. In the global south, you've got to do it yourself. It's just not there. So overall, we've trained more than 4,300 people on the continent, and we're just continuing to do that, and the demand is just never ending. So because we've built this massive infrastructure for training, we're able to leverage this for the new consortium, which started about a year ago. So the NIH are basically funding this new initiative called Harnessing Data Science for Health Discovery and Innovation in Africa, otherwise known as DSI Africa. So this consortium has a number of research hubs, training grants for degree programs, LC projects, and then a big open data science platform. That's Alwazi, and that's the one that I'm leading, the open data science platform. But these research hubs are tackling, they had to use existing data sets and have multiple different data types to answer a research question in health and get to a health benefit. So that it has to be reasonably translational. And so the data types are extremely diverse, from climate to environmental to clinical to omics data. It's very diverse data types, images, etc. And so we've had to sort of move out of our comfort zone of genomics and think about data models for all these different data types and how to bring this together, how to harmonize across these, and particularly the linkage and the data integration and then application of data science tools for a real health benefit. So the infrastructure development has been the open data science platform, which I'll talk a bit about, but there's also an engagement component, building these big networks of data science for health across the continent, and then human capacity development, again, the basic data science skills. So the Alwazi platform, this is the infrastructure that allows the data sets to come together and be analyzed, with data science techniques and on various different cloud computing platforms. So all the different projects from these research hubs bring in their data, and we've also looked outside of the consortium. We've got much interest from other groups as well. You have your data sets sitting either on local HPCs or on various cloud buckets. They are all indexed in the platform. The platform has a registry of all these data sets. There's a registry of tools, and there's access to various cloud computing infrastructures, GCP, Azure, AWS, on-premise solutions. You log into a workspace, that's the Alwazi workspace. It's currently running through Terra at the Broad Institute. You identify the data sets that you want, you pull out the data, you identify the tools that are in a common repository, completely open access, and then you choose which environment you want to run in. And so you can actually run this in a collaborative way. And we are making sure that this is feasible for the African setting, not for the US setting, not for the British setting, but for African researchers who have local infrastructural challenges. So another big component of this obviously is data science training. So the data science grants themselves, they are degree programs. So they're starting brand new degree programs in data science related to health, all around particular topic areas. So they all have particular disease areas or machine learning for imaging, etc. And then as a consortium, we're working on developing data science competencies. Data science, specifically data science for health. Data science is huge. We're looking specifically data science for the biomedical sciences and thinking about the competencies you need in order to apply data science across multiple, very diverse data sets. So we're busy doing that, and we're mapping these to the degree curricula. And now, as we're in HRA Barnet, we've got our flagship Introduction to Bioinformatics course that runs across the continent. We're going to be developing a flagship Introduction to Data Science for Biomedical Sciences that can run across the continent in an equal way, reaching up to between 400 and 1,000 participants. We also focus on training fellows to develop the next generation of research leaders. We do this in a number of different ways. We give specific professional development to our fellows, but we also get them involved in our working groups. We put them in co-leadership positions. They learn from osmosis and learn from the managers and really build their skills. And we've seen people go from postdoc to full senior lecturer positions and associate professor positions in the span of HRA Barnet. And then finally, the last initiative I'll just talk briefly about is the public health training. So again, the infrastructure we built in HRA Barnet was perfect. It was a perfect springboard to be able to apply this to the public health setting. We started this work actually just before COVID started. So really we were ready to get up and running and do a lot of training on SARS. And the components there are to build a training curriculum. We've rolled our training in SARS-CoV-2 for wet lab and bioinformaticians. We've run some foundational courses in bioinformatics for public health and also in containers and workflows so that they can develop their own tools. We are working on a standardized curriculum for the Africa CDC so that they can make sure that when they start a new public health institute, that each institute knows what skills they need to have and then have access to the training materials for that. So we're working with the public health institutes across Africa that are linked to the Africa CDC to build a standardized curriculum and then roll this out or have all the materials available. And then for stakeholder engagement, we've, as I'm sure many of you have seen, there's been an enormous need for long-term support after training. You can't just train people and then leave, because they still need further support. They need further mentorship. So we've actually developed a trainer database where trainers, global trainers come in, they put in the area of expertise, and then that's linked to a help desk where trainees can come in after any course, anytime, anywhere, ask a question with a category, and then that category also automatically links them to the trainer. And it's all anonymous, so you don't have to worry about your email address getting out. And then there's sort of an organic, question answer, global connection of trainers and trainees. And so the aim is to build, these trainee communities and trainer communities. So the take-home messages is that over this time, we've built significant capacity for bioinformatics and data-related skills on the continent. These have all been through funded networks. Funding brings people together. If you don't have any money, you need serious will. But we've managed to bring people together. We need to think about how this ascends long-term. So we're looking at a potential African Bioinformatics Institute or African Data Science Institute, which can then be applied to anything outside of health as well, because these skills are applied to everybody. So with that, I'd just like to acknowledge the various consortia that I belong to and the funding from the Bill and Melinda Gates Foundation for the public health training and the NIH for the other two consortia. Thank you.
Thank you very much, Nikki, for this great talk. I think we can have time for 2 questions. There are questions from the audience for Nikki. Yes, we can start here. If you can move forward a little bit so that you can get the microphone quickly, that would be great.
Thank you. So my question is to Nicola. So I was wondering, has the H3A Bionet been doing any work related to undoing the culture of male biology-oriented research through its work in data science capacity building? Because I see a lot of potential there. Thank you.
So you're related to?
Related to undoing the culture of male biology-oriented research.
So we have, so a few of us, including Amel, we're women in data science ambassadors. So we promote, women in data science. We have a specific symposia on that. And we have a group that, so some of our people have been working with, it's a group at Sanger who also have been working in women in data science. There are a number of initiatives. There's the, kind of, I can't remember what the name is, but it's, R, women in R, and women in biostatistics, and women in programming. And so we work a lot with those different groups to promote women. Actually, our greatest shining stars in H3A Bionet have been women, and particularly in Muslim countries, actually, which has been amazing. So we've got some amazing people from Tunisia, from Sudan. Amel was in H3A Bionet for many years. And so we've seen a lot of women rise through the ranks and they get into these leadership positions.
That's great news. I was also mostly wondering about gender inclusive data.
Oh, the data.
Yes.
So we don't, because we are in the kind of the next step, we help people to work with the data. We don't have any control over what the data is. So the data comes to us when it's already generated. So we can't tell the research projects, you need to do this. But in Asia Africa, there's a very strong, awareness of gender balance in the data. But as I say, as we get the data after the fact, so it's not like we can maybe change that.
Thank you.
We have time for one more question, if there's a question in the audience. I'll use my chair privilege here to ask a question, another question to Nikki. Curious to hear a little bit about how do you connect the different stakeholders and disciplines. You run trainings for public health institutions, training for academic institutions. Curious to hear a little bit more about how do you help connecting the dots?
So we actually find that reasonably difficult because there are very different audiences. And they do have different priorities. But in the SARS group that we've been working with, it is quite a big mix of academia and public health. Because I think, as you've seen from the previous talks, is a definite need for both. So when we've run training courses, we've had both audiences in there and we've tried to get them connected. And first, particularly in South Africa, they are very well connected because we have a network that covers both when SARS came along. So H3N has been traditionally academic focused, and obviously this one's public health, but we've recognized that we need to connect them a bit more. And some of the courses, as I say, do have both.
Great, thanks. Thank you very much, Nikki. With that, we're going to move to the next talks, which are highlighting exemplar research studies, leveraging data to answer different research questions, to inform decision-making and also inform product development as well. We're going to start with Valentina Martufi from SIDAX Brazil. Valentina is going to talk about the use of real-world data for measuring primary health care and its effects on maternal child health in Brazil.
All right, good afternoon, everyone. Thank you very much to the conference organizers for this opportunity. So today, as Amel mentioned, I'll be presenting my research team's work, how we use real-world data to measure primary healthcare quality and its effects on maternal and child health in Brazil. So primary healthcare is a pillar of any universal health system and a determinant of maternal and child health outcomes. At the Center for Data and Knowledge Integration for Health, SIDAX in Brazil, we do pioneering research using real-world data from millions of Brazilians. Where am I supposed to point this? To create population-based cohorts. So we study, among other things, how public policies impact the population's health. In specific, my research group was using an innovative approach to evaluate the relationship between primary healthcare components and under-5 mortality in Brazil. So the objective of this work was to describe the utilization of real-world data to explore the relationship between the quality of primary healthcare components and under-5 mortality in Brazil. So it's an experience report of how we integrated different administrative databases to use or reuse real-world data to understand how PHC interventions impact maternal and child health outcomes. So we created an anonymized database linking a series of government databases, which are the Live Births Information System, the Mortality Information System, the Unified Registry of Social Programs, known as the Cadastro Único in Brazil, which provides socioeconomic information on over 130 million individuals who apply to any social benefit program. Also, we use the database from the National Primary Healthcare Access and Quality Improvement Program, which characterizes the structure and work processes of primary healthcare teams. And finally, we use the Bolsa Familia program conditionalities database, which details at which primary healthcare facility are Bolsa Familia beneficiaries, which is Bolsa Familia is a conditional cash transfer program. So where they comply with their cash transfer conditionality, so where they receive their primary healthcare. Okay, so as you see in the figure, we joined several databases and ended up with a population of 143,000 children, which by SIDAX standards is actually quite small because we used to work with databases of millions. And these children, but still it's a significant population. So these children were all born in 2010. And they were attended by 12,085 primary healthcare teams across 3,601 Brazilian municipalities. We created a theoretical model of determinants of under 5 mortality, specifically 10 PHC components and some proximal determinants that represented individual socioeconomic and biological characteristics. These are determinants that we know affect under 5 mortality. So what we tried to do with our primary healthcare model is to open up the PHC black box and decipher its relationship with under 5 mortality. In doing so, we identified 5 PHC building blocks, which represent the foundation necessary to be able to deliver primary healthcare services. And these were reference and regulation system, planning and organization of work processes, facility infrastructure, general supplies, and workforce. So the quality of these building blocks affects the quality of maternal and child health services, which we identify as the most important being antenatal care, the quality of antenatal care, childcare, and immunization, bearing in mind that this is a quality of the infrastructure for immunization rather than immunization coverage. Our proximal determinants were birth weight as a proxy of biological characteristics and mother's education as a proxy of socioeconomic characteristics. We also included antenatal care utilization variable to mediate the effect of antenatal care quality. So the conclusion with related to the usage of real-world data is that it enables innovative approaches to assess the impact of primary healthcare quality on maternal and child health outcomes. And these strategies allow an agile and robust scientific production capable of uncovering scientific evidence in unprecedented proportions, quickly and with low costs. Some challenges we encountered were specifically in terms of methodologies we could use to analyze our data, as we were assessing simultaneously the effect of various components of primary healthcare, limited the methodologies we could use, as there's not many methodologies that allow to study multiple exposures at the same time. Also, under 5 mortality, fortunately, is a rare health outcome in Brazil, even in our cohort of millions. So this implied further methodological limitations. And the nature of our data was dichotomous, so it also limited our choice of methodology. However, we managed to pull through, and we realized that it is possible to measure clearly and concretely the quality of primary healthcare. We have a series of very clear and concrete variables that joint into indicators, and these indicators form our components that I presented. This PHC model that we developed can be applied to study the impact of primary healthcare on other outcomes, also less rare outcomes. And also recognition to our statistics team, because they studied a lot to adjust existing methodologies to be able to measure our exposures and their impact on under 5 mortality. And they really did some pioneering work. So I know we're only supposed to speak about the processes, but just bring a bit more detail about the research project per se. We did a literature review and an expert consultation to develop our PHC components. We used Bayesian confirmatory factor analysis to measure the quality of our primary healthcare components on a continuous scale. We use multi-level Bayesian path analysis to measure the impact of the PHC components on under 5 mortality. And finally, we used predictive modeling to obtain more concrete estimates of the effect of better PHC quality on predicted under 5 mortality. And I'm going to bring a little spoiler of our study results and some recommendations for policymakers based on them. So we found that improving the quality of planning and organization of work processes can decrease under 5 mortality by almost 6% by increasing the quality of childcare services. This was the greatest effect that we found among what we identified as our PHC building blocks. Improving all of our PHC building blocks, however, all of them at the same time, can decrease under 5 mortality by almost 41%, which demonstrates that PHC is greater than the sum of its parts, and we feel that's a very strong message coming from our study. So we recommend policymakers in Brazil to value the development of first-line implementers' capacity for planning and organization of PHC services. And for policymakers in other low and middle-income countries, they can try and adapt our PHC model to their context to try and measure primary healthcare quality and understand in their own health systems which primary healthcare components should be prioritized. That's it.
Thank you very much, Valentina, and thanks for keeping with time. Our next speaker is Durga Parkey from the University of Warwick in the UK. Durga is going to talk about machine learning predictions to look at the development of personalized medicine for women with glucose intolerance and gestational diabetes. Durga?
Thank you, Amal, for the introduction. I'm Durga, I'm from India, and I'm in my last year of PhD at the University of Warwick, UK. I'm working with Professor Saravanan. So today I would like to talk about our work on using machine learning for the antenatal prediction of postpartum prediabetes in women diagnosed with gestational diabetes in their pregnancy. So gestational diabetes is defined as glucose intolerance first diagnosed during pregnancy. When the mother is diagnosed with GDM in her pregnancy, the mother as well as the baby are predisposed to a lot of short-term as well as long-term complications in the future for the mother as well as the baby. And some of these are listed in the respective bubbles. So a major and a very common complication of GDM for the mother is type 2 diabetes in the future. So the glucose levels rise in the pregnancy due to hormones secreted by the placenta. And usually these again come back to normal levels when the mother delivers the baby. However, in some cases, when the normal functioning doesn't happen, the mother still has high levels of glucose in the postpartum weeks. And this is when she is termed to have prediabetes, and then she is at higher risk of developing type 2 diabetes in the future. So just some statistics, around 90% of GDM is concentrated in low and middle income countries. And these GDM women are at 10 to 12 times higher risk of developing type 2 diabetes as compared to normal women, in spite of having such high disease burden in the low and middle income countries. The follow-up rate is very low. So if you see the follow-up rate in high-income countries of about 60% in the UK, what would you expect in low and middle income countries, right? It's much lesser than that. You would be surprised, it's practically 0% also in some places. So we developed this study with the vision to develop precision model in order to improve the quality of life of two individuals in one go, the mother as well as the baby, and in turn help to prevent the intergenerational propagation of diabetes. So specifically for this study, the objective was to develop a prediction model. So the story is very simple in 3 steps. First is to develop the prediction model for antenatal prediction of postpartum prediabetes. Second is identify the woman with high risk of developing postpartum prediabetes using the model. And third is to achieve targeted follow-up of this high-risk group in the future. So even after the mother delivers the baby. So it's a very simple and straightforward story. Now, how do we achieve this? So the methods can be divided into 2 broad parts. So part A is develop the prediction model. And secondly, which is I think the most important part, especially for the low and middle income countries, is to select the optimal cutoff for stratifying these women based on their risk of developing prediabetes in the postpartum. Depending upon the resource availability in that particular setting. So we used the KL divergence and information theory from the formal mathematics to develop the optimal cutoffs. Now we had 607 women recruited, however, only 394 turned up for the postpartum screening. So the machine learning experts in this room would obviously raise questions. The 394 is a very small sample size to train a good machine learning model. So this was the biggest challenge that we faced to train a good machine learning model with such small amount of data. And we had to develop the framework in such a way that we use maximum data, so the data that we had as effectively as possible. Usually machine learning divides the data into 2 parts, training and testing. But then we lose the testing portion for training and training portion for testing, right? So the novel idea of this framework is that we used the entire available data for training, as well as the same entire available data for testing, without letting any part of the testing set see the training data, which is the central dogma of machine learning. And we do this using the nested cross-validation concept. So there are two cross-validations running one inside the other. The outer one is for evaluating the model, and the inner one is for tuning the hyperparameters of the algorithm. So there's a very nice saying that better data beats fancier algorithms. So we focused on improving the quality of the data that we used for training. And we used a very simple algorithm of logistic regression in order to maximize the interpretability of our developed model. So the key ideas of the methods step by step are: first, identify the features with maximum predictive ability. In this process, we can create new features if possible and if they are meaningful biologically. Then develop a prediction model using an effective model architecture. Fourth is representing the model mathematically if possible. So maybe develop a composite risk score using the logistic regression algorithm. Study the optimal thresholds to stratify the women based on their risk. And finally, all of this we can translate to a simple tool that the clinicians can use in the real world setting. We had our share of challenges in this process, and I would like to share some of them, as this is the main target of this conference. So first and the foremost, so we had very small data, as I told before, and this is a big concern in all prediction models, model development work in the health science domain. So even if data is collected, sharing the data becomes difficult because of ethics and data privacy related issues. So both of these concerns can be, can be solved for by using the novel ideas of deep learning and generative adversarial networks to generate data synthetically. And then we can either augment the synthetically generated data to the real world data to increase the sample size, or completely replace the real world data with synthetic data to account for the data privacy issue. Data incompleteness, so there was less follow-up, failure to have 100% follow-up, and missing values in the existing collected data, which can be solved for using a targeted follow-up approach, which I talked about through the entire presentation. And there was data imbalance, so very less representation of the positive class, so it becomes difficult to train good machine learning models without bias for the positive class, for the negative class. So but then these can be addressed using technical things like SMOT and so this is the last slide where I'll show the interface of the postpartum prediabetes prediction that we developed using only two features: antenatal fasting glucose and antenatal HbA1c. And you can see in the first case, the woman has a low risk with only 0.09% probability. And the second one with 5.8 fasting glucose and 40, we can easily predict that she has high risk of having postpartum prediabetes. So the clinicians can use this effectively in the real world setting. So these are my acknowledgements, and thank you very much.
Thank you very much, Durga, for this great presentation. Next up, we have Ephraim Kumi, who is a nurse scientist from Accra, Ghana. Ephraim is using the Ghana Maternal Health Survey to look at socio-economical factors associated with adolescent pregnancy and motherhood.
Thank you. Thank you. I'm Ephraim Sinchre, and I'm a nurse from Ghana. And I'm here to share with you secondary data analysis from the recent Ghana maternal survey, which was in 2017 on socioeconomic factors associated with adolescent pregnancy and motherhood. Adolescent pregnancy is a contributing factor to global maternal mortality rates as a result of unsafe abortion practices among these adolescents. In Ghana, approximately 40% adolescents between 15 to 90 years had childbearing, and adolescent pregnancy contributes to approximately 9% of maternal mortality in Ghana. The aim of the study was to assess the association of socioeconomic factors with adolescent pregnancy and motherhood in Ghana. And understanding these variables are vital for effective policy formulation in Ghana. 2017 Ghana Maternal Health Survey, which was implemented by the Ghana Statistical Service, was used, and the sampling frame was from 2010 Ghana Mortality and Housing Census. The survey's sample involved two-stage stratification, and in the inter-stratification stage, 10 regions of Ghana was divided into urban areas and rural areas, which resulted in 20 sample strata. And in the independent selection in each stratum, 2 stages were involved. At stage 1, the sorted the strata generated administrative regions and levels by using indirect stratification and population allocation before sample selection. And probability sample technique was used to select 900 enumeration areas, which produced a cluster sample of 466 from the urban areas and 434 from the rural areas. In stage 2, random sample was used to select 30 households from each of the 900 cluster, which resulted in 27,000 household sample. And from these, 92.8% were women between 50 to 49 years. Also, women greater than 20 years were 80.9% of them were greater than 20 years. And adolescents between 50 to 90 years made up of 90.1%. Among these adolescents, 40.6 were ever pregnant and 11.8 were ever had live birth. And during the motivate regression analysis, we found that zone of residence, wealth index, marital status, level of education, age were associated with adolescent pregnancy and motherhood. And also adolescent pregnancy and motherhood were higher in the middle and coastal zones, and also among older adolescents. We also found that pregnancy and motherhood was lower among adolescents from households with highest wealth index, those who were never married, and also those who had secondary or higher education. In conclusion, we found that several socioeconomic factors were associated with adolescent pregnancy and motherhood in Ghana, and hence sexual and reproductive health education should be intensified among this population. And also adolescent friendly corners where they can access reproductive services should be also made available and accessible to all adolescents in Ghana. The process, the process and challenges, how the data was obtained. First, you have to register with the demographic health survey as a data user. And in your comment letter, you have to state the purpose and also emphasis on requested data. You have to emphasize that the requested data will only be used for the purpose of the research study. And also, if you want to use the same data, you have to send a new cover letter. And normally, demographic health survey review all request data within 24 to 48 hours. And they also provide notification if access has been granted or modification is needed. And the challenge from this analysis was it required more analytical skills to make meaning to the data sets. These are my references, and I want to acknowledge the demographic health survey, the survey participants, all co-authors, the government of Ghana, United States Agency for International Development, the European Union delegation to Ghana, and the United Nations Population Fund. Thank you.
Thank you very much, Ephraim. Next up, we have Christy Martina, who is a nurse researcher from the Emmanuel Hospital Assam and Tata Institute of Social Sciences, Mumbai, India. Christy is going to talk about the use of the India National Family Health Survey data with a focus on understanding barriers to health equity.
Can you hear me? Yes. Now it's post-lunch, so I have to be a little louder so that everyone is awake. I understand post-lunch sessions are difficult. So I'm going to make it little interesting. Okay. Okay. So the topic I've researched this on the equity in reproductive health care using the healthcare equity transformation model. So when we talk about equity, so there is difference between equity and equality. Equity is like everybody is given the same. Equity is like they give what you want, what you deserve. So I remember the Global Health Network, they're very particular with what you want. So they follow lots of equity. I appreciate it. So when you talk about equity, I found some very interesting thing. There's a definition for equity. It said that there is, in short, equity creates a path from hope to change. I found it very interesting. So equity is something which has to create a path where we think of something, where we hope for something, but equity actually should bring a change. And when we talk about reproductive health equity, it gives people what they need to have a fair chance at sexual and reproductive well-being and autonomy. So this is a place where I work. So these are the tea gardens of Assam where I work. So you see how beautiful they look, but when you look inside, it's quite challenging. The situation is different. This is another part of India. India has a part called Assam, where we find the tea garden people who are at the lowest, who are the most vulnerable population who are there. And the objective of my study is to introduce the health equity transformation model in the reproductive healthcare. So we have used a secondary data and we have used a rapid review to analyze what is the reason for the barriers in the healthcare equity. So NFHS means it's a National Family Health Survey data. It's a large-scale multi-round survey data which is done in the households of India. So we have the 5th round of data which we have analyzed. So the data was conducted between 2019 to 2021. It was conducted in 2 phases and they have covered around 6,36,699 households throughout the country. So when we talk, there were around 7,24,115 women and 1,01,839 men, and providing the key estimates for all the states of India, covering 707 districts. So when you talk about the sample and the sampling in the NFHs, so they have covered the district into a rural and an urban area, where the rural, they take something called a sample of villages. And in the urban area, they take something called the census enumeration block. And each one is called a primary sampling unit. So each primary sampling unit, they were around 30,456 primary sampling units. And they used a probability systematic sampling, which was a random thing. So when we analyze the data, so what we want to analyze from this NFHS data, we want to analyze 2 things. One is the equity to access reproductive health services. And the second one is the utilization part, where women, how they utilize the antenatal care, the skill birth attendance, and the family planning. And the equity was measured against the urban-rural area and women's education and the wealth quintiles. So as you see here, this is the data which talks about the education, the wealth quintile, along with the registered pregnancy. So when you see here, the data is very interesting. People register, but when you see the antenatal care, it's high among people who are educated, and it's high among the people in the urban areas, and also among the people who are having a higher wealth. So there are interesting thing is people register, but there are people, the percentage keeps coming down when it comes to people who had more than 4 antenatal checkups. So people register, but people are not compliant. They don't follow up. So this is it. And we all know that it follows a social gradient where a person from a lower socioeconomic position, their worse is a chance to health. So that is universal everywhere. So we want to find out particularly what are the things which determine for this non-utilization and the equity in the reproductive healthcare services. So we have chosen the health equity transformation model for this. And we have done, we have searched 4,107 databases and records, and we found 42 studies which were relevant to our topic. And we found a conceptual framework for the healthcare equity. So there are few interventions and there is an impact and what is the outcome. So there are few interventions which are required to achieve this reproductive healthcare equity. The first one is the policy. Second one is there should be accountability. Third one is there should be leadership in governance. Fourth one is collaboration. And the last one is the culture. So the impact is divided into three dimensions. The first one is the system. The first one is the socio-economic obstacles, the lack of quality care, and lack of poor infrastructure in India. The next one is the role of family, which is very important. A woman is pregnant, she wants to go for a checkup. It's the family who decides where to go, what to be done, where to deliver. So the role of family, I didn't put the role of mother-in-law, but it's actually the mother-in-law and the husband who takes the lead in India. And also, there are lots of cultural and traditional practices which are prevalent in India, where people say you have to go here for your delivery, we have to go to your mother's place for delivery. So they have lots of things. And the last one is the individual experiences. The first one is a negative experience. Like women sometimes don't want to go to a healthcare provider because they had a negative experience. And the second one is women have priorities in spending. Imagine a poor tea garden woman or any woman who has money. She wants to spend it for the family rather than spend it on health. They don't know the importance of health. So they rather spend it on something which benefits the family, which benefits the children. And the last one is women lack autonomy in their like utilization or access to the healthcare services. So when you have these interventions, when you have this impact, I'm sure that it's going to have an outcome, good outcome on the reproductive healthcare equity and utilization. So there were a few challenges. As usual, we have used the secondary data. And when you use a rapid review, it's like we limit our database search, and but still we were able to produce a comprehensive analysis of the factors which are necessary. So there are few recommendations. The first one is we have to strategically target the social determinants of health, which is my doctoral thesis. This is a part of the study which we have done. And we have to emphasize more on women's education and economic empowerment. And we have to empower the health workers to collaborate more with the community. And we have to address women's social vulnerability as a barrier to utilize reproductive health services. And the last but not the least, we have to address the cultural and religious belief, which provides a tangible first step for all the communities. Thank you.
Thank you very much, Christy, for this amazing talk and talking about through the all sort of outcomes, drivers, and understanding of the cultural context and how that drives inequity. Last but not least, we have Christine Milowaza from the Ministry of Health in Uganda. She's going to talk about the assessment of the effect of community differentiated service delivery models on viral load suppression among children and adolescents living with HIV in Uganda.
Thank you. Good afternoon. I'm Christine Muloza, a medical doctor. I work as a research coordinator with the Ministry of Health in Uganda in the AIDS control program. Thank you, the organizing committee, for giving me the opportunity to be here today. I'll be talking about assessment of the effects of community differentiated service delivery models on viral load suppression among children and adolescents living with HIV in Uganda. Viral load suppression for children and adolescents living in Uganda improved but remains low at 74% compared to adults, which is 91%. That is according to the District Health Information Software System 2021. This is due to suboptimal ARV regimens, non-adherence to treatment due to psychosocial and drug administration challenges. With support from PEPFAR, Uganda started implementing the community differentiated service delivery models for children greater than 2 years and adolescents 10 to 19 years living with HIV in 2020. The facility-based models, we have the facility-based individual management model, the facility-based groups, the fast-track drug refill, and amongst the community models, we have the community drug distribution point, the community client-led distribution. A national DSD dashboard was developed to monitor viral load suppression among clients on DSD models by DSD type. We set to assess the effect of the community DSD models on viral load suppression among children and adolescents living with HIV across the country. We have the processes where the community client-led ad distribution point. This is when a particular group of clients, usually there are 6 in number, and one client goes each month to collect on behalf of the group. And then the community drug distribution point, these are designated points within the community where retroviral drugs are dispersed to persons who are living positively with HIV. We retrospectively analyze data for children and adolescents living with HIV from the DSD dashboard for all HIV AD clinics in Uganda. That was from July to September 2021. And this dashboard pulls data from the DHIS2, the National Reporting System, on a quarterly basis. Descriptive analysis included data on demographics and viral load suppression for community DSD models. 92,562 children and adolescents living with HIV were active on ARTS between July to September 2021. 56.2% were females and 43.3% were males. Amongst the facility-based models, there were 74%, and then we had 21% for the community DSD models, and then 5% were the uncategorized. The uncategorized are usually people who never belong to either of the models. And then amongst the facility-based models, for the facility-based individual management model, we had 28%. The facility-based groups were 45.3%. The FTDR, that was 17.9%. And then amongst the community models, the CDDP was 1.6%, and the CCLAD was 1.5%. Viral load suppression among the community DSD models did not differ by sex. We saw the males were 67% and the females were 66%. And then by the community DSD type, there was also no difference. We saw the CCLAD 62% and the CDDP was 61%. So from there we concluded among children, viral load suppression, that is less than 1,000 copies per mil, was 62%, and 75% among adolescents living with HIV were receiving ARTS under the community DSD model. We observed a lower viral load suppression for children and a comparable viral load suppression for the adolescents in the community DSD models compared to the national viral load suppression. However, there's no significant difference in the viral load suppression among the two community DSD models. Children and adolescents living with HIV can still benefit from the community DSD models. However, psychosocial support should be strengthened, especially for children. Some of the challenges were delayed viral load testing. This was mainly observed, especially for the CCLAD clients, whereby some of them would go to the facility and at times they'll miss out having the viral load testing done. There's also poor documentation, and this is evidenced in those who are in the uncategorized, whereby we all know they belong to a certain model, but somehow it was not documented. And then the poor patient literacy, where some of the patients didn't know which models they belong to, despite being on ARTS for a very long time. Special thanks go to the PEPFAR through the CDC for their support in making this happen. Thank you.
Thank you very much, Kristen. And thanks to all the speakers. Please join me to give them another round of applause. This was an amazing panel, and I'll try to summarize a little bit, but I know we won't do justice to all these amazing talks. So we talked about the importance of data science skills, how skills evolve, and the need of developing infrastructure and analysis workflows that are adapted to the context. Then we saw some amazing exemplars of data reuse, leveraging different types of data, primary healthcare data, routinely collected data, national and household surveys to answer different types of research questions, look at efficiency of health service delivery, thinking about the use of therapeutics, personalized medicines, measuring inequalities and targeting interventions, improving healthcare services, to inform policies and guide interventions on the ground. It also struck me that we have different backgrounds represented here. It was really great to hear from some experiences from frontline healthcare workers, leveraging data to support and inform interventions. We also heard a little bit of some of the challenges. I'm not going to dwell on that, the lack of standardized data, the lack of quantity of data that is available to develop different types of models. There were obviously different models described and how they have been implemented. There was also mention of collaborations between different skills and different experts and bringing together the different stakeholders. This was really amazing. And because you did an amazing job sticking with time, I think we have time for a few questions from the audience. We can start in the middle, then go to the right and to the left. If you can come forward to get the microphone, that would be great.
This is Lydia from Colombia. Thank you very much for your presentations. I've been sitting here very interested in what you have to say. So the data science is very valuable. The models that are produced, you have shown good examples on how valuable they are, but still they are simpler models of more complex realities. So one of the things that we have been reviewing in the literature is that they usually lack validation. What are your approaches for training the limitations of these models, and also your plans to actually try to translate these models into real life tools after good validation studies?
Anyone want to take this question? Ephraim, Durga, anyone? Yeah, go ahead.
Hi, thanks. So, totally agree with you. It's like in our case, it was really challenging to try and represent something as complex as primary healthcare, for example, in a model that a statistical methodology would be able to deal with. In fact, I don't know if anybody noticed, but I said 10 components, but actually only presented 8 because it was 10 components originally, but then just this, it wasn't working. So we had to simplify in order to be able to get some results. What happens then is, but I feel like that's what happens in research all the time. Like this is one image I didn't bring today, but it's like massive knots of lines around and researchers in a small room trying to connect A to B with one line. Like this is what we try to do always in research, right? Simplify in order to understand. But moving from here, what we're thinking is like, okay, some interesting things have appeared, but for example, due to the complexity of our model, we weren't able to include a lot of confounders and contextual factors. So we're going to look into more detail. This planning and organization component that we found that was really important, we'll maybe study it individually, being able to then take account of, because statistical limitations are always going to be a factor and we can't just stomp our feet and decide to overcome. But that's kind of, yeah, it was a struggle to accept this, but we had to just try and simplify, find a balance, right? Between simplification and trying to contemplate all the things that were relevant. So
that's the reality of data science implementation. I saw another question in the middle, and then we can go to the, please, if you can move forward to get the microphone. Oh.
All right, thank you so much. My name is Oyewole Edeli from Nigeria. That's Institute of Marine Biology, Nigeria. So I just want to add, so just in response to our question, actually that's what I have in mind too, that the challenge with external validation in terms of bringing all this to reality. So I would suggest that you test these data sets in another population. Let's see if we have similar findings, and with that you can compare your results. Another thing I have in mind is regarding this sample size, the data size. I noticed that is small, that's for you. That's quite small actually for testing and training. I just want to know, do you do what we call consider parsimony, where we consider the parameters that are lesser or fewer in number to be sure that we have the predictive model? Thank you.
Could you please repeat the question?
I couldn't hear the question. I'm sorry.
Let me just simplify here. What I'm trying to say is when you have a data size that is small in number, you want to consider parameters that are also fewer. That's the concept of parsimony. So in that case, we say less is better. And by so doing, you have more kind of a model that is more predictive rather than generalizing. So I just want to know whether you consider that when you do your testing and training.
Yeah. So we try to reduce the number of features because the sample, the data samples we have is less. That's what you want to come at, right? Yeah. So if we had maybe a larger data, we could use techniques like, more advanced techniques like neural networks and so on for building the prediction models, because the number of features were, quite okay, quite decent. There were around 20, 25 features. So if the number of samples were more, we could use more advanced techniques. But maybe, again, addressing your point as well. So sometimes it's better to keep things simple in order to interpret the model more. And that is what we essentially want to do in case of clinical settings, that if you try to see every person is different, so then you would need a different model for every person in that sense. But when you're trying to generalize things for the whole population, I think it's better to keep things as simple as possible and use the simplest models so that you are able to interpret the results in a better way.
I think there was a question here. If you can come forward.
Good day. My name is Victoria. I work as a data analyst at the Institute of Human Virology, Nigeria. So I think this is my best session yet, because everything has been over, but this one I'm able to relate to everyone, and great job to all the speakers. So the first question is to, sorry, I don't know your name, from Brazil. So I just wanted to ask how you were able, what techniques you used in linking data sets in your study. You did talk about how you linked up to about 6 or 7 data sets. So where I work, it's difficult for us because you have data in silos, and the challenge is that these data sets do not have a common unique identifier. And linkage, I have been struggling with that for almost the past 6 months. Linking those data sets is a huge challenge. So most times they're only able to show the data in aggregate formats. So you were just saying this has this, this has this. So how did you deal with that? I know you have population size cohorts. Unfortunately, we don't have that where I come from. So the second question is for Professor Nicola. Yeah, I know IHVN works with you on the H3 Africa project, and also the Inform Africa, that's DSI Africa. Just to ask if the training institutes would be, that's data science institutes would be degree awarding, if you have those plans, whether they'll be degree awarding and where they'll be located. I know the projects are scattered across different countries in Africa, if they would be just in South Africa or across those project sites as well. And for the doctor from Malawi, I'm sorry if she's not from Malawi. I'm sorry. You said, VLS, yes. HIV, sorry, sincere apologies. Just to ask, you found that viral load suppression was lower in children using the DSD model, but just wanted to add that as compared to those in other facility-based models, just wanted to ask if that difference was statistically significant or it was just lower, if you did a proportion test to know if it was statistically significant. Thank you.
All right, I think we got a good combo here.
Oh, okay, I said for the, you said that viral load was lower in children within the differentiated service models as compared to the facility-based models. Just to know if that difference in proportion was statistically significant, if the p-values were lesser than maybe a set threshold, or they were just, you just stopped at the descriptive part of things. Thank you.
Christine, do you want to start?
All right, thank you, Victoria. For children was significantly low, and it was observed from the results. And one of the main reasons why they were really affected, in most cases, I believe we can all attest to this. If you're giving psychosocial support, usually focus on the older children, we focus on the adults, and we hardly think about the little ones. So as we were enrolling some of them in the DSD models, even some of their parents actually didn't even know what it was all about. So at times people, yes, they're suppressed and they're pushed to do things when they're not even aware about the whole idea. So at some point it significantly affected quite a number of children, and they had their viral loads, not suppressed as compared to the rest of the other older children and the adolescents. Yeah, thank you.
Valentina, you go next.
Hi, thanks a lot. Oh, where'd she go? She disappeared. Oh, hi. So we work in a
Briefly,
center.
I know this is a complex question.
Sorry?
Briefly, try to answer this question briefly. I know it's a complex
Sorry. Super briefly. Myself and my team as mere researchers, we just did a bit of merging for the last little bits of not the individual level data. We have like data specialists that take individual data, and they use like a whole lot of very special techniques to link them. And I'd love to talk more about this. So let's exchange contacts. But, and if we can support, I think we would love that as well. So I'm not going to delve into that detail because Mel got scared.
It's going to take us another hour otherwise. Nikki. So on your questions about the Institute, it will be continent-wide. You know, we'd obviously build on H3 BioNet, but also other networks. So the African Open Science Platform has in its plan a data science institute. African Biogenome Project now wants to do an institute. So it'll be quite widespread and quite diverse in terms of the research areas. We wouldn't focus immediately on degree programs because that is the remits of universities, and we've looked at accreditation across different countries, and accreditation and recognition of credit-bearing courses is different across African countries. So that's a big hurdle to get over. So we'd start with short-term training, professional development training, and then think about degrees and supporting that later. Great, thanks, Nikki. I think because we had 3 questions in one, we're just going to wrap up. And I wanted to ask all of the panelists if they can share one recommendation based on your work on how to maximize the impact of data-centered findings in 20 seconds. We'll start with Christine.
All right, thank you. I will strongly and courageously encourage all of us to focus on psychosocial support. For me, from my findings, this is an area where most of us neglect and we assume people know what they do. But as a health worker, as a psychosocial person, as a community health worker, in whatever, cadres you are, it's very important to make sure that the people you're working with, you're talking to, know what you're talking about, they understand, they've understood what you're telling them. Psychosocial support goes beyond telling someone, take your drugs, do this and this, but also finding out they understand what you've told them, they're okay, their lifestyle is okay, like going beyond the common things we know. It's part of healing and it's part of health. So let's not forget that. Let's encourage that and let's work to make sure that it's done. Thank you.
Christy?
Yeah, one takeaway point I want to say is it's women and women needs to be empowered. The second one is we have to look at the cultural and traditional values. Each one we value and we own a culture and tradition. So I think it's when we look at a group, we have to value what they believe and we have to go along with the flow. There's a saying that when you're in Rome, become a Roman. So when you're with a group, you have to become one among them to get them. So we have to respect the culture, we have to respect the tradition so that they will get the benefit of the health outcome. Thank you.
Ephraim?
Thank you. For me, I think irrespective government collaborating with other sector in management of adolescent pregnancy is a key. And also as individual, we should also collaborate with others to learn from each other on data sets. Thank you.
Durga?
So I think in very short words, I think data is everything. So there's a lot of information that data hides in itself, which represents the things going on around in the true world, in the real world setting. So it is important to trace back and think where the source of the data is coming from, rather than only focusing on applying different new machine learning things or new techniques. So if we go back and focus on understanding the data better, I think we can apply, we can build models that that can be applied to the real world.
Valentina?
Yes, so I think we've seen what the power and the potential of administrative data collected by the government is. So collaboration with these governments is super important, especially for creating current knowledge, right? So as you may have noticed, the dates of a population were kind of old, and that's due to the process of obtaining these databases. So close collaboration in order to expedite this and have more current knowledge would be really great.
Nikki?
Okay, so the social and cultural things have been covered, so I'll focus on the data. We used to have an environment where we were data poor but information rich. We're now data rich and information poor. And the data, whatever we do with data, it's nice to play with it, but we need a real outcome. So we need to be working with data because we want to generate knowledge, or we want to work with data because we want to generate a product, or we want to benefit a patient. So let's have a real research question. Let's have a real reason to work with that data and do it responsibly.
Thank you all. Collaborations, who benefits from the evidence, think about the context, bringing the different stakeholders together. We have a lot to do. Thank you, everyone.
We've had such a brilliant set of chairs this couple of days. So that was an awesome job of chairing, and what a panel. Thank you. That was just such a brilliant session. Thank you. And so now we've got the session I'm perhaps most excited about for the last 2 days coming up after coffee, and we don't want to squeeze the time at all. And what's been so nice is over the last 2 days, we've had so many questions about women in science, gender balance. So we're totally focusing on that after the tea break. So could you do this, please, just for the last session of the day, so we completely give it a maximum time? Run outside, grab the bit of sunshine, get your coffee and your bun, and come back. And so we're sat here absolutely ready to start. We will start dead on the half hour because we want to give us maximum time to this fantastic session coming up. So no chatting, no side meetings, and just have get your coffee and then come back for the last brilliant session. And thank you again.
Good afternoon, everyone. I said good afternoon, everyone. Yes. It's been a wonderful 2 days, so let's finish strong. My name's Iris Mwanza. I'm the Deputy Director of the Women in Leadership Work at the Bill and Melinda Gates Foundation. I'm just delighted to be here today to discuss this really important topic of women in global health research. We know that there's been progress, and big thanks to the hard work and heavy lifting of the Global Health Network and others. And I have something very, very special to announce today. If you look on your seats, you will have a piece of paper. Yes, yes. Don't sit on them. Take a look at them. And so we are launching today a new community of practice for women researchers in global health. Yes. Super exciting. Everybody is invited to be involved and participate and join this community. It's our community. So thank you, Trudy. Thank you for everybody for making this happen. Okay. So today we have an incredible group of panelists for you, and they in just a couple of moments are going to be introducing themselves and talking about their work and their personal and professional journeys. By the end of the session, you're going to be inspired, but in addition to inspiration, you're going to have some good ideas, some recommendations, some thoughts, food for thought to take home with you back to your home organization. I know I'm going to take some of this back to mine, but also back to your home countries. The goals of this conference, as you know, aren't just to have an overdue celebration, even though that's a part of what we're doing, 10 years plus. Yes, we can clap for that. To convene, to dance. Nobody told me to bring my dancing shoes, but next time I'll get it right. But more importantly, we're here to have meaningful conversations. We want real progress, and we need to accelerate our goals for gender equality and women's leadership in global health research. As many of you might know, it's the Thanksgiving holiday in the US, and the US is my adopted home, even though I'm originally from Zambia. But I want to take this time to just express my profound gratitude to all the organizers. So much hard work went into making this convening the success that it has been. Yes, absolutely. Thanks to my panelists in advance, and thank you to this audience, just such a beautiful audience. So thank you for your active participation. I do have to say I am a little bit sad to miss the annual Thanksgiving feast that my in-laws put on, but it's a very, very, very small price to pay for this wonderful honor and tremendous opportunity to be with this family and this community. So really, really happy to be here. Before we get into our panel discussion, I want to take just 1 minute to say how proud the Bill and Melinda Gates Foundation is to have partnered with the Global Health Network since its inception, so 10 years plus 2. And the foundation will continue to support this important work into the future. The team that I lead is all about women's leadership. My job and my passion is to accelerate women's leadership in health. I have the privilege of working with a remarkable team, and we promote women's leadership in global health, in law and economics, but I also work with many, many other teams in the gender equality division. And our collective objectives are around achieving SDG 5. So I won't pop quiz you and ask you what SDG 5 is. I think the majority of you know, but in case you don't, the goal is to achieve gender equality and the empowerment of all women and all girls. We know that gender equality in research is the absolute right thing to do, but we see in our work that equity and equality also leads to stronger, more robust research, which in turn leads to better health outcomes for all of us. the Global Health Network has been so effective at strengthening the capacity, the quality, the diversity of both the researchers and also research. They've done this across disciplines, across the globe, and this session is going to explore both the barriers and enablers of women in global health research. So now, turning to my wonderful panelists, we're going to kick off the session with you introducing yourselves and your work, starting with you, Lida.
Shall I just?
Yes.
Hello, thank you, Iris. And first of all, thank you for the organizers for inviting us here and bringing us all the way from Colombia and giving me the chance to meet up with my colleagues of the Global Health Network Latin America and the Caribbean, but also encounter again people that have been very key to me early in my career, both women and men that I have seen here for the first time in many years. So thank you for that opportunity. I will never forget it. My name is Lida Osorio. I'm an infectious disease epidemiologist at Universidad del Valle in Cali, Colombia, where I do research in mainly arboviruses, neuroinflammatory infections, and also are very motivated to share the privilege that I had to have access to a PhD and postdoc training. And I want to give back that to my fellow students and also younger generations in Colombia to have the same privilege, and that sometime in the future, higher education is no anymore a privilege, but a right. Thank you.
Hi, good afternoon. Thank you, Iris, for the introduction. It's a pleasure to be here in this lovely panel. And my name is Cristiane Machado. I'm a researcher. I was graduated in medicine, and I'm a public health researcher at the National School of Public Health, which is a scientific unit of Oswaldo Cruz Foundation in Brazil. I'm currently the Vice President of Education, Information and Communication at Fiocruz as well, where I have many responsibilities, including the coordination of the Women and Girls in Science program at Fiocruz. That's why I think I'm here representing the institution. I'm also the mother of two girls who were born while I was at my doctorate, both of them, and now they are at the university. So everything worked out perfectly. Thank you.
Christian just ended with a reflection of successful women. So we'll talk about it later. So I'm Alia Nahid. I'm a medical doctor, but I was a disease epidemiologist. I am a disease epidemiologist. I have 15 years of track record in infectious disease. And I was frustrated looking at the epidemiologists not being interested in translating research finding into policy. Then I pushed myself to get into health systems management. I am a specialist in there. My main focus is now non-communicable disease, health systems strengthening, and of course, service delivery, including equity and gender equity particularly. So I don't know what I should say. I am a scientist in International Center for Diarrheal Disease, the organization is famous for its invention of oral rehydration solution that is saving millions of lives in the world. So from that organization, I probably don't need to talk much about it, but just all I want to say that there's a huge number of women researchers working there. And this organization in many other organizations, developing countries, is making solutions for problems, but which we don't know. So it was a great forum in the Global Network Conference that knew about it to some extent. So look forward to hearing the story and challenges and the success behind those for those women. Great to be in the panel. Thank you.
Thank you. Good afternoon. My name is Alice Lakati. I work for Amref International University. Amref International University is born of Amref Health Africa, which is an NGO that has been there for over 65 years in Africa, implementing projects in primary healthcare. We are actually in 35 African countries. So the university was formed 5 years ago to complement the work of AMREF in terms of advancing the agenda of human resources for health. At the university, I have taken different roles where I have founded different sections of the university from scratch. I founded the School of Public Health, the Department of Community Health, and now I'm the founding director for Community for Research and Extension. I'm delighted to be in this panel, and I'm also greatly honored that we have the privilege to discuss and learn from each other. Thank you.
Good afternoon, everyone. As you can see, I'm a man. My name is Tumbi Dungo, and I'm director for Basic and Translational Science at the Africa Health Research Institute in Durban, South Africa. But I'm also program director for a research and capacity building consortium known as the Sub-Saharan Africa Network for TB and HIV Research Excellence, which brings together 8 African institutions for research and capacity building around HIV and TB. And yeah, I'm looking forward to this discussion. I was really horrified to know that I'm the only man in the panel. And so the tables have slightly been turned on me for this one, because usually it's the other way around.
Good afternoon. I'm Catherine Littler from the WHO Ethics and Governance Unit in Geneva. I'd like to, I think, thank the organizers for the invitation, but I'll tell you that in about 50 minutes. But I had the classic female reaction when I got this invitation. I did that, oh, I'm not an expert. Should I sit on this panel? And that was my first thought. And then I thought, by virtue of my gender and my experience and my role looking at ethics and access issues, maybe I'm well qualified to sit on that. The second thing I did was thought about who are my role models, like who have been my role models in this space. And what's really interesting is now I've got some. So the last session was Nikki Mulder. I had the privilege of working on H3 Africa, and she has to be one of my role models. I'm also currently situated in the science division, and we have the inaugural chief scientist, Dr. Soumya Swaminathan. And I have to say, watching her in COVID, which would have to be one of the toughest jobs to be the chief scientist at the WHO during COVID, watching her humanity, watching the way she handled really tough questions, gave information really well. I just, I have an utmost respect for her. So it's really nice to have someone at the top of the organization or very close to it, female, that I can look up to. But when I was looking back in my early career, there weren't many people for me to follow. And I do think that's tough. I actually think that's really tough. And when I was speaking to Iris at the beginning of this, before the session, I was thinking, this is a hard conversation because it's not about an add-on. Gender is not an add-on, it's a systems issue. So pulling it out and teasing it out, like ethics, people often roll their eyes when I say I'm in ethics. That's a systems issue also, and so is gender. So I think part of this discussion today is challenging ourselves on the systems issue and our responsibility. So I'm really looking forward to the panel and hearing from my fellow experts or the people who are actually embedding policy so I can learn how to be better in this space as well.
Great, thank you, everybody. So we're going to get stuck in, and we're going to open this discussion in Latin America. So again, starting with you, Lyda. You're a professor, you're an infectious disease researcher. You've previously talked about your experiences as being a scientist before motherhood, and then being a scientist after motherhood. So what do you mean by that? And please, could you just share more about your story and your journey?
Yeah, our careers are at the
forefront of our list of priorities. And then comes motherhood to fight that first place. And for me, it was a struggle, that fight. And sometimes I feel guilty when motherhood was on the top and for not doing research. And then when research came up first, and I felt guilty because I was left in my son alone, quotes, which means without me. No, he wasn't alone. And, or it was neglecting him. I thought that's what it felt in my mind. So there was a struggle there to find that balance. And for me, I think it was the only time in my entire career that I felt some sort of discrimination, because I thought that was unfair. That was me who was having that struggle, but not my partner. At least he didn't communicate that way. So I thought it was a need to discuss in society how we value care for the kids and for the family, and how much burden is put in us women. And it's up to us to actually educate the kids very early on to be able to share the care of the family and also housework. So it's more balanced. And also the workplace, how can be more friendly for us to find a better solution to that dilemma. And fortunately, I have the support of my workplace, the university. So I had the flexibility to manage my schedule, work from home. Also, we have good maternity leave laws in Colombia. And also, I think I have also the support, and my colleagues was very important to cover me, and also to be flexible when I have to leave a meeting early because I needed to be home, for example. I think finally, it was my decision to restrict traveling. I think that was my own decision, and it has to be worth it, like this one. It's for me to leave home, or if it's gonna be short, I won't travel. And I'm very keen into virtual meetings and virtual teaching, etc. So I think that's at the end was the only decision that I took. But I have friends who have decided to completely stop their careers and dedicate to motherhood. And I think that's completely, I respect that. It's their decision, and that suits their interest. But then it has been a struggle for them to come back after certain years. And for them, I think we still to work harder into how we facilitate the comeback after motherhood as well. Thank you.
Okay. No, absolutely. We have heard and we know ourselves that there's an unequal burden of care that's falling on women around childcare, as you mentioned, but also elder care, caring for sick relatives. I think a recent ILO study said that depending on what country you're in, the burden of unpaid work that women carry versus men can be 2 times up to 10 times the amount for men. So this is a very significant, very real issue. So Mike, and we know, and I think COVID, it just exposed the reality. It wasn't something that was new, but I think it brought it to the fore because what had been a struggle became completely unbearable. So you did mention that your university was a conducive place for motherhood, and you now are in a leadership position. So please, could you share with us ways in which you've been successful, either yourself through the university or at the national level in initiating change?
Yeah, I think as you said, I'm in a privileged position, which shouldn't feel privileged in the first place. But anyway, I think first I needed to be better educating myself. And I had this anecdote when I was interviewed for gender disparity survey within my university. And all the replies were, no, I haven't felt that. And at the end of the survey, I was asking, why are you doing this research? The university is so balanced, it's so good. I have experienced that myself. And then the researchers show me the data, the difference in salaries, in the amount of work. And I was like, I was illiterate about my own gender position in the workplace. So I felt the need to educate. So one of the things that I started to do was to educate both men and women. And I ask you that to be please more educated in the data that is actually our data showing the imbalance, not only in gender, but other minorities, minorities of people that is underrepresented in research, and then how we can improve that. So the way I've done is to talk about my experience. I think is the first, to share it. I usually don't talk about myself very much, so it has to be an effort to do that and share it with my students, both men and women, and also to raise up the women issues in every meeting. One of the things that I think has changed a lot is to trying to understand that women, we don't necessarily have to dress in a certain way or speak in a certain tone of voice to be able to be heard, and to respect and make ourselves be respected in our opinions. And if you need to speak loud, I think you have to do it. It doesn't mean that you're aggressive, as that's what usually the society makes us to believe. And I think for me, what is the impact is when I see my students who are pursuing their careers. So for me, that's the big change. And they are able to balance, to find balance in their working and family lives.
Great. Thank you so much. So we're going to move down the line to you, Christiane. What are the main challenges you've seen in promoting gender equity in science in very unequal countries like Brazil and some of the other similar Latin American countries?
Well, the first challenge is that Brazil and other Latin American countries are very, very unequal. And so gender inequalities are deeply entangled with other dimensions of inequalities: income inequalities, class inequalities, racial inequalities, territorial inequalities. And so it's really hard. You have to work with comprehensive policies, public policies, to reduce inequalities, and also to adopt affirmative action in several different areas. Otherwise, girls and women will have less chances to choose what they would like to study and to work with. And because moreover, they are frequently victims of harassment, of domestic violence, of kinds of discrimination, because most of our societies are very patriarchal. And so there are lots of structural inequalities in this way. The second problem is that in science, for example, now we are approaching, in Brazil at least, some equilibrium between women and men in science in what regards the number, the quantitative number. But when it comes to the power positions, men are preeminent. You know, even in institutions that are very progressive, as mine. We know we have a woman as a president for the first time in 120 years of Oswaldo Cruz Foundation. And we have 5 vice presidents, and I'm the only woman, the other 4. So the president is a woman, and have 4 vice presidents who are men, and I'm the woman, the only one who is a woman. And so this is very unequal. We have data on that from the students to the top level. And this happens in politics, this happens in business, this happens in public administration and in our institutions. So we have to articulate comprehensive public policies with institutional policies and pro-equity measures to face these challenges.
Great, thank you. So I think for a lot of people, it's overwhelming. There are just so many problems, and we've talked about systemic problems, we've talked about legal policy problems, we've talked about institutional problems. So what lessons can we draw that are sort of pragmatic that you've learned from your experience at, I'm going to mess up the pronunciation, but Fiocruz?
Fiocruz, that's perfect. In Fiocruz, we have been working with gender equality initiatives. So we have a committee on race and gender equality, pro-equity, gender and race equality committee since 2009. And since our president was elected in 2017, she considered this a priority in her agenda. And so we launched a Women and Girls in Science program in 2019. And this program we have been working in three main lines. The first one is to recognize the women that are the scientists, the women who are scientists at Fiocruz, to promote their work and to make their work visible. And so we have this memory, the institutional memory initiative, which makes videos and tells stories, and we have many initiatives in this way. We have produced a little marketing, okay? A dossier about the program, which has its main initiatives. It's in Portuguese, but I have some postcards here. And so this is a very important line. We have also this, it's an example, I brought some example. This small book is his stories to inspire future scientists. We have 12 stories about Fiocruz scientists in a very logic language, aimed to reach girls. So we work with storytellings, with programs. And so our second line of action is the More Girls in Science program, in which we work with girls in elementary and in high school. So we have some programs to attract girls to know better about science and about the possibilities of the science profession. And we've been working that in all states in which we have Fiocruz units, 11 states. We have Fiocruz institutes in 11 Brazilian states. So we've launched this program, and the researchers are very engaged in promoting initiatives and with schools, with different social organizations. It's really a beautiful program. And the third one is promoting studies about gender and science, equalities, inequalities, and its repercussions on science, and promoting debates in the society. Academic studies about that, and also debates to influence public policies and to exchange experiences with other institutions. That's it.
Great. I love that, because our hypothesis and the work that I lead is that if we can get women into leadership positions, they're going to take care of the rest. And this is a brilliant example of exactly that. So we're going to leave Latin America and go to Asia. My next question is for you, Aliyah. I'm sure some of what Lyda and Christiana is really resonating with you. But I do want us to explore what is similar with Latin America and what is different in your experience in Asia.
I don't know whether it is a good news or bad news. What I just heard from Lydia and Christiane, I see no difference what we see in Bangladesh or in other countries in Asia. So it is, their social inequality is there and the gender inequality is there, but it does not start when a woman is coming to science profession. It starts when a woman is going to an education system. And it is the parents who decide, at least still in our countries, parents decide what the girl should study. Maybe boy has some says, but the girls, not always. And when girls go to university, when they have a chance to choose a science, I think there is some pressure also. And taken, for example, if someone comes to science, they come up with a dream, but dream gets destroyed after their marriage. If the person who she is getting married to or his family, the family he's getting married to, is not supportive about the profession this girl chooses. Even doctors, I have seen the medical doctors and engineers, they left profession. They are doing something else. It is such a waste of the national investment that happens a lot. So what the similarity, like both Latin American countries, I see. So women's voice is not heard. And unfortunately, my experience is that in our societies, it is the women in the families who are supposed to guide them. Their voices are not raised for their girl children. I think so. This is sort of male domination is still there, but I should not say it is picture for everyone. And there are many men in our countries that support the children irrespective of the gender. And these girls come out, and I have seen many girls on their own choice. They really don't take the hardship way. They try to do easy things maybe society also support, you will see very small number of people coming to science, technology, economics, mathematics, right? STEM science. So social science, there are a lot of interest and people go there. So I think this is also not different in other countries. And so I see similarities as in that ways. I don't know what I would say as dissimilarity. I think one of the dissimilarity, I don't know whether it's true, I didn't hear that, but what I see as a general women's status, if I talk about Bangladesh, general women are respected in the society. Maybe in professional world, what they choose, this is a different. And when they grow older, they have more empowerment than they are younger. So the women who actually survive in their professional role for certain ages and that come to a middle age, I think that is the time when they jump, when they fly. And all the women I see in my country, I see those are persistent fighter in the family, in the society. Despite all those negativities, they actually stay in their profession, in their career, even in science or in business, whatever you say. And they really fight against women and men and try to run side by side. So in that sense, I'd say that this is, I don't know if it is true for Latin America, but I see this as a positive notion in Bangladesh society. Thank you.
Yes, I think there's a lot to be said about perseverance, but you have obviously persevered. You've obviously overcome many of these obstacles to be phenomenally successful yourself. You have also done, I think, an incredible job of raising money, which is part of success in research. We have a lot of beautiful young men and women who are starting their careers. So what advice would you give to them? What advice do you wish that you had in addition to perseverance, particularly for the young women researchers who are just starting out?
Beautiful question for me, because even when I was very young, I always wanted to mentor other women, which is not usual. And I would say that I have started my professional journey back in 1994 when I completed medical education. I did not choose any other profession. I directly came to my organization, ICTDRB. That was my first job interview, first appointment, and first job. I never looked back. I really wanted to be a scientist, and I'm so happy I could be. But when I joined the organization, I never could believe I would come to this level ever in my life, because I have seen there is no support. Like, I think it is true for both young men and young women who come to a professional like research organization. So they are sort of told, you need to do this, you need to do that. And I didn't see an environment where I could say, I want to do this, or this is my dream. And it took me about 7 to 10 years just to get my master's degree. So the first advice I would say that for any scientist or in professional research, particularly in research, you really need to have the research training. And you better get this as early as you can. So when joining an organization, any research organization, I'm talking about science. So it is difficult for her to choose which team she should work. But when there is a chance, this young lady should choose a team where there is a mentor who actually encourages career development of the juniors and create an opportunity to take a leadership role. This is very important. And what a lot of people think in the society, even in our society, that maybe a female mentor actually promotes a female better, a male mentor does not. But in my reality, I really didn't see any difference. So it is actually the person who chooses. It is difficult, but this is really important who you are choosing to work with, because that person will not guide you, but create an opportunity, which as a young person, it is very difficult to create. And the second thing, I see a lot of young people, either out of frustration or out of work pressure or out of not meeting their dreams, they leave the research organization or job. But research is such a job that you cannot get benefit in just a few months or few years. It is a lifelong approach. So perseverance in sticking to the career is also important. So I would encourage you who are in the early career stage, don't leave your job in the middle because you miss the opportunity to learn the research cycle. A research from generating a grant up to publishing a paper or translating into policy. This is a huge pathway and it doesn't happen in a year or two. It takes time. So I would highly encourage wherever your stage of professional career is, stick to the process so that you learn. And research is such a thing. You have to do research to learn research. So there's no other way. Doesn't matter how many degrees you may have. That is the other thing I should say professionally. And so getting education is very important. But other than education, what I would say that when someone gets a education, MPH, and then there are a lot of women who think, okay, if I get an opportunity to get a grant, I will get it, or I will work with other people. If I'm given opportunity to write a paper, I will write that. We have to come out of this. You have to drive yourself and push yourself to motivate other people that, yes, I want to write a grant. I want to write a paper. I want to do analysis. A lot of people cannot dare to do that because they don't have the skill. Again, the training comes into play. If you train yourself enough with study methodology, analytical analytics, you will be empowered to do research. So that is the first point. Educate yourself, and trust me, nobody drove me to go for education. Nobody told me that you need to get training. I found it out after 7 years that it is a waste. I did not get training to do my job. Then I had to fight for it. But when you do that, you come to a middle-aged career. So this is my second advice for all of you. Middle-aged career, you're coming to a leadership role. Don't just try to be a team member or be a leader. And try to do things that you can lead, and let other people to support you. But being a leader, a lot of people think it is bossing, which is not bossing. You have to share responsibility with others so that you can mentor your teams and your colleagues. And you have to be very open, reaching out to successful people, either successful male scientists or female scientists. Try to work with them, try to create an association with them, learn from them. Because if you just have a cup of tea or have some social interaction, you will learn from them. Just from hear the story, what they say, they will give you a lot of tips. And that will help you to decide what you can do. And second thing, I mean, in a mid-level career researcher, when you lead a research, you will, in any organization, you will be faced with a lot of challenges. So in order to mitigate that, I think the role is family. The third advice I would say, that never ever neglect your family and your own thing, because if your family environment is not in harmony, you have to take an extra pressure in my mind, and you cannot give your full potential at your work. So having a wonderful, harmonious relationship in the family is very important. But family is not, it can be parents, it can be a husband, it can be children. But there's another family, that is friends. What we don't do is we don't take care of ourselves, and we totally forget our friends, our society. We just go to work and come back and quickly to take care of our kitchen, take care of our children. I know this is tough, but at the same time, you have to give yourself time so that you go out, meet with social people, meet with friends, meet with extended families. The reason is, when you are in hardship in your professional work, these are the people, buddy, who will stand by yourself, and they will support you, be psychological support. That is very important. But one thing I should, as an advice, please never ever share your failures with, or your frustration, not either with family or with your team members. It is difficult. Share those with somebody who will not impact, because when you talk your negative things in your professional career, in your organization, in your family, they will think, oh, leave the job. You shouldn't do it. So that negativity will be coming in. So you have to be strategic where you express your emotion, where you will not be pressurized negatively to leave your professional career. So these are three advice I would say.
Thank you. And I will add a fourth to that. Now you have this community of practice for women and global health researchers. And I think it's probably fair to say, at least I know when I was coming up, we didn't have the benefit of the internet, and we didn't have access to these mentors, these inspirational women, and places where we could have these conversations. So yet another reason to join that community. So now we're going to go to Africa. And talk to Alice. You've been working as a professor as well as a researcher. You've worked across the continent, Pan-Africanist, can I say, a Pan-Africanist? And most recently, as you mentioned, you have founded many schools in AMREF International University. I'm excited about the university, but I also have, I guess, a tough question for you, which is why? We have so many institutions on the continent. Many of them are gasping for resources. So why, instead of bolstering the institutions that exist, why start a whole new university?
Well, thank you. Thank you for that difficult question. But I want to say that AMREF has been in Africa for the last 60 plus years, implementing primary healthcare. And for those years, AMREF has learned so many things. They have learned that for you to really impact on communities, you really have to really focus on primary healthcare. And what we have seen is very few universities focus on primary healthcare. A lot of universities focus on producing graduates who are waiting to work in a perfect world, which is not actually the situation. But more importantly, if you look at the statistics, in Africa, one of the concerns that the world is concerned is the demographic change that we are facing. Africa population is a major concern. So we are going to have so many young people who require education in Africa. Even though it looks like there are so many universities, just look at the UNESCO statistics and you compare the number of universities in Africa versus the population is around, if I was referring to looking at the UNESCO statistics, it's talking about around 500 universities to 660 million African youth. While in the US alone, we have 5,000 universities for 323 million. Meaning, if we don't address the young people and give them the skills in Africa, then we are not going to solve the problems of health. Another important area is our university is only focused on primary healthcare. And we recognize from our experience of 65 years plus that only if you have a fit for purpose leader, we will not attain lasting health change. That is why we are in this space to contribute towards that. We also want to learn. We have a privilege of being in 35 countries and knowing the health systems of those countries. So we are bringing all that experience to develop a Pan-African university that is producing graduates that can work across borders. And we see this as an opportunity to learn, invent, and just like young people who really want to be listened, as a university, we are saying there is an opportunity for us to learn from mistakes and strengths of public universities and also other private universities and work with them, with many organizations.
It is so true. I take it back. We need more universities. So, I mean, one thing we know, and I think it's true even more so in African universities, women researchers are even less successful than their male counterparts in attracting funding. Is that something that you're going to be able to solve for under the rubric of AMREF University or in your own experience working in collaboration with other institutions across the continent?
Thank you. Let me say that as we are launching this, our university is launching its first strategy. It's just been going on. We are launching our strategy that is 2022 to 2027. And we are focusing on key strategic areas. The first one is we want to develop fit-for-purpose leaders for primary healthcare systems in Africa. What we are saying fit for purpose is we want to ensure that we develop a graduate using the experience of the 35 countries who is able to work across the region. Because COVID has even taught us that diseases have no borders, and Africa remains, if it is not attended to, is a threat to the global health security. The other thing we are doing is we are looking at equity to access in education. We know that, and my colleagues have spoken about this, if you look at accessing health science training in Africa, you need to have gone to a good school, you need to have gotten good grades to be able to be a doctor and nurse. That is not happening everywhere. So you are talking about, we have a population that despite the many health workers that are trained in universities, we shall never solve the shortage of health workers because I will be trained, but I'll not be willing to work in some of the hard to reach areas in Kenya. I will work only for some time, then I'll go back. So we'll continue to have challenges in those areas. So we are building a scholarship fund to be able to target girls and communities that cannot access health sciences training so that we can solve the problem of human resources for health in those communities. We are actually starting with a program of nurses in South Sudan and Malawi. And we have been partnering. For example, in Kenya, we have partnered with some of the counties that also have shortage of human resources for health. And we have convinced county governments that you can actually sponsor people to study in our university and you take them back to work in your county because we shall always continue to have that challenge. So therefore, as a University of Health Sciences, we hope to grow researchers that are going and women researchers that are going to really impact on primary healthcare. The other thing that we also want to be able to do, and we have learned this from COVID. For example, when COVID came, Africa took up the measures that the world was taking, lockdown. I happen to come from a community in Kenya that is nomadic. Our governments took up these policies of lockdown. So how do you lock down a nomadic community? Because we are taking research from and recommendations from the world and we are saying lockdown. So we want to be able to drive evidence for primary healthcare that are appropriate for our setting. And that is the space that our university wants to work with you and all these partners here. Thank you.
Great, thank you so much for that. Yeah. Thank you, Tumbi. Now you know how it feels, right? For the rest of us, most of the time we are presenting in rooms and there are not that many women. So we'll try not to beat up on you too much. My question for you is, you're a researcher, you're a professor. You've been very passionate about the next generation and preparing the next generation of researchers. You're also often in rooms where women are not present. I assume, I know. So what are you doing that you found effective to promote women within your immediate sphere of influence? And since it's a related question, I'll ask you the second question. You know, you have been a gender champion, and what are some of the things you have seen that have worked to convert those who are probably not as enlightened as yourself? Some folks are gender blind. Some folks are gender hesitant, and some are just obstructionist. So tell us about your experiences of what's happening in the room when we are not there.
I'm sure everybody in the room feels sorry for me. But I think it's a difficult question. But the first thing I would say is that if I'm in a room where women are not present at the table, I think that's problematic right from the get-go. Because I think the best advocates for women issues, the most articulate advocates for women issues are women themselves. So we have created a very difficult situation, I think, in the world where traditionally it has been men who have actually sat at the decision-making table, and we definitely need to change that. And until we change that, I don't think we will adequately address women's issues. Because for me as a man, even though I may have good intentions, it's not enough. And actually, one of the things that I've realized in my career is that good intentions are never enough. Never trust people saying we have good intentions to change things and bring women to the table until you see a specific plan and a formalized process. So if people are saying we are looking for women, but to take up certain positions and can't get them, ask them for the specific plan to address that particular challenge. Don't just trust that there is going to be some kind of magical process that will work and bring women to the table of influence. So I think we need to change that, and we need to have very specific programs and specific goals to ensure that women are at the decision-making table, because only when women are making decisions are we going to actually change things. And then the other thing that I would like to point out is the issue of resources. Is putting resources behind what we are saying. It's all good to, again, have all these plans. But if, for example, you're working in an institution and there is no funding dedicated to addressing the issue of gender inequity, things are not going to change, even when the plans are there. They're going to sit there, but they're not going to be implemented. But if you put real resources and say, we're going to spend so much money, for example, to promote young women researchers, and this money is going to be ring-fenced for young women researchers, then I think we begin to shift and you begin to see a change. And so, just to be very specific, some of the things that we have done, for example, in the Sub-Saharan African Network for TB and HIV Research Excellence, SANTE, was that we realized that a lot of women, for example, could not participate in scientific conferences, sometimes because they have young babies, young children. And if you have a 6-month-old baby, you find it very difficult to go to a meeting in Nairobi. What are you going to do? And some of these are postdoctoral researchers or PhD students, so they don't have a lot of resources. So one of the things that we did to address that was to set aside some money for diversity, what you call diversity and inclusivity. And what we did with that money is to actually support a family member. It could be, for example, a husband or a mother or a father, to accompany that trainee, so that they can go to Nairobi with a baby and have somebody take care of that baby, so that the baby can be breastfed during that meeting, but also the trainee is able to participate in the meeting. Another initiative that we did was, for example, we realized that postdoctoral research phase is very sensitive, because that's when you develop your career, and that's when you begin to get a name for yourself and establish yourself as an independent investigator. And we realized that when women take maternity leave, for example, they lose a lot of time and they cannot catch up with their male counterparts. So again, one of the practical things that we did was to set aside money to hire a technician 3 months before the postdoctoral fellow goes on maternity leave. And this allowed the work to continue even when this trainee or postdoctoral fellow went on maternity leave. So again, a very practical thing, and the kind of feedback that we have gotten is very positive on these issues. Just to very quickly add that these problems are systemic. They are very deeply rooted. They are cultural, and we really need to be very sensitive and educate ourselves and sensitize ourselves, all of us, both men and women, because actually one of the challenges that I've noticed also is that it is not just, sometimes we talk about women and the problem of young children, and you think that's only where the problem is, but actually it's even the other way around. Sometimes we discriminate against women scientists who have chosen not to have a baby. So women are stigmatized when they go out for maternity leave and have a baby, and there are cultural expectations that they will have a baby. So when they don't have a baby and they are scientists, we also stigmatize them and say, why is this person not getting a baby? Is it because you're just so much dedicated to your work? So there's a lot of these cultural pressures on women that we need to educate ourselves to help ourselves to get rid of these stereotypes of what women should be and let women be.
Absolutely. I think in the US, they say damned if you do and damned if you don't. And that's kind of how it feels for a lot of women. So we're going to round out this series of questions with you, Catherine. We're going to go global since you're at WHO. You're the head of global ethics and governance. Please, can you explain to us why ethics and governance matters for research and how gender is intertwined into your work?
Okay, I really like this question because normally when you discuss ethics around research, people focus primarily and only on research ethics committees, which are critically important. And actually in terms of gender issues, one of the ongoing problems we have seen in COVID, I have responsibility for WHO's Headquarters Ethics Review Committee. I have also recently held a meeting with 30 Ethics Review Committee leaders around the globe. And one of the outstanding issues that's still happening in research during COVID was the systematic exclusion of pregnant women and lactating women from research, even though all the guidance is heading towards a presumption of inclusion, not exclusion. So we have a translation dilemma, which takes me to the bigger issue about ethics. And I'll go back to COVID because I've been buried in COVID for the last 2.5 years. If you look at COVID and the language that's used, what do you have? Solidarity, equity, access, inclusion, exclusion, vulnerability, lack of access, transparency, exclusion, vulnerability. Vulnerability is a double-edged sword. That's all ethics language. That's all ethics values, ethics challenges. Have we succeeded in all those challenges? Clearly not. Vasi Modi, my colleague, yesterday stated COVAX, I think was the stat, 3%, I think, uptake in some countries of vaccines. They were only able to get 3% out. We've clearly failed. Ethics matters because we're not heading in the right direction in terms of global health justice. It matters because inclusion is an ethical issue. I think on the back of what my colleagues have said, I've really enjoyed the honesty of the discussions, and I have a lot of empathy with the being a mum guilt and work. What do we at WHO need to do about this? So we produce normative guidance. I think that normative guidance is critically important. A lot of our power is soft power. It's only things like the IHR where we have hard power. But the development of that guidance is critical. The inclusion of gender, of cultural diversity, of different types of expertise. That's really important in our guidance development. And that, I think, which we've heard a lot over, including end users early in the process, will mean you'll get better outcomes. And the same has to exist for WHO's guidance. And that's the kind of thinking we're doing in the ethics space with our ethics guidance. How do we embed ethics early in the process? How do we embed values in our guidance documents? But most importantly, I think in terms of gender and ethics, what are we doing in terms of implementation? How are we implementing these policies? So the example I just gave you of the exclusion, even though we know that there's a presumption in favor of inclusion now, what are we going to do about that? Well, we're going to take a leaf out of some of the Global Health Network and some of the initiatives that have already been mentioned. We're going to do some train the trainers. We have to train researchers as well. This is not just about ethics review committees. So I think working together with our regional and our country colleagues, as well as we've got 13 WHO ethics collaborating centers, including one here in Stellenbosch. And I think really focusing on implementation. And for me, thinking about my responsibility for gender inclusion, my responsibility to stop that exclusion. What can I do in my position? And I would challenge all of you as researchers, all of you in this community, we all have a responsibility to be able to stop that type of exclusion. And I'll stop there.
Fantastic, thank you. So this has been such a wonderful and engaged audience. And so I'm going to say a few things and then hand it over to the audience to ask questions. But also, I think it was such a wonderful opportunity. And thank you, Trudy, for this panel, which is quite different, not just at this. I go to a lot of conferences, as you can imagine. And we don't really have a lot of opportunities to have these kinds of candid conversations. And we need much more of that. So just in conclusion of some of the things that I've heard, there's a lot of work to be done for sure. We need to empower individual women. We need to change organizations so that we can present as our authentic self, be that mother, somebody looking after parents, somebody who is a person of color, somebody who identifies as a different gender, whatever it is, however you want to present should be not just fine, but embraced. And that's the organization that we want to work for. The reality is there's a lot of advocacy that needs to be done to change societies. Sometimes you need to force the issue, and that's through law or policy. Quotas, personally, I'm a big fan of, I think somebody mentioned affirmative action and quotas. People squawk when you say that, but the reality is it has never been a level playing field. And so oftentimes I think it's appropriate and fair to help level it out a little bit more. So with that, I just want to open it up. I know people are running out of gas or fuel, as we say. I feel like I'm bilingual. Sometimes I speak American and sometimes I speak English, proper English. So yes, just want to open it up and okay, we'll start in the front here. So 1, 2, 3 women in the middle, please come forward so that we can hear your questions clearly. And if you want to direct it at somebody, please do so. Okay, sorry, we have 2 microphones. We'll start with, I think you had yours first and then you go second.
Thank you very much. My name is Donna from AMREF, Health Africa. Of course, I work with Dr. Lakati, but my question is to Catherine. And you've talked about policies and laws and the importance of that. And my question is, what would you want advocates, the key messages you would want advocates to use to promote, research in science and in health? What are the messages you need us to use so that we promote and ensure that the laws and policies are implemented?
It's a great question. And thinking about this earlier in sense of some of what we've heard today, I think implementation has to be both top down and bottom up. So I was really interested in the Women in Data Science initiative. I think we need to harness the networks that are out there. And I'm looking at Trudy because the new network, I thought to myself when that was announced, that is something that I could harness for help with implementation in policy making. So that would be one level. I think the bottom up is really important because this is a systemic cultural issue. So for policy implementation, I would start definitely with the network approach. And then, as I said, because we're a member state organization, we'll work with our regional colleagues and our local country officers. One of the pieces of work we're looking at the moment is implementation of the human genome editing guidance. And we're working with the Uganda country office, and we'll work with the ministry. So I think it has to be an approach of bottom down and top. Bottom down, yeah, and top down and bottom up. That would be right, wouldn't it? That's the word. It's a long day, and I was the last speaker. Could have been worse. So yeah, but I definitely think harnessing pre-existing networks will be critical for implementation of our policies. And I will be looking to Global Health Network, and I'd be looking to some of the colleagues on the table to help with the policy implementation.
Thank you. Go ahead. Thank you for a wonderful session. I'm sure it was eye-opening for others. My question is, it's actually a question combined with a comment, especially for the organizations which are normally putting out calls for research fellowships. There's something called, I don't know if it is there yet, but some people experience it, like age discrimination that normally would affect women, whereby a call will be put out and an age limit will be put there. And you have a woman who has just maybe, she was feeling she was having mother guilt, so she decided to take care of the children. Now she's ready to come back. But now when she looks for opportunities, all of them are saying under 40 or under 45 or under 35. So where is she supposed to get the same opportunities? Does it mean it's the end for her? And what can you do about it? Can you be the people who are championing for others to see that you're not actually putting limits, but you're actually only considering the capability of the woman? And my second question is, what should be done in the cases where, so I don't know if this is only in specific areas or in Africa, where you find young women, the people who push them down more are not necessarily men, but women who have reached, women who are at positions of power. They are the ones who put down other young women because they feel these women have maybe too many opportunities and they're not working hard enough, or they are the ones who will tell you, no, you can't do this. So what are some of the things we can do to be able to change this? It can be a mental attitude, or maybe they don't even realize they're doing it. Thank you.
So perhaps, Christiana, you want to take the first one, and Lida, and then perhaps you and Alice as well, given the Africa nature of the question. So we'll have the first four panelists respond. Really great questions. Thank you.
Well, that was a really important question about what kind of action can we take. We have already talked about regulatory measures, financing, and we shall have affirmative action in different ways to avoid discrimination and to promote more diversity. We are worried about this in my institution, for example. We are trying to adopt some criteria to convince people that they have to include diverse criteria in selecting people and promoting this. We are worried about this, even when we are selecting girls through scholarships. So we have some programs that we are trying to adopt different criteria to select girls in the community, girls from poor communities to engage in this project. So we are adopting this kind of criteria. And another important issue is that we have to talk about that with all people, inside and outside the institution. We have to talk in the schools. When we have these programs to bring girls, the more Girls in Science program, and to show how science is and to engage them in our scholarships and so on and so forth, They want to talk about everything, about every kind of difficulties that they are facing in the families, in the communities. And it's important to talk about everything because they have many obstacles, especially very poor girls, in the case of Brazil, Black girls from peripheral areas, from poor areas, because Brazil is a very unequal country, and Black girls and Black women have a lot of difficulty. So we have to talk about this, and we have to include these affirmative actions in our policies and initiatives and strategies, and to talk about that with people, because people sometimes doesn't notice that they are committing injustices, even in selection process and so on and so forth. And even in my institution, sometimes I see there is this panel with 7 white men. I call the person, how do you manage to organize a panel with 7 white men? That's absurd. We can do this and put there our symbol, our name. So we have to talk about this and to problematize this kind of issue. And that's for now, and I will keep here.
Thanks for the question of the calls for fellowship and scholarships, because this is a very easy way to make a change. And I think it has been now more current in calls that the issue of gender is being addressed. So there are like 2 indicators that I usually look after when there is a call for fellowships or scholarships. First is the amount of women that apply, and the other with respect to men. And the other is the proportion of those that apply that are successful. So usually the biggest gap is in the applications. So there is less women who apply. There is a gap also in the successful rate, but this is usually lower than the applications. So one of the reasons we explain it very well is the age limit. And for that, usually the modification is to increase the age limit. And I witnessed that has been done in the calls at the Ministry of Science and Technology, for example. The calls are usually had increased the age from 30 to 35 or even in the 40s. And I have seen that also in TDR calls that I've been part of, some of the committees. And the other strategy that was used and was part of that was to mentor women through the application process. So we have a list, at least this was in TDR, a list of women, usually women to mentor women. We offered to mentor women who wanted to apply. And there was a link in the application webpage that women who wanted to apply could ask for some mentoring and guidance in how to write the essay or put up their CV, etc. And I have been part of that. So not always successful, but it has been a good process that to give usually is the confidence to do it and have some experience in how they can be more visible successful during the application process. I think the success rate comes very much to the training, and the training has been affected also for the some of the issues that were discussed earlier during the panel. So for that, we need to have better ways that women we can be trained and be trained while we are with the family. So because at the end of the day, what it's been assessed, the criteria are the same. I'm not expecting that we have different criteria. I don't think that's what we want. We don't want different criteria for selection, but we want the opportunities to have the same CV. So we need to improve that capability to be trained and keep up with their CVs while we are, for example, in maternity leave or have care for others as well.
Great, thank you. We're running out of time, so I'm going to ask all the panelists to weigh in because it's such a great, important, relevant, real question. Have everybody weigh in and please kindly make it brief because I think there's 1 or 2 more things still on the agenda before we wrap up this fabulous, fabulous convening. Go ahead, Aliyah.
Yeah, it's me, Aliyah.
Yes, Aliyah, just we're gonna go through, everybody's gonna answer the same question very briefly.
Can I go?
Okay, go ahead, go ahead.
There goes the man again. What I wanted to address is that the issue of the women suppressing women, if I may put it that way. I think personally, I see it as a cultural issue and systemic issue. That's why I was saying that I think if you come from a patriarchal society, as most of us do, you have this even unconscious bias that you might have some unconscious bias against women. And so it has to be a very intentional process to actually support and empower women. And this affects both men and women. And this is what makes women empowerment so difficult. And therefore we have to constantly dissuade ourselves of this idea and this concept that is so culturally ingrained, sometimes even in our unconscious, that women somehow cannot do certain things, because we have to support women. And we have to realize that this kind of bias comes both from men and women, and we have to fight against it. That's what I wanted to comment.
Very, very quickly, everybody else, please weigh into both. There were two really good questions, so you can weigh into either.
Thank you very much for raising that question, and I'm glad that we are having this conversation, because the challenge of those cutoffs are actually worse for African countries, because if you look at our education system, you finish medical school sometimes even at 25 years or 26 years. So by the time you start your career, it's really late, and therefore that really disadvantages women from sub-Saharan African countries. And I'm glad that the panelists are thinking about this. And my thoughts are, it's true, we have had situations whereby women put down women, but I look at that there is light at the end of the tunnel, because at the moment we have more women also supporting women. I see in my organization, we have even formed a network of women to discuss women progression in careers. So we have an opportunity to come together and address some of these things that my colleague actually is saying. They are cultural, because sometimes older women feel like, maybe depending on their experience, and sometimes it's unconscious, but I think there is an opportunity, and the fact that we are discussing this is really an important thing for us to move forward. Thank you.
Although we are blaming the culture, I had the opportunity to work with many people as my mentor who were coming from different culture, different nationalities. And I have seen this in my career and other careers, that there is a tendency not to support women. It can be women, but not always women. It can be men as well. And I personally don't think it is women trying to suppress women. I think it is true for both men and women, young people who are developing their career. When you become a very good team member, a boss really wants to keep you there. And if you try to get promoted to something else, this is a loss of investment on their part. I'm telling you this is the reason for this barrier, this ceiling. And when it's what you do, you can do two things. I think everybody has to face the situation in such certain magnitude at any time of the career. I think the first thing would be have a dialogue, open discussion. The best thing you need to talk about your expectation, your dream, your career. That men do that a lot, because men have boys club. These boys talk to boys and they are empowered and they share everything. Girls don't do that, unfortunately. Not in my society. I don't think any society, girls have a girls club where they share everything. I think this is important to have a dialogue, understand what are their expectation and what is your expectation. And if it doesn't meet the same pathway, just choose a different pathway and say it honestly. Being honest, open, and show them you have a dream and you want to follow that. So there is no magic bullet to solve everything. It depends on individuals' personality characteristics. But as a woman, I would say from my experience, they are always hesitant to talk about their need, to talk about themselves. So you have to come out of this period, of this cocoon, and you have to talk to them. And never ever give up your dreams. Follow your dreams, believe in yourself. You have extreme power that you can make a change, because you have to dream, because dream comes true. So never be disheartened. This will be a situation every time in your life, either a junior, mid-level, or senior. We also face the same thing in our state of career, right? So this is a challenge. The more you crack this challenge, the stronger you become. So take it as an advantage. Thank you.
Thank you. Thank you, everyone. I think we're going to end on that very inspirational note. Sorry we didn't have more time, but if she had a hook, she would have pulled us off. So
I was sitting there being a little bit female, thinking, dare I get up?
No, thank you, everybody. Thank you to this wonderful, wonderful panel for your honest conversation. Thank you. Bye.
So thank you, panel. It's I think we should put a vote in for a whole conference on this, don't you think? I mean, we should have talked, we could have spoken for a whole day. So thank you. What an amazing panel. And a round of applause for our token man. You did brilliantly. So thanks very much. That was absolutely fantastic. So we're doing it. We'll wrap up really quickly, but we've got some special people to bring up now. We're just in a quick swap round. I'm going to sit down here so we're all equitable. Alia and Christiani, we'll sort, and we need Elvis, and then you all know who's coming up now, so we'll just swap over. Here. Come on, everybody's got a piece of paper. Hurry up on stage and then we'll move on. I'm just going to take a moment and then hand to my global colleagues to conclude this meeting. Look at this lot, isn't that lovely? So, and they're going to be closing the meeting. My main job is to say a few really important thank yous. Firstly, thank you to everybody, all of us. Thank you for traveling so far. There's been some epic journeys, but thank you all for your participation. I mean, it's just been such a really participatory event, which has been the whole point. I really need to thank the University of Cape Town team for looking after us so well. So I'm not sure they're in the room, but we'll pass it on, but this is recorded so we can show. So please thank the Cape Town University team. But I thought you all want to thank, can the Global Health Network team please stand up? They've all been, look, they've worked flat out. Stand up, come on, stand up. You are legends, all of you, and it's a total team effort. Thank you so much for your hard work, and they're all going to want a week off now and to sleep. I also need to thank the sponsors. This conference, over half of us in the room have been fully supported in attending, and I think that's probably quite unusual. And we've all benefited from that because we've valued everybody's participation. And so thank you, sponsors. It's been remarkable to have the colleagues and new friends we've got with us. So thank you, sponsors. There's going to be some really important outcomes from this conference. This isn't a one-off. I mean, you know, this has been a process of trying to, this is like the Global Health Network Live, somebody said, I like that, the Global Health Network Roadshow. But we're going to be writing up the PLOS papers to capture all the recommendations. Please share anything you want to from anything that's presented or anything that you've got, you can share on the platform. And of course, we've all made amazing connections. I've heard about so many, I'm sure you all have. We've made new connections and friends, so keep those going. Thank you for that. And so lastly, over to my wonderful colleagues who are going to close the meeting, but thank you, everyone.
Thank you very much, Trudy. First of all, I would like to say I feel honored to have been here this week to participate in this very well-organized and well-spoken meeting. And I'd like to seize the opportunity to clap for everyone who made this possible. So I would say that the Global Health Network was born in Africa, as we all know. It's been around for a while. It's been to places, but now in Africa, it has grown to become a teenager. And we know that when you become a teenager, there are certain responsibilities that you have to take for yourself. So at the end of this conference, we have the birth of the Global Health Network Africa, which means that leadership, coordination, and definition of the way forward in a coordinated manner has to come from the Global Health Network Africa. This does not mean that we are going to reinvent the wheel. It simply means that we are going to do it in a way that is fit for purpose and addresses the needs of our local communities. I think this has come up so many times, and we are glad that in the room, we've got so many people who are going to support us in this journey. And we will do that in leveraging existing networks, because I mean, we've seen so much work that's already ongoing. And then the second part about being a teenager is that you get the opportunity to go out there and talk to your peers. I think in the previous discussions, it was said that boys have the opportunity to talk to their other friends, to learn lessons from them. And we are glad that at the time that the Global Health Network Africa is being born, peer networks of Asia and Latin America are being born. So we really want to talk to each other, learn from each other, share experiences, and move forward. So that by the time we are celebrating out of teenage age, we should not be talking about how many papers or how many data sets we've exchanged, but we should be talking about how much impact we have driven in public health on our different continents and in the world as a whole. And we'd like to thank the funders who has been supporting us so far. It is always said that behind every grateful person is a sacred wish for more services. So we are thanking you because we'll be coming to knock your doors for more funding. Thank you very much and have a nice travel back.
We were looking for champions. When I met Turi 4 years back, Turi came to me and said in a meeting, Ali, I'm looking for you. And I was surprised. Why is she looking for me? She doesn't know me. And she told that I'm looking for someone like you who can do things. And that was the beginning of a dream that to put leadership in global health in a global manner everywhere in the world. And now we are having a conference where we are launching the Global Health Network Africa, the Global Health Network Asia, the Global Health Network Latin America and Caribbean. So the Global Health Network has gone global, finally. So this is a dream that is coming true. And this conference is just the beginning of the journey. And it is a tremendous idea, wonderful idea to announce this journey through this conference. And there is a trick in it. This journey cannot be started without our partners, our other researchers. And we wanted to bring everyone under this umbrella to share what we really want to do, all these 3 regional centers. But without your support, your participation, all these wonderful plans will not work out. So those who came to this meeting without being a presenter, without having been a scholarship, and those also who had come all the way down with all the hardship and also got some scholarship. I really applaud you that you made this conference successful. So it's a big applause for all the participants sitting in the hall and who already left. You made it successful. But this day did not come in a magical way just over one night. We have been working for this for the last 2-3 years. We are doing tremendous job. There are small teams behind all of us, all the regional center. There's a big team. Some of them you see on the backside, some of them you see out there. And it is the hard work, day and night, relentless effort of those people who supported our team. So rather, I've been thanking Trudy. I think Trudy and I convey the heartiest gratitude to all of you who are the workforce of the Global Health Network, all this region and the UK, who made this conference to happen and made it a successful one over the 3 days event. So a big applaud, I would request to give all these people who work behind this screen. Just with last word, this journey started with a dream. I want to repeat what I just said a few minutes ago. We are dreaming of a federated leadership world, and we were looking for champion, I told you. And everyone's present here is a champion. You are a leader. When you go back, you take efforts, you drive your own innovation, your own work, and we, the regional centers, are here to support you. So please join us and knock at us without any shame. Thank you very much.
These were amazing 2 days, and for some 4 days of very, very intense work, because we had lots of pre-conference activities as well. And so this conference was very dense, very intense, and very, exciting. We are leaving with lots of ideas, a lot of inspiration to go on, to move forward. And so I would like to reinforce and thank very much all the group that was involved in the organization of this conference, the Global Health Network team, and the University of Cape Town team was involved in this organization, and also who welcomed us so warmly. I would like to thank as well the scientific committee. This conference was opened by a member, the head of the scientific committee, and their role was very important. And also to thank all of you, all the delegates, all the speakers, all the people who made this such an interesting event. In what regards the Global Health Network, we are very, very proud and happy to be launching the 3 Global South networks. As my colleagues have said, the Global Health Network Africa, the Global Health Network Asia, and the Global Health Network Latin America. And it's very significant to us that it's being made here in Africa. And I'm the last one to speak. And I thank you, all my colleagues. We from Fiocruz are very, very excited about working with our Latin American partners and also with our Asian and African partners in the next year. So we have several different networks in the Global South working together and exchanging ideas, experience, and dreams. And so I'm the last one to speak because I'm supposed to announce that the Global Health Network Conference in 2 years, I mean in 2024, will be in Latin America. So we hope to be funded and to invite people and to have you all there and many other friends and colleagues with us. There is a very healthy competition about the exact place. But I can ensure that it would be a warm and interesting place and that people will be with their arms opened to receive all of you. And so we will be together again from now to then. We will work a lot and we will work a lot and exchange experiences and build new perspectives to research capacity building in the Global South. Thank you very much. And some claps from our colleagues who are here standing. What a wonderful group. So many different countries represented here. Thank you very much. Yeah.
Oeps. I pensa în clar,
What's this got my feed? Huh? It's got my feed. I in the meeting or must I leave the meeting? I'm a co-host. And I can in the meeting.
I'll just leave. Your co-host can leave.
And the recording's still gonna once they close the meeting. Do they have the power to close it? What are they? Yes, please. Thank you, bro. The cable that was in here. That's a long cable running also. That's tough. It's but I don't know, there's people in the way now. Yeah. When are they leaving now? Hi, I'm host, my bro, Ethan. Huh?